Thank you very much.
Thank you very much, sir, for your thoughtful and enriching introductory remarks.
अब हम डायस पर आमंत्रित करना चाहेंगे बिहार स्वास्थ्य सुरक्षा समिति के सीईओ श्री शशांक शेखर सिन्हा IAS. A big round, ladies and gentlemen, kindly join me in welcoming him to the stage with your applause.
Now, moving forward to our session, we now have the privilege of welcoming Professor Brigadier Dr. Raju Agarwal, sir, Director of AIIMS, Patna, to deliver the introductory address. Sir, a retired senior surgeon from the armed forces with decades of academic excellence, lead the clinical services. Sir, please.
Good morning, dignitaries sitting on the dais and in the audience. When they approached AIIMS Patna for being an academic partner, they emailed and they never expected a response. So they were quite surprised when the appointment was within 24 hours. So that is, we want to, of course, be part of these activities. And where is this slide? Yeah. So I think all we are aware of digital so technology for long has been, it is nothing new. It is only an adaptation of the technology in health sector, which also is not new. The concept has been for quite some time. Only thing, after this pandemic, we have realized the potential of digital health. It is just the realization that what it can achieve. So automation, we know, like Dr. Binde was saying, when he introduced automation, there was a lot of hue and cry from manual to automated system. But yes, any change will bring a disturbance for some time, but if it is a good and a robust tested system, definitely the benefits are long term. So we find that hospital, whenever we have this automation of hospital information management system, our workflows are quite smooth. We don't have, there is a queue management, we don't have congestion. There is a continuity of care. And with digitalized health, national health mission, the digitalization has been an approach to remotest of the area who are deprived of the health care. So accessibility and equity of the health care is given to the person who is far away from a center of excellence. Then policy making. Science has the answers, but the policy has to ask the right question. And for policy to ask the right question, they have to have data. They have to analyze and interpret that data. So once you have the data, and then you interpret, and then you can really put the question. You can frame the question to the population which is being served or affected because of a large geographical area like our country. The problems may be different in different areas. So once you ask the right question, science will come out with the right answers. Answers are always available with the science. We, of course, are, I can say quite a bit, we are following all our hospital information management system. We are towards digitalization, and also now we are moving forward. It is a continuous process. So as our workplace people get adjusted to a particular technology, and when we find there are edges have smoothened out, and then we move on to the next. So shortly what we will have is with CDAC we have a capacity building center for AI in healthcare, and about 16 medical colleges will be our ambit, where in a batch of 30 we will be teaching them or making them aware of AI in healthcare. So we have taken that initiative to train a lot of people in how this can help digitalization AI in our healthcare system. Of course, we are with the government priorities, Ayushman Bharat Digital Mission. We are, of course, leading. When I met Mr. Shashank also the other day, he was mentioning that AIIMS Patna is probably the best in Ayushman Bharat scheme. So I was very happy to hear that, and our hospital administrators are continuously, we are very, very proactive in this Ayushman Bharat mission. And of course with state authorities, whatever we can contribute towards the health of the state, we are always there. And like we have with ADRI we have, so we are looking forward to global agencies for being partners and for bringing out the health solutions. Now this gathering, we have so many experts, academia, industry, and public health. So this is a forum where we can really deliberate, and all are experts in their field who have the experience with their lived experiences, I can say on-ground experiences, which can come with certain innovations how to solve problems. It may not be a straightforward solution in our country where you have to go for something out of the box solutions. So we can share evidence, we can share innovations, and in AIIMS Patna recently, some of you may be aware that we have Incubation and Innovation Center from Department of Science and Technology, where we are encouraging, now it is fully established, we are encouraging everyone, our undergraduates, our nurses, our doctors, to come up with the innovations, and they will be through that Incubation and Innovation Center, we'll take it forward, a collaboration with industry. And because most of the time doctors know the solutions while they are working on ground, but they don't know how to move forward, how to move ahead in innovations. They have the ideas. So I think this will, it is just few months, and it will go a long way in medical innovations. Bihar as a state, because of its large populace, healthcare accessibility is not that good compared to certain states. So digitalization will be a solution to a lot of problems in this state, in maternal and child health, surveillance outbreaks, and rural health access. So once we adopt, there are challenges in digital adaptation of digital, because it requires good amount of capital, resources, training, connectivity. So these challenges will all be there in remote areas, but however we see how to overcome those challenges and move forward. We are also in the process of now, in the sense we are with international universities who are leaders. We are in the process of AI in healthcare, especially radiodiagnostics. We are in talks with them, and if the things materialize, probably we will collaborate with some of the leading world universities in these radiodiagnostics. I think together we can build a digitally inclusive, equitable, and resilient health system. Thank you. Jai Hind.
Thank you, sir, for this thoughtful and enriching introductory remarks. Now, we would like to call Shri Ajay Kumar Singh, a senior journalist, former press secretary to the President of India, to to address the gathering.
I have an emotional association with Adri, so it will be a kind of walking down the memory lane for me. My association with Adri goes back to 1991 when I was appointed here as a reporter in Economic Times. सहबालदा उस समय एन सिन्हा इंस्टीट्यूट में भी थे and we used to talk about Bihar and so जो भी deficiency as a journalist दिल्ली की होती थी, अगर वो fulfill होती थी तो Adri was the reference point. सहबालदा, we used to talk to him and he would explain it to us कि बिहार का positive side क्या है. So I don't recall any journalist from Delhi or Bombay or anywhere in the world coming to Bihar and not visiting Adri and not meeting सहबालदा. हमें तो लगता था कि पटना जाने का मतलब होता है कि सहबालदा से मिलना ही है, और सहबालदा से मिलते थे तो हर बार टर्मिनोलॉजी एकेडमिक्स की नई नई पता चलती थी. हम तो कई फेसेस देख रहे हैं जो हम लोग अक्सर उनके साथ बैठते थे और वो लोग साथ रहते थे. So what I'm trying to say is that understanding of Bihar was deficient in Delhi और Bombay जर्नलिज्म में हम लोग के, और वो सहबालदा यहाँ हम लोग को एक्सप्लेन करते थे या बाकी जर्नलिस्ट को कि कैसे इसको आप बिहार को समझिए. एंड आद्री यूज्ड टू बी द रेफरेंस पॉइंट. You know, this visiting Amartya Sen came to Bihar because of Adri. Joseph Stiglitz, he came to Bihar. Adri was involved in that. मुझे अच्छी तरह याद है कि बिहार के चीफ मिनिस्टर उस समय एक बार सहबालदा से बोले थे कि अरे भाई, इन लोग को आप इनवाइट करते हैं तो हमें तो बता दिया करिए. और ये इनविटेशन होता था तो पूरे इंडिया में बिहार के बारे में जो पॉजिटिव स्टोरीज होती थी वो आती थी. सो आद्री हैज दैट काइंड ऑफ लेगेसी विच इज रियली बहुत बड़ी थी वो, और एक कैसे उन्होंने इसको बनाया, कैसे बिल्ड किया. आई वॉज रियली वेरी हैप्पी व्हेन आई सॉ दैट इस उनकी बेटी ने उसको और भी अच्छे ढंग से शी इज़ ट्राइंग टू डू इट. शी इज़ ट्राइंग टू रिवाइव द स्पिरिट ऑफ सहबालदा. एंड हेल्थ के सेक्टर में मैं एक्सपर्ट तो नहीं हूँ, बट व्हाट आई हैव हर्ड फ्रॉम एक्सपर्ट्स, पैंडमिक किसी के लाइफ में अगर एक आ जाए तो बहुत होता है. मतलब 100 साल से ज़्यादा में एक बार आया. इस पैंडमिक में हमने देखा कि किस तरह से टेक्नोलॉजी ने ये डेफिशिएंसी को फुलफिल किया. दिल्ली में मैं देख रहा था कि जब पैंडमिक का पीक था, मैं राष्ट्रपति भवन में था और कई लोगों की हेल्प मैं चाहता था कि उनको अस्पताल पहुंचाऊं, लेकिन नहीं हो पा रहा था. उस समय टेक्नोलॉजी ने किस तरह से हेल्प किया. तो टेक्नोलॉजी जो लो एंड मिडिल इनकम कंट्रीज़ हैं उनके डेफिशिएंसी को अगर पूरा करता है तो वो एक नया इनोवेटिव और नया मेथड होगा. लेकिन डिजिटल डिवाइड तो एक इशू रहेगा ही. तो डिजिटल डिवाइड एंड विद टेक्नोलॉजिकल इनोवेशन, हाउ डू वी प्रोवाइड एक्सेस टू दोज हु आर नीडी, दैट विल बी वेरी इम्पॉर्टेंट. So I hope this endeavor from Adri would go a long way to create a kind of a space जहाँ पे ये एक alignment होगा. और I'm really thankful to Ashmita for initiating this, and I wish you all the best. Thank you very much.
Thank you so much, sir, for this emotional and enriching address. Now, I would like to call Dr. Ravi Shankar Singh Sir, Medical Director, Jai Prabha Medanta, Super Speciality Hospital.
Good morning, all dignitary on the dais and off the dais. So, how Ajay was saying about Adri, the similar stories with me when I came to Patna to establish a first corporate hospital. I got interacted to Shaivalda. And one person was absolutely dedicated to Bihar, that anything, किसी को बिहार में कुछ positive करना हो तो Shaivalda is the person to go who will guide you. Though I am Bihari, but I was not in Bihar for a long time, and I was kind of distracted, and I had my views as any Delite would be, because my most of the work life was in Delhi. But through him, I started seeing the realities, and I started actually seeing what is the need. Though I was establishing a hospital, that hospital got established, but the human touch and the realities of the ground started coming back through Sevalda. My various interactions with him gave a lot of insight how people think on the ground, how things are moving socially, and how it should be interpreted as a doctor, as a hospital administrator. And that shaped up in one hospital, then setting up another hospital. The similar spirit and started coming up, because I had some now background to set up the next hospital was very easy, and bringing it to some height become easier. When this conference was being conceptualized, Sanchita got in touch with me, requested me some, references of people on the dais. How do we shape up? So we started discussing few discussion, and I'm very happy that today this conference has shaped up the way we discussed in earlier days. AI is today what computers were in 70s, probably. Scary, a lot of noise in the system, jobs will go, ये खत्म हो जाएगा, वो खत्म हो जाएगा, ये नहीं होगा, खूब सारा noise होगा, AI will take over, this thing, that thing. Nothing happened. Computers are there in every nook and corner. Every job is there, if not more, the job opportunity came more and more. AI is a new disruptor, it's touching most of the aspect of the life today. Healthcare probably is biggest achiever or gainer today through AI. Think about a world which is connected, thoroughly connected. Whatever we are discussing, somebody, not directly, but through AI is listening. Whatever we are deliberating will be listened by a lot of people sitting somewhere far in the world. And these things will be kind of integrated somehow. Whatever data is being created in our hospitals, Dr. Binder sir, Dr. Raju sir were talking about in their hospital informatics systems, their diagnostic tools, all those tools are connected. All your data, when we are getting tested or being treated through your symptomatology, is being logged somewhere, and all those things will be coming back to Shankji's this thing, Abha. Abha will be collating everything in one this thing. Look at the power of the data. When everything gets collated at one place, the research becomes easier. Everything is cataloged through, every individual will have their, all the data of their respective health, whatever they are going through, and, their symptomatology, their genetics, their, everything is there, and some researchers come out. It will be anonymized, but, it will be very easy to predict next thing. Which brings you to the next generation healthcare. What is going to happen in future? You will see something is happening today when genomics is being taught. Something is being discussed with personalized care. In probably 15 years, 10 to 15-year timeline, you will see your medicines are going to be personalized, if not early, the way things are. So for similar symptomatology, person A will be given something else, person B will be given something else. Maybe not for your common elements, but for the serious element, definitely. Cancer is one area which this disruption is taking big way. Some of the cancers are now broken into genomics, genes, and some of the treatments are already in play today. I am very hopeful that in coming days, those things will become, day-to-day activity. Your doctors will be prescribing, God forbid, that is required. And the similar thing will be coming down from cancer to the similar things like lighter things. Lifestyle disease will be biggest gainer when AI's full potential is kind of, come into play. So with these things, we will be discussing in the coming session further how the hospitals are changing, how healthcare is changing, and how AI is being in the midst of all these things. Thank you very much for the day.
Thank you so much, sir, for your insightful address.
अब हम स्वागत करना चाहेंगे श्रीमती शेरिंग वाई भूटिया मैम, आईएएस, एडिशनल सेक्रेटरी, स्वास्थ्य विभाग, बिहार सरकार का। मैडम, आप स्वास्थ्य नीतियों को लागू करने, राष्ट्रीय स्वास्थ्य कार्यक्रमों के संचालन एवं राज्य तथा जिला स्तर पर सहयोग करने में महत्वपूर्ण भूमिका निभा रही हैं। मैडम, हम आपसे निवेदन करते हैं, कृपया अपना संबोधन दें।
Distinguished guests on the dais and off the dais, medical practitioners, experts from across the globe, ADRI team, members of the media, ladies and gentlemen, Namaste. A very good morning to all of you. Today, technology has touched every aspect of our lives. Whether it is how we communicate, store our documents, navigate, shop, or access service. Everything is now available instantly, at a click or a touch. In India, this transformation has been especially powerful because of two major advantages: extremely affordable mobile data and very high mobile penetration, which reaches even our remotest habitations. This combination has democratized digital access in a way few other countries have achieved. And in this era of reels, instant messages, and AI-assisted tools, information travels faster than ever before. So the natural question for all of us is, how do we channel this immense digital power into the sector that touches every single life, which is obviously healthcare. Let me now share a small personal story that has really stayed with me. Recently, I had taken my father for a follow-up consultation. He had, however, misplaced all his earlier prescriptions. So I told the doctor a bit apologetically that we didn't have the earlier papers. He simply smiled and said, "No problem at all. Everything is stored digitally." He typed my father's name and mobile number, and within seconds, the entire case history appeared on his screen. He made his updates, printed a clean typed prescription, and handed it to us. And I must say, it was probably the first time in my life that I could clearly read every single word of a doctor's prescription. And many of us joke, doctors and handwriting have always been a legendary combination. But digitization has finally solved that problem. Today, if you travel across Bihar, from the APHCs to the district hospitals. You will see this with your eyes. I will now touch upon how IT has been used and integrated by the health department in Bihar. I will not go into details of each of these big initiatives to avoid overlap with the distinguished speakers from the government who have addressed before me and will probably be addressing after me. Over the past 2 years, under the Bhavya Digital Health Platform, Bihar has achieved one of the fastest and most comprehensive health system digital transformations in the country. The platform is now fully operational across all 38 districts, covering more than 13,500 health facilities, from district hospitals to health sub-centers. Over 1.4 lakh healthcare workers have been trained across more than 3,300 batches, ensuring that digital tools are used effectively at every level of service delivery. The progress made under Bhavya is both deep and measurable. In just 6 months, Bihar recorded more than 1.65 crore OPD registrations, with nearly 1.2 lakh digital registrations every single day. Today, 92% of patient registrations take place digitally through scan and share, ensuring seamless ABDM integration. We have already created 1.48 crore ABDM-linked health records, enabled 3.3 crore digital drug dispenses, and captured over 68 lakh diagnostic tests electronically. A similar shift is visible in inpatient care, with nearly 8.8 lakh IPD admissions integrated into the digital care continuum within just 6 months. This digital backbone is strengthened further by real-time governance tools. The state-level command and control center, it was the first of its kind in India, along with 38 district-level centers, now provides round-the-clock analytics, help test support, CCTV-based facility monitoring, performance benchmarking, and continuous patient feedback tracking. In addition, 534 block-level data analytics centers enable grassroots decision-making based on real-time information rather than paper reports. Under the M-ASHA platform, more than 2 crore households have been digitized and over 10 lakh new beneficiaries are added every month, significantly improving last-mile service delivery. And with 2007 CCTV and dashboard monitoring across all 35 SNCUs, every neonatal admission, referral, discharge, and death can now be tracked in real time across the state. Nursing Digital Portal is a unique initiative that provides structured learning materials, digital coursework, and online examinations. This greatly strengthens the quality of nursing education and training. E-Sanjeevani teleconsultations have significantly improved access to healthcare, particularly for rural families. Patients can receive timely, qualified medical advice without traveling long distances. I would also like to mention an area that often does not come up in public discussions, but has enormous impact: the digitization of procurement and supply chain processes. Today, tendering, approvals, inventory management, and vendor performance tracking are all handled through digital platforms. Transparent and predictable procurement is directly linked to the availability of medicines, equipment, and supplies at the last mile. This shift towards digital procurement has strengthened efficiency and significantly improved the delivery ecosystem. We are also moving towards the digitization of medico-legal documentation. Through MedLeaper and related platforms, legal medical reports, including post-mortem reports, are now being generated and provided online. This has brought extraordinary convenience for families, the police, courts, and all stakeholders who earlier had to make multiple visits and navigate cumbersome paper-based processes. What was once slow and opaque is now timely, accessible, and transparent. This international conference could not have come at a more fitting time. We stand today at the intersection of traditional healthcare systems and rapidly evolving AI tools, predictive analytics, digital monitoring frameworks, and data-driven decision-making. For India and for low and middle-income countries around the world, technology is not optional. It is a force multiplier, enabling us to bridge resource gaps, strengthen equity, and improve outcomes at a scale. As a millennial, I often say that we grew up with Google. But for Gen Z and Gen Alpha, AI and technology is the only way forward. And as administrators and policymakers, it is our responsibility to ensure that technological power is channeled to improve healthcare access, quality, and dignity. A conference like this, with policymakers, specialists from the medical field, and experts from across the globe, gives us the space to reflect, ideate, and collaborate. I'm certain that the next 2 days will generate rich insights and actionable pathways for the future of digital health in low and middle income countries. I congratulate ADRI for organizing this significant conference and for bringing together some of the most committed and accomplished voices in health and technology. Thank you for having me, and thank you everyone for giving me a patient hearing. Dhanyavad.
Thank you so much, ma'am, for your thoughtful insight and policy-oriented reflections. अब हम श्री शशांक शेखर सिन्हा IAS मुख्य कार्यकारी अधिकारी बिहार स्टेट हेल्थ सोसाइटी का स्वागत करते हैं। सर बिहार में आयुष्मान भारत PMJ के कार्यान्वयन का नेतृत्व करते हैं। उनके मार्गदर्शन में राज्य स्वास्थ्य एजेंसी स्वास्थ्य बीमा संचालन, अस्पतालों का एम्पानलमेंट और दावा प्रबंधन सुनिश्चित करते हैं, जिससे राज्य के आर्थिक रूप से कमजोर परिवारों के वित्तीय सुरक्षा प्रदान की जा सके। सर, आपको 2 शब्द बोलने के लिए मंच पर आमंत्रित करते हैं।
आदरी के द्वारा इस हेल्थ इनोवेशन टेक्नोलॉजी के इस कार्यशाला में मैं सबसे पहले धन्यवाद देना चाहूँगा अस्मिता मैम का कि जिन्होंने मुझे आमंत्रित किया। आदरी से मेरा एसोसिएशन काफ़ी पुराना है, शायद 1993 से, ड्यू टू माई वाइफ्स एसोसिएशन विथ अभी मैम हैं, सुनीता लाल मैम हैं सामने, तो तभी से हम जुड़े रहे हैं। सहवालदा के साथ भी हमेशा हर कार्यक्रम में लगभग हमने अटेंड किया है और मुझे बड़ी खुशी है कि आज उनके बाद अस्मिता मैम जो है इसको बहुत अच्छे तरह से संभाल रही हैं। और क्योंकि अभी जो आयुष्मान भारत की एजेंसी है बिहार स्वास्थ्य सुरक्षा समिति, उसमें आदरी हम लोग का डेवलपमेंट पार्टनर है, तो इनका सहयोग मुझे हमेशा मिल रहा है, इंक्लूडिंग दिस टॉपिक जिस पर किया गया हेल्थ इंफॉर्मेशन टेक्नोलॉजी। हेल्थ के आईटी में हम लोगों का बहुत अच्छा बिहार का प्रदर्शन रहा है। पहले केंद्र सरकार ने एक योजना प्रधानमंत्री जी के द्वारा स्टार्ट किया गया ABDM, अखिल भारतीय डिजिटल मिशन, और उसी का एक 2022 में बिहार सरकार ने भी एक मुख्यमंत्री डिजिटल स्कीम स्टार्ट की। मुख्यमंत्री डिजिटल स्कीम एक तरह से सपोर्टिंग स्कीम आज हो गई ABDM की, और मैं ये जो मुख्यमंत्री डिजिटल स्कीम था वो अपने आप में एक इनोवेटिव स्कीम था पूरे कंट्री में। आज हम लोग बिहार को हेल्थ सेक्टर में डिजिटली सबसे एडवांस माना जाता है, और मैं इसका क्रेडिट दूंगा उस समय के ACS प्रत्यय सर का और हमारे जो अभी मिनिस्टर हैं श्री मंगल पांडे सर का, जिनका लॉन्ग स्टैंडिंग विजन था कि हम इसको डिजिटाइज कैसे करें बिहार के हेल्थ सेक्टर को। इसके लिए 2022 में मुख्यमंत्री डिजिटल स्कीम स्टार्ट हुआ। इसका सबसे बड़ा चैलेंज था हम लोग को PHC लेवल से लेकर के सदर हॉस्पिटल तक के लोगों को डिजिटल प्लेटफॉर्म पर लाना। इतना आसान काम नहीं है बिहार का जो लिटरेसी या जो लेवल है, लेकिन इसमें कई प्रॉब्लम्स आए। काफ़ी हेक्टिक रिव्यू मॉनिटरिंग के बाद आज हम लोग की स्थिति है कि पूरे स्टेट के हम लोग 500+ सेंटर पर डिजिटाइज जो है OPD करते हैं। इसमें जो है हम लोगों का काफ़ी अच्छा इसका रिजल्ट भी आया। मैंने मतलब कि हम लोग इसी हॉल में आज से लगभग 1.5 साल पहले हम लोगों ने एक ABDM स्टेट लेवल का कॉन्क्लेव किया था। हम समझते हैं कई लोग इसमें से उस कॉन्क्लेव में शामिल थे, और लोगों को हम लोगों ने काफ़ी सेंसिटाइज किया कि इस स्कीम का क्या है। मुझे खुशी है कि पिछले 1 साल में हम लोगों ने बहुत अच्छा रिजल्ट किया है। बिहार को माना जाता है टेक्नोलॉजी बैकवर्ड, लेकिन आज जब भी कोई कंट्री लेवल की मीटिंग होती है हम लोग जाते हैं, तो हम लोग जो है सो इसमें बेस्ट प्रैक्टिसेज में हम लोगों को माना जाता है बिहार का। मैडम ने बताया, भूटिया मैडम ने, थोड़ा सा मैं इसको रिपीट करता हूँ, स्कैन एंड शेयर एक ऐसा चीज़ है जिसमें हम लोग कंट्री में लगातार टॉप कर रहे हैं। मतलब कि EHR लिंकेज, इसमें मैं बताना चाहूँगा कि सबसे बड़ी चीज़ है ABDM का जो एक डिजिटल प्लेटफॉर्म पर लाने के लिए एक आभा का जो अथी किया है कि हर आदमी का एक यूनिक डिजिटल नंबर होगा, आभा होगा, और उसका जो रिकॉर्ड है उसमें जो है EHR बोलते हैं, इलेक्ट्रॉनिक हेल्थ रिकॉर्ड लिंकेज, इसमें भी हम लोग रैंक 3 और 4 पर है कंट्री में। तो इसमें क्या है कि जो इलेक्ट्रॉनिक हेल्थ रिकॉर्ड क्रिएट होता है, हर आदमी का जाता है, वो एक आभा नंबर देगा। बहुत आसान है बनना, हम लोग बना भी रहे हैं अभी ये। और आभा के बाद जो उनका जो इलेक्ट्रॉनिक हेल्थ रिकॉर्ड है उस क्रिएट होता है, जो भी जहाँ भी गए। उसके बाद उसकी सेफ्टी भी रखी गई है पर्सनल हेल्थ रिकॉर्ड का, कि कहीं जाता है तो उसे उस मोबाइल पर एक OTP मांगा जाता है, जैसे मैम ने बताया अपने फादर के संबंध में। तो वो एक बहुत ही अच्छी चीज़ है कि अब पेपरलेस डिजिटाइजेशन के लिए हम लोग जा रहे हैं, और इसको हम लोग अभी काफ़ी कुछ करना है। और आज निश्चित रूप से ये जो आज का ये फंक्शन है, इससे हम लोग को काफ़ी फ़ायदा मिलेगा। अभी और भी चीज़ें हैं जो डिजिटल ट्रांसफॉर्मेशन में हम लोग काफ़ी काम कर रहे हैं। उसमें सबसे बड़ा चीज़ है HPRA और HFR रजिस्ट्रेशन, जो हेल्थ पर्सनल का रजिस्ट्रेशन। जितने भी जो हमारे हेल्थ जो डॉक्टर्स हैं, नर्सेज हैं, वो सभी का एक प्लेटफॉर्म पर उसका डिजिटल रजिस्ट्रेशन होना है। और दूसरा HFR है, जो हेल्थ फैसिलिटी रजिस्ट्रेशन। इसमें जो है सो जितने भी हम लोग हेल्थ फैसिलिटी हैं, चाहे वो गवर्नमेंट हॉस्पिटल्स हो, मेडिकल कॉलेज हो, PSCs हो, चाहे वो फार्मेसी हो, लैब्स हो, ये फिजियोथेरेपी सेंटर, ब्लड बैंक्स, ऑल हैव टू बी रजिस्टर्ड कम इन द सेम प्लेटफॉर्म। इवन हम लोगों ने एक बहुत अच्छा ड्राइव चलाया है, जितने भी दवा की दुकानें हैं उसको भी इस चेन में हम लोग कर रहे हैं। और अभी बहुत खुशी होगी कि अभी हम लोग कल तक जो है पिछले 15-20 दिन से इस ड्राइव को चल रहे हैं, अभी 6000 फार्मेसी शॉप्स इस प्लेटफॉर्म पर आ चुके हैं। तो ये चीज़ जो है हम लोगों ने डिजिटाइजेशन में काम किया है, और इसमें आदरी का काफ़ी सहयोग रहा है। मैं बताऊंगा AI का बात, जो आर्टिफिशियल इंटेलिजेंस को हम लोग प्रधानमंत्री जन आरोग्य योजना में यूज कर रहे हैं। अगर आयुष्मान भारत से काफ़ी फ़ायदा हुआ है तो काफ़ी मेल प्रैक्टिसेज भी शुरू हुए हैं। जैसे एक हॉस्पिटल एक मेडिकल प्रिस्क्रिप्शन को 2 पेशेंट भी यूज करता है, द AI ट्रिगर्स मी, जैसे ही वो बिल आता है कि नहीं भाई ये आदमी का ये जो प्रिस्क्रिप्शन है ये किसी दूसरे केस में भी यूज हुआ है, तो ये टेक्नोलॉजी का ही है। नहीं तो ये जिस तरह का वॉल्यूम ऑफ केसेज है तो उसमें बहुत मुश्किल था इन चीज़ों को डिटेक्ट करना। आदरी ने एक साफू डैशबोर्ड बनाया है, मैं मैडम को धन्यवाद दूंगा, काफ़ी उन्होंने पर्सनल इंटरेस्ट से बनाया। वो डैशबोर्ड है कि हम लोग जब किसी हॉस्पिटल में जा कर के उसका लाइव ऑडिट करते हैं तो उस डैशबोर्ड से हम लोग काम कर रहे हैं, तो इसका काफ़ी अच्छा ये आदरी का रहा है। तो ये है कि अभी हम लोग डिजिटली हम लोग इंफ्रा की ओर भी काम कर रहे हैं, अभी काफ़ी आगे जाना है और हम लोग लगे हैं और बिहार के लिए ये एक बहुत बड़ा वरदान होगा। थैंक यू।
धन्यवाद सर आपके मार्गदर्शन और हमेशा हमें समर्थन देने के लिए। नाउ वी वुड लाइक टू इनवाइट स्टेट बैंक ऑफ इंडिया जनरल मैनेजर श्री नटराजन सर टू ग्रेस द डायस। May we kindly him to the stage with a warm round of applause, please.
Now, after that enriching inaugural session, we will have a small round of felicitation. I would like to call Dr. Ashmita Gupta ma'am to kindly felicitate our esteemed guest. हम शुरुआत करते हैं श्रीमती शेरिंग भाई भूटिया मैम से। मैम प्लीज, वी वुड लाइक टू फेलिसिटेट यू मैम, प्लीज। इसके उपरांत हम बुलाना चाहेंगे श्री शशांक शेखर सिन्हा सर। Now I would like to call Shri Ajay Kumar Singh sir. Now I would like to call Dr. Binde Kumar sir. अब हम आगे बढ़ते हैं प्रोफेसर ब्रिगेडियर डॉक्टर राजू अग्रवाल सर। अब हम बुलाना चाहेंगे डॉक्टर रविशंकर सिंह सर। Now I would like to call Shri R. Natarajan sir. Thank you ma'am for felicitating our esteemed guests.
We would now likely to welcome Shri R. Natarajan sir, representing our sponsor, the State Bank of India. Sir, we request you to kindly deliver the leadership address.
Good morning, everyone. Esteemed guests seated on the dais, others off the dais. It's a rare privilege for State Bank of India to be part of this two-day conclave organized by ADRI. It was to be addressed by CGM because due to some official engagements I've been deputized for this. I was just hearing to the two speakers when I was seated there, the type of technological innovation the country is taking and the state is taking. It's very heartening to know the developments that are happening in the medical field and the type of telemedical facilities that is available, and to tell you from the perspective of the financial sector, the banks are also equally involved in digitizing, providing a lot of digital solutions to hospital management. We have been providing complete solution. It has been given in the hospitals in Lucknow. Before this, I was posted in Lucknow, where we are given it to the one of the biggest hospital there. It has been given, government hospital. Complete solution has been given, and the solutions are also equally can be spread, extended to the students also. How they can be taken right from the attendance, their complete course, payment, everything can be done through a smart cards. That is also possible. Apart from that, we are moving the solutions that are given by the bank for cashless facility. That is happening especially in government hospitals. It is a big boon for the patients who take the card by paying the required amount, and then after that by flashing the card they can get all the services done across the hospital without paying any cash, without any hassle. So this is a small step that is being happening. So we are very happy to be associated with this ADRI, and also we all offer our assistance, help in any area that is there where the bank can come in as a digital partner and provide a digital solution to you, so that we can take it forward. Both private and government, we are actively involved in that. So I wish this function all the very best. To like to continue here due to some official engagement, I would like to take leave of you. Very nice to be here. Thank you so much. Have a great day. Thank you.
Thank you so much, sir, for your valuable insight and for sharing your leadership perspective with us. That brings us to the end of the inaugural session. We sincerely thank you, each one of you, for joining us and making this session truly meaningful. Ladies and gentlemen, a big round of applause for all our distinguished guests. We will be beginning our technical session shortly. Kindly stay with us as we prepare to start.
ही देखिए चेक चेक ही चेक 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 आ रहा लेवल आ रहा है सर हाँ check 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 he check check he hello आ रहा है सर hello 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 लिखिएगा हेलो 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 हेलो। हेलो हेलो हेलो। हेलो 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 हेलो। आ रहा है? हेलो ऑन हो गया। ये माइक का होना चाहिए। चेक 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 चेक। हेलो 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 हेलो। हेलो 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 हेलो।
Hello, 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 hello. Hello, hello, hello. Hello, 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 hello. Hello, hello, hello. Hello, hello. Hello, hello. Okay,
Hold on, then I'm listening it. So I can hear, but you should check in the room, please.
hello. 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 Sir, hello, hello, hello.
I can hear whoever is saying hello, but can you hear me? Yeah, but somebody is saying hello at least 100 times till now. Yeah, but there are others who are connected on the microphone and they're speaking, and I think they have access to editor or somebody. They are speaking continuously. That's what probably might even get relayed when I'm speaking. Can others mute the microphone or whoever is connected on the system?
Requesting all the guests to take the seat. So we are now starting with our first technical session.
Welcome back everyone. Now we would like to begin our technical session 1. This session will be chaired by Dr. Santosh Kumar Sir, CEO of Tata Medica Hospital, Kalinganagar, a distinguished healthcare leader with over 27 years of experience across hospital management, academia, and global health systems, a former WHO Geneva consultant and mentor to numerous scholars. He is recognized for his work in quality, patient safety, and healthcare transformation, a recipient of Erasmus Mundus Fellowship and multiple WHO awards, and trained at premier institutions such as Harvard, Johns Hopkins, and the IIMs. Dr. Kumar continues to champion AI-driven system improvements, workforce, well-being, and sustainable hospital management. Ladies and gentlemen, please join me in warmly welcoming Dr. Santosh Kumar Sir.
We are also honored to welcome our co-chair, Shri Prakash Kumar, State Information Commissioner of Bihar and one of the region's most respected journalist voices. With nearly 3 decades of impactful reporting and editorial leadership, he continues to shape public discourse with clarity and integrity. He is going to join us shortly. I would like to hand over to Dr. Santosh Kumar Pandey sir to further proceed the session.
So, good afternoon, everybody. I think after having such a sumptuous inaugural session, having heard the leaders of the healthcare from Bihar and the policy maker, we are into the first technical session about data-driven decision-making and AI applications in public health. So, we all know that in the beginning we were talking about taking the decisions based out on the intuitions, the hunches. And then there was a problem because we would never know whether which decision we take, in which condition is it correct or not. And then talked about data-driven decision-making and then of course I will not talk about much in depth, but then going forward we entered into the evolution of AI. We have with us, so during this process, we call it transformation from digital transformation to the AI evolution. So we have to talk about this topic, we have 3 very specialist senior expert in this field, Dr. Girdhar R. Babu, Dr. Ravi Shankar Singh, and Dr. Arpan Sharma. So before we begin, I invite all the speakers also to come on the dais. And Dr. Arpan Sharma. So while Dr. Arpan Sharma comes, maybe I'll take this opportunity to introduce Dr. Girdhar Babu. Dr. Girdhar Babu is an epidemiologist known for his work on non-communicable diseases, environmental health, and primary care. Previously, at PHFI, he has contributed extensively to Indian public health research and training. To my left is dear friend Dr. Ravi. He is the director of Medanta, Patna. He is a practitioner, clinician, and administrator. He has been involved into building the high-tech hospitals in different parts of the country, specifically transform the healthcare systems in the state of Bihar. Another co-panelist is Dr. Arpan Sharma. He is an environmental and geospatialist scientist specializing in climate science, land use, changes, and spatial analytics. His academic interest focus on applying geospatial evidence to ecological and public health research, as well as development planning. His work has been featured in reputed academic and non-academic outlets, including Nature, the Indian Express, and American Physical Society. So please give a big round of applause to all our panelists. And to begin with, because I don't want to take much begin with, I would invite Dr. Girdhar R. Babu, who has joined us online from Qatar University, and he will be talking about data-driven decision-making and AI applications in public health, the life cycle course of with epidemiological approach. Over to you, Dr. Girdhar Babu.
Thank you, Chair and Co-Chair and all the esteemed dignitaries. Can you hear me all right?
Yes.
Okay. Can you also see the slides?
Yeah, we can see.
Sure. Thank you. Good morning. At the outset, I sincerely thank the organizers, Dr. Sanchita, Dr. Tanmay, Dr. Aritra, and all the other esteemed colleagues at ADRI. I am very happy to speak regarding data-driven decision-making and how AI applications can help. And I'm seeing through this the lens of the life course epidemiology approach, because this is what I have been doing through my career. So to begin with, public health decisions, whenever we take any actions in terms of implementation, they have to be based on data, and this is something all of you are already aware. So more than intuition or what the other opinions are, what is important is how are we using data for enabling our actions. And with data-driven decision-making, we can actually address the priorities in the system, making sure that the data is more like a light that path gives us the path and also the destiny in terms of what action we need to take. And this data comes in several forms, be it research, surveillance, or real-time information streams such as HMIS. Now, using this framework, I have been following the path of life course trajectories of illness and disease and health. What do we mean by this? I mean, in layperson interpretation, can we examine a question such as, can we prevent any non-communicable disease such as diabetes even before the child is born? We are very familiar with vaccines, but can we take actions even before conception or during the fetal life that can actually prevent non-communicable diseases? If that is the question that we ask ourselves, there's a whole body of literature which is a do-had hypothesis and related research, which means development, origins of health and disease hypothesis. And this actually looks at early life experiences, be it any determinant, micro or macro, be it in the mother, father, in the social environment, and how that is going to shape the entire trajectory of health through the life course. So this is what I have been doing as a researcher for a long time. Here, the true principles of prevention are used. We are trying to understand. There's somebody else speaking on the microphone. There are opportunities for us in terms of windows available during conception and before and afterwards, and how we are using these windows of opportunities where the data collected at that time are going to offer us interventions in the long run. That's what we are doing in Life Course EPI. And by doing this, what we are trying to understand is what is the disadvantages that people have contextually, be it at the Indian settings or other LMIC settings. Global health has been, you are all familiar with decolonization. So far, we only know how the developed countries have these trajectories, but there's very little evidence in the low and middle income countries. So we are trying to map this using our approaches to cohort and other trials that we have done. Given that there is increasing non-communicable diseases, what we have tried to understand is what are the contextual factors, what are the evidence-based interventions that can be developed in the low and middle-income countries based on the dual burden of diseases that the countries are facing. So this is where I would jump to at least give the facet of AI in the whole perspective. What can AI do? But to begin with, I would say AI cannot actually do anything that we are not doing now in terms of technology platforms. But AI can augment, AI can transform, AI can facilitate. So here AI is not the driver, but it's more of a catalyst, and this I would want to make it clear even before we continue. But what AI can do in terms of life course API is it can uncover complex health patterns. So we all know that diseases are multifactorial in nature. And when we study, generally the research is only about one hypothesis, one specific risk factor at a time. What we are now have the power is using AI to make this complex interwoven strategies and how the illnesses are stemmed from these early life course that we can understand. And definitely AI can be used for data-driven prediction models for both early life and later risks in the entire adulthood. It can integrate several pieces of information, be it clinical, demographic, environmental. It can enable precision public health, and this is increasingly used. We need to understand the distinction between precision and personalized interventions. Precision, I would see mostly in terms of reducing the error, whereas personalized is making sure that every individual gains from these precision interventions. But towards that is a long way for a country like India, because right now we are looking at community-based, large beneficial interventions where we are saying, let's say, salt reduction or promoting physical activity. We have not even achieved those group level interventions. So therefore, although it's fancy to use personalized and precision medicine, we are not currently there. As a nation, we need to strengthen several other systems. But this is where AI can augment, both at the group level, also at the individual level. And finally, anticipate based on the existing data what future projections can be done, both at the individual and community level. I wouldn't want to go through the entire details of what we have done, but I would want to qualify in terms of what we have already done in terms of integrating data and using data. First such initiative is MASTI. MASTI is the acronym for our cohort. Again, I would not want to give details. There's a QR code. You can actually scan it and then visit all the publications of our research study. But a cohort, most of you are familiar, is following a group of individuals. And what we did here was we followed a group of pregnant women who are generally visiting the public hospitals. And then we ensured we mapped both biology and in terms of the psychosocial environment. By biology, we mean how is the glucose levels, or what are the other biochemical markers that mother has, what kind of nutrition markers she has. In addition to that, what is the psychosocial environment around the mothers? And then we followed up both mother and children, and it started with screening more than 5,000 women, but we have followed 2,873 mothers and children dyads now for more than 10 years. So we have this data. And when we looked at this data, we have multiple layers here. There is nutritional environment data, there is environment as such in terms of air pollution, then there's also physical activity, then there is psychosocial. So just within the mother, there are several domains. And with children, we are following up with each year their growth, their development, and even now we have included child mental health, several aspects that are included. And our follow-up rates are pretty decent compared to most cohorts all over India or across the world. So While establishing and continuing this cohort study, what we then saw is not just as a study, we use this as an example of how to harmonize several data sets into something meaningful from a life course perspective. Because we keep saying health is not just absence of a disease, but when you really want to prove that how are the social environment, how is the emotional environment, how is the physical environment resulting in what are the opportunities for prevention, the data isn't available there. So cohort studies give you those kind of opportunities, and that's what we have done using MASTI. Beyond this, we used whatever way in which we can use technology as a platform. We had a map, an Android app just for data collection. Then we started using RedCap for the data collection also in the backend. Then we used the cloud platforms to actually integrate the data. So even though AI was not there, even though machine learning algorithms were not implemented, we did whatever we could do when we started off. But right now, if you have to start a study or if you have to integrate the data sets, there are more tools available just to combine and follow up the data longitudinally. Beyond this, we also got Team Science grant from the India Alliance, where we are looking not just at the nutritional environment, but also on the environmental influences, on psychosocial influences, on both child mental health and development. And this, again, I have given the QR code. Please visit if you are interested. What we're trying to understand is how, as a sum total of all these domains in the mothers, the children, in terms of both neurodevelopment and cognitive outcomes, and also child mental health, is impacted. And this is what we are doing through the coincide. We have mapped environmental determinants, and now with Delhi air pollution and everywhere else, how environmental health is an integral component of human health. So therefore, how do we measure, how do we see what the associations are, and how does it influence mother's health and child health, that we have mapped using this study called as Apple. This is supported by Department of Science and Technology. We are fortunate. We are in an ecosystem where research is not done only for the sake of publishing papers, because if the evidence that we collect, if it doesn't get implemented into action, it's only good for journal publications. But here, what we are trying to do is this ICMR consortium of combining all the data sets available in India from all the cohorts, and we are fortunate to be part of this. And as a result of this collaboration led by ICMR, the first such effort was to examine how stillbirth is an outcome related to specific biomarkers, be it nutritional biomarkers or environmental biomarkers. This is a complex data analysis that is being done now at ICMR with all the cohorts together. So this is where we are already seeing big data being used for immediate action for priority health problems in India. And one such paper is on stillbirth, there's one on anemia, and there will be more papers coming out of this consortium. And again, you have these protocols for you to go and examine. Can we use technology also to do interventions? And this is one such effort that we did, where we used the mobile phones of the mothers as a mechanism, tool, to reach out to them in terms of imparting education on gestational diabetes screening, and whether these films that we show through the screens, either in the waiting area or in their mobile phones, will have any impact. This is a trial that we did both in India and Uganda with support from DBT and MRC in the Uganda side. And of course, our collaborator was London School. So the point here is technology can be an enabler, can be a catalyst, as long as we know what the challenge is and where do we intervene, and can we have technology being a catalyst to implement the intervention. From the cohorts through the pandemic's response, what I saw was how big data can be both a challenge in terms of data collection and analysis. And these are two QR codes I have given from the papers that are a result of the pandemic lessons. The biggest challenge was availability of high quality data. But with whatever limited data we had, what kind of projections in terms of real-time actions and responses can be done? This is what we did in India, be it ICMR task force or state level, the technical advisory committees or these scientific forums. These meetings were more than meetings. They were like war rooms because we had to make decisions based on data, and the data availability was limited. Because during the earlier time of the COVID response, misinformation was so rampant. Therefore, this is where, as a tool, AI or any of the advanced data analysis, if you know where the problem is, with whatever limited data, what is the most unbiased way of interpreting this? And these are the examples of how we used it. For example, syndromic approach. If you were to do, what are the minimum set of criteria? Because the definition of the case itself was changing. In the unvaccinated were vaccinated, what were the factors that were determining mortality or morbidity? Who requires oxygenation? These were not simply theoretical frameworks that had to be done. We had to answer these based on the available data. For example, states started purchasing ventilators right in the early part of the response, whereas the requirement for ventilators wasn't that much. Strengthening oxygen delivery systems was again as a result of the data analysis. So therefore, if you have the tool, if you know how to analyze, you can use AI to layer it towards the direction that you want to go. But if you let the AI to be the driver, then I'm sure only noise will come out of noise. Therefore, you will have to navigate, and it is for us as technical people, how do we navigate using AI as a tool. So without going further into the details of my studies or my engagement, these are the things that I see as an important way of moving forward. So what we have learned so far is, from all the studies that we have done, that evidence has to be collected through the life course perspective. Because if you are speaking of universal health coverage, and if you say primary health care is the primary driver of universal health coverage, whatever we offer has to be from a life course perspective. We can't be simply treating the tip of the iceberg in terms of the illnesses. We need to follow a life course approach. I think adolescence or at least preconception time is the best, but that is theoretical if they are not within the health system. But once women see an antenatal clinic, that is the first available opportunity for us to both start collecting data, analyzing it, and just imagine if we could do one cohort from using one district hospital. If all the district hospitals collect the data, if the state health systems collect this data with the tools that they have, already there's so much data available. We can actually map these factors which we can use as early prevention interventions. And the more the better, but we have the tools now, so nothing should stop us. And if prevention is the key, early prevention is the way to go, and that's what we have seen, at least from the studies that we have. Now, in terms of other risk factors, we don't really understand what's happening specifically in Indian population. There are many hypotheses. Why are Indians having type 2 diabetes mellitus at a lower BMI compared to the Western populations? There are many reasons, including thrifty phenotype and the so-called thin phenotype being described. But can we simply rely on theories? Can we not test them using the data that we already have? How much stress is contributing to the NCD? How much is air pollution contributing to it? We don't have to simply depend on the other studies. We can look at the data that we already have, and if we don't have, we can start collecting the data. And these are scalable, and whatever we do in India can actually help many other low and middle income countries, and that's where the interventions will be useful. These are the people who walked with me. Some of them are PhD students when they started. Now they are the leaders, and this is a team of what we call as Center for Development and Life Course Research in Bangalore. It's a pan-India institution, and led completely by bold, brilliant, compassionate women. Most of them trained through PhD, then they became postdocs, and then they're the early career researchers. So the point connecting to the technology and AI is the leaders. How are we strengthening the next layer of leaders is what matters. And since young people are anyway motivated to learn technology, use AI, this is the best time to instill the knowledge of epidemiology, biostatistics, also understanding the broader nature of public health. How do you work with the government and other stakeholders? And so this is what we did at the center, and we are exceptionally proud that what started as field notes now has become a hub of innovation, connecting communities. And I would call them true data scientists, but they're not data scientists alone. They're the ones who work with policymakers and the field level community action. And I would want to end with the set of slides for the future. If you want to build smarter health systems, we need to ensure that whatever the technology that we are using, it has to be purposeful. Just to give an analogy which you're all familiar, each state health system has more than 500 to 600 apps being used, different platforms being used. So we should not overload the system with simply technology and these apps, but instead follow. I'm not saying life course approach is the only approach, but let's say if you are purposeful and say that we will invest in a life course approach, we'll start mapping all these risks from a futuristic perspective and act on prevention early along, then you are then using digital power, AI, into interventions because you are trying to see where the purpose is, what the path is, and how do you map this data. And that's how the technology can be used. And preventions based on this data collections and analysis should again be used or catalyzed by the AI systems. And dashboards are something that are very powerful. Instead of making the ANM or ASHA collect millions of data sets on different apps, can there be some common entry at that level, and then can we have adaptive dashboards at the community level, at the primary healthcare level, rather than district or the state giving them actions on what to do. But while we try to do that, let's see what the potential of AI is and what are the challenges. These are the potentials. AI can definitely uncover long-term perspectives in terms of several domains being interlaced together, and it can also track the longitudinal data sets really well, and you can build systems where AI can be a phenomenal tool to help. But the systems will have to integrate these data sets first. So that's the prerequisite. It can build predictive models and it can give us interventions, scalable interventions as pilots. We need to be able to see which one of them are pilot worthy and which one are implementation worthy. We need to capture the complexity of the real world populations. AI can help to get these complexities figured out, but it is for us as humans to understand whether AI is right or not. That brings me to there are several other uses in terms of transforming health systems through several complexities, enabling cross-sector collaborations and all of that. But I'm not worried about the potential. I'm sure you're all familiar with the potential. What I'm really worried about, the ethical aspects. And if you have not already read, I recommend a book called Nexus, on which explores the potential pitfalls of using AI and other language models or any other intelligence which is not human. And this is not to be scared of it. This is not to be fearful of the future, but to be responsible. And the first layer is privacy and data protection. And because we are trusting the system, how are we trusting with the data that goes in? And how can we build in informed consent and autonomy when we are using AI? How do we avoid bias? How do you make the systems fair and equitable? These are the challenges, and this is our responsibility. Instead of blindly using AI tools for everything in terms of what actions that we are doing. Transparency is another issue. Accountability is an issue. Purposeful and beneficial use of AI is an issue. And finally, what are the shared benefits? Will it be inequitable are also the issue. So these are the ethical challenges, not to make us worry about it, but to be more responsible and take them in our stride as we move ahead. So reflecting on my path so far, I've used technology mainly for our purpose of making sure that intergenerational health is protected. And there are several technologies that have helped us, and some have failed. For example, IVRS we tried to use, but it never worked out for us. So these are merely tools, and with all the hype around it, I am not negating it. AI is a very useful tool, but we should know how to use it. So it will help us to learn from whatever data that we have collected in the past. We can also predict, but we can only protect if we as human beings are responsible and take this as another tool to be used very wisely, judiciously, and responsibly. Thank you for giving this opportunity, and I'm happy to hand over this to the chair.
Thank you so much, Dr. Babu, for taking us through the life course epidemiological approach of AI and database decision making. I think we all know that the most important thing about decision making, evidence-based decision making, is having the correct data, and that is the biggest challenge also, especially in developing countries, low LMIC countries and all that. But AI comes there also as a solution because it strengthens the data model, reduces the noises and biases. Now there are different models which can actually help us. The other thing is that we all work in silos, so different data are there, but different platforms are there which don't interact with each other. But AI also comes there as a solution because it can capture data from different sources, and then it can integrate. I'm sure the next speaker, Dr. Ravi, will talk about that. Even though the HMIS doesn't have the data, different apps and all that can pick the data from different modules and then can integrate and give the solution for whether it is patient safety or about the public health issues and all that. It enables other issues is of course that shortness of staff, the acumen of the staff, the workload is too heavy in especially the public health organizations and all that, and there the AI may enable precise investigation. It can anticipate, predict, and therefore help us in taking the personalized and precise information and decision making. So you have also kind of discussed about the different challenges, specifically about the ethics privacy and all that, the data governance, I think I'm sure that in some of the other technical session people will talk about that. But I will end it here. And definitely I agree that AI may not drive the decision making in health system, but it can definitely act as a catalyst. So we'll hold on over here, and maybe we'll take few questions from audience at the end of when all our speakers are finished and express their experiences and all that. So I request Dr. Babu, please be with us, and we'll come back with different questions. So having gone through the public health approach about AI, uses of AI and decision making, now we'll take private hospitals experiences. So Dr. Ravi is an expert of hospital management, so we'll talk about the smart hospitals and role of AI in decision making.
Good morning again. And we are talking about data which is coming from different sources, and AI is going to help them accumulate for the researchers to ask the questions and answer those questions. How this is being collated, this is going to be very important, how these things are being collated. So I'll just try to walk you through a kind of, scenario, how patient is searching today, what is the consumer behavior, how data is going to trickle down and collated somewhere, and from there some of the researchers, as Girdharji was saying, are, it's being discussed, sanitized data comes in play for development of tools, whether, where you are going to apply these tools will be a thing to see. As of now, the way everybody is saying is the application of AI primarily into healthcare is about operation, clinical decision making, and ease of operations in different area. Some of the larger public health issues it can solve if we are able to implement those questions. We are asked those questions rightly, give a long-term view, short-term view. So I'll start with the walk, this thing. So where are we today? Few years back, everybody was searching Google to their symptoms. And they're trying to find something, doctors were busy discussing. Most of the questions were started coming like, Sir, Google mein ye dikh raha hai, what should I do? In today's day, in today's era, question is changed. Now they are not asking that Google has said so. They are coming out with the healthcare because access of healthcare has improved, especially in the metros. And they come with the EHC, something called Executive Health Checkup, this thing data, fed into AI tools, and they come up with so much of jargon, which is not relevant for anyone. Not for the doctors, definitely, but now this is becoming day-to-day routine when people come with too many diagnoses for themselves with the EHC data which is fed into any of the tools. I deliberately am not naming any tool, but any of the tools, and with the diagnosis which is non-existent. Doctors don't talk like that. Doctors don't even, some of them, the diagnosis we have not seen. We don't even know. Maybe they are written in some footnote in one of the medical journals, but that is not my diagnosis. These guys will come with all of a sudden for a simple dry eye because you are using computers. They come up with a Suzanne disease, Suzanne syndrome, and you are talking, what the hell? Who said Suzanne syndrome? You have got no idea why he is talking about Suzanne syndrome. But and these guys are well educated. So this is changing day-to-day practice of healthcare. Currently, as of now, where AI is being practically used is mainly into diagnostics. The imaging has improved. All the images which you are seeing today, X-ray, CT, MRI, these things have been more or less, X-ray is fairly, AI is reporting X-rays. In TB eradication program, AI is being used as a first-line tool as of now. It's being applied. CT, MRI images are being, read by AI. Strokes are being diagnosed very accurately, and intervention can be planned on AI-driven this thing because time is very essence, and in some part of the country or the world, the access of radiologists and right time reading is not possible. It's still not possible. AI comes very handy. Stroke intervention can be done, and some life and functions can be saved. Laboratory reports are in and out; they can be interpreted. Still, histopathology is a little far, but rest of the biochemistry, hematology is being read and advised accordingly. In patient care, procedural and treatment explanations, which every patient complains doctor doesn't have time. AI comes very handy. All the questions can be, shared with all the answers can be shared with the patients in detail. All the guidelines, explanation of the surgeries can be done through this thing. Chatbots, AI-driven chatbots, specifically designed for any of the departmental needs, help the patients to understand the disease, the surgery plan, the treatment. All those things are, as of now, happening across the country, and some of the, even in Bihar, in Patna. This also triggers efficiency part. Is happening, all kind of analytics related to business of healthcare, patient behavior, how consumer is looking at the searching data, how patients are searching their data. Like chest pain is easy example. People will talk about heart attack, they talk about chest pain, they will talk about vague symptoms. And mostly it's being searched on the net. In today's world, mostly it's through AI-driven net. Search engines have gone in AI way, so they are giving this data. The problem with us is that when this data is coming to us or the patient, he is not able to interpret them rightly. A lot of jargon, a lot of garbage is there, and they get confused. They come with the highest and the worst diagnosis first, and doctors think otherwise. They look at the commonest and the easiest one first, and they rule out. Pharmaceutical and drug development is a big thing, and AI is boosting this whole thing very big time. Personalized medicine is, as earlier I said, probably 10-15 years you will have personalized medicine. Genomics and gene therapies are already happening, already in cancer area. A lot of treatment is happening in this thing. And no human brain can understand the genomics if you are going through the seeing yourself by naked eye, or you are going to see. There is no way you can read human genome by yourself. You don't have bioinformatics or AI, you don't get any information. So their AI is the way, the AI is the only way to probably go about. I'll walk you through a hospital OPD, how patient is happening. Today's world, patient is searching hospital or doctors through symptoms. He can find out what he needs. He will just feed his symptoms. He will go through the doctors or hospital. Doctors and hospitals are graded according to various parameters. Doctors are graded by experience. Everything is happening online. It's going through appointment booking. The schedule, payment is done through wallets. Then patient is given a navigation tool. He reaches to hospital. Even in an unknown city, if you go through this system, you are driven, your car will come to a navigation tool which will bring you to the hospital, even to your designated spot of the parking. There is something called in-building solutions. They will take you to the next level where you are supposed to report to the hospital, maybe to the nurse or to the billing counter, wherever designated. When you go to the doctor's room, that is the best part. Today, earlier, how the conversation was happening in the doctor's room, doctor asks questions. They get the answers from you. They ask the counter questions. They deliberate the doubts of this thing, and then they write a prescription. This is changing. AI has completely changed. Now, whatever conversation you are having, the prescription doctor is not writing. It's already being read. While he is discussing, the prescription comes on the computer. As soon as he finishes the conversation, he talks about what kind of treatment he is looking for. So he will say 1 tablet of this, 1 tablet of this, for these kind of investigations. All those things are printed, and as soon as he finishes the conversation, your prescription is with you. This is happening real time now across the hospitals. Again, as soon as your prescription is printed, the tests are ordered. Now you are supposed to just acknowledge in your app whether you are going ahead with the test at that hospital. As soon as you acknowledge the test, you are again directed to designated spot of a hospital to give your samples, to get your tests done. As soon as you finish those things, your reports are going to be read and delivered to you in your app. You see your doctors and your day finishes. This whole thing can be done, is being done at some part of this thing. The best part is that all those data which has come out of your prescription, your pharmacy, your lab, everything is being collected under your name, under some ID, which is government is proposing ABHA, and it's going there. Look at the beauty of it. In back end, what happens? In back end, every data is there for a researcher like all of you. This data is cataloged, specified according to gender, locality, their caste, creed, location, everything. And this is the real-time data, just to be anonymized, and it's available for you to take it further. And it's being taken already in different level of treatment. As soon as the patient is getting hospitalized, the things changes. Now patient care, all patient care is happening through your doctors are visiting. Everything is again being, nurses are discussing with you. Everything is going into EMR all the time, real time. It's going into EMR. And orders are given. All the orders for your, if surgery is prescribed, most of the surgeries nowadays, 70-80%, earlier it was open system. Now most of the surgeries are coming through either endoscopic, microscopic, or MAS, minimally invasive surgery, or robotics. Robotics is another game changer. Robotics has done one thing, where, it has dissociated patient and surgeon. Surgeon is sitting somewhere else, patient is at a far distance. Look at the scenario when patient is sitting in, say, in today's world, when you are looking at a hospital, it's in the same operating room. Surgeon is sitting at a console and patient is at a far distant table. But now patient can sit in Patna, operate in Chapra or Sivan. It's already happening. Delhi has operated few cases in Bangalore, and Gurugram has operated some cases in Delhi. It's happening in our country. It's just a matter of time when we are going to help this thing. While we go through this all treatment, robots are going to deliver medicine. They are already delivering these medicines in Delhi, NCR circle. The foods which are supposed to be prescribed, they are coming to you by robot. This is happening already. All these things are being collated. AI will be operating in 15 years' time. All robotic maneuver, all images are being recorded. All equipments today which are in play are recording and sending your data at some place. Everything is on cloud. Everything is being collated and seen, analyzed. And hence, it is subject and data available for next level of research. As I have already mentioned that all data are, images are being read. They are being finalized. CT in certain diagnosis is confirmed. Cancer is going to be the biggest gainer in coming days. Cancer treatment is changing and will change completely with hormonal therapy in play, immunotherapy in play, and gene therapy, which is in some cancers have been diagnosed, and they are predicting to change the whole course of disease. As soon as gene therapy is coming into play, the next thing is going to happen is, genes will prevent diseases. Gene changes or genetic gene therapy will prevent diseases. Some part, the previous speaker touched about diabetes. This is going to be, probably 15, 20 years horizon if you see. These things is going to make a difference in all lifestyle diseases. All the EMR equipments, robots, diagnostics, as I have said, are being, the key word is to collate, and AI, as the previous speaker also mentioned, please always believe that this is going to be a navigator. It's never going to be a driver. You are the driver who is supposed to drive. AI has to be navigator. If AI comes into driver's play, we are going to be in a big problem because of the interpretation which a human mind gives, AI doesn't give, and is not capable as of now to do that interpretation of this thing. Caution. Privacy is the biggest casualty in while we are discussing that everything is connected, all your data, all your intimate things, all your histories, everything is going online. Hence, privacy is going to be a big concern. Today is also, it's a concern. Controlled growth of AI and proper validation methodology will be a boon, but commercialization, as happened to all the other technologies, is going to happen here and will lead to discrepancies, misuses, and hence a lot of erroneous data and erroneous research results and ambiguity in people's mind. It's important to keep a watch. The last line is very important, as the previous speaker also sounded, because ethical concerns and the watch on the proper uses of AI is going to be the key for in days to come. Thank you very much.
think we have our now session chair, Shri Prakash Kumar ji, the State Information Commissioner, has also come. So request you to come over there. Thank you, Dr. Ravi, for taking this walkthrough through the smart hospital. I think digitalization has become and of course the role of AI has become kind of differentiators for the hospitals, and the cost involved, it is going to be for sometimes I believe people it becomes democratized, because not every hospital can afford at this point of time. So we'll take some questions. We can come and then take the question from audience as well. So before we begin, I request sir that you can say a few words and then.
रिसर्च वर्क तो सबसे इम्पोर्टेंट है और हर इंसान रिसर्च करता है। यहाँ बैठे जितने लोग हैं सारे लोग रिसर्च करते हैं, लेकिन उस रिसर्च से सोसाइटी को कितना फ़ायदा होता है वो ज़्यादा इम्पोर्टेंट है। मुझे ये मौका आप लोगों ने दिया है कि इस अवसर पर मैं बताऊँ। मैं अपना खुद का एक्सपीरियंस शेयर करना चाहता हूँ कि जैसे आप मेडिकल फील्ड की बात करें तो डॉक्टर साहब का सुन रहा था, सब बहुत अच्छे से संभालते हैं। इट्स वेरी गुड। इस मेरी टीम का मुलाकात करूँ, कैसे उन्होंने काम किया है। एक्चुअली वो रिसर्च का ही नतीजा है कि कैसे आप डे टू डे लाइफ में जो आप कर रहे हैं उसमें उसका कितना बड़ा योगदान है, और अभी और भी कुछ करना बाकी है। रिसर्च एक तो प्रोसेस है जो ऑनगोइंग प्रोसेस है, कभी रुकता नहीं। कई नई चीज़ें आती हैं, कई पुरानी चीज़ें खत्म हो जाती हैं, कई नई बीमारियां आती हैं। उन बीमारियों को भी लोग पहचानते हैं। अभी हाल ही में जो कोरोना का हुआ था, इतनी बड़ी महामारी जिससे हर कोई भयभीत था और लग रहा था जैसे दुनिया खत्म होने वाली है, उसमें भी रिसर्च का ही बड़ा योगदान रहा। बहुत कम समय में लोगों ने वैक्सीन खोज निकाला और वैक्सीन का नतीजा ये हुआ कि लोगों की जो दिक्कतें थी वो धीरे धीरे ख़त्म होती जा रही है। लेकिन उसका जो इम्पैक्ट है वो आज भी है लोगों के शरीर पर, दिमाग पर। आने वाली पीढ़ी को हम क्या दे रहे हैं और कैसे दे रहे हैं, ये रिसर्च से ही जाना जाएगा। और आप जैसे डॉक्टर्स, ख़ास तौर से मैं उन डॉक्टर्स के लिए एक बार ताली बजाना चाहूँगा जो लोग क्लिनिकल पेशा को छोड़ करके इस विधा में आते हैं। ये बड़ा ही साहसी कदम है। मेरे लिए उनके बहुत रिस्पेक्ट है उनके। ठीक है, जो डॉक्टर्स हैं वो हेल्प करते हैं मरीज़ को, तत्काल उन्हें रिलीफ देते हैं, ये बात सही है। और कहा भी जाता है कि एक प्रोवर्ब है जो लगातार चला रहा है कि डॉक्टर जो है धरती के भगवान हैं। लेकिन सच्चाई ये है कि रिसर्च जो लोग करते हैं वो बेस है, वो बुनियाद है, जिस बुनियाद पर ये डॉक्टर्स इलाज करते हैं। कई लोग जो हैं पूरी ज़िंदगी खपा देते हैं इसी चीज़ में कि कैसे रिसर्च किया जाए। जो आदरी संस्था है, मैं इस संस्था को मैं बहुत पहले से जानता हूँ, और शहबालदा जब थे तो उनके साथ मेरा काफ़ी अच्छा एसोसिएशन था, और यही वजह है कि इस जगह पे मैं उनके लिए एक तरह से उनके प्रति श्रद्धांजलि अर्पित करते हुए मैं आ रहा हूँ कि नहीं, उन्होंने जो अलख जगाई है वो आगे भी जारी रहे, और आप जैसे नौजवान लोग, आप जैसे रिसर्च स्कॉलर्स लोग इसे आगे बढ़ाते रहें और नए लोगों को वो इसमें लाते रहें। तो आपने का भी बड़ा योगदान रहा है। आखिरी बात जो मैं कहना चाहूँगा कि जितने भी लोग रिसर्च में आ रहे हैं उन्हें सम्मान मिलना चाहिए। मैंने सुना है कि ये डॉक्टर यहाँ पे काम करते हैं, ये डॉक्टर वहाँ काम करते हैं, तो एक ऐसी संस्था बनाई जानी चाहिए जो संस्था रिसर्च के साथ साथ आम लोगों के साथ भी जुड़े, और आम लोगों को ये पता चले कि यही वो संस्था है जहाँ से निकल करके डॉक्टर्स को मेडिकली इस तरह से उन्हें चुना जाता है, इन्हें फिट किया जाता है ताकि वो उन्हें मदद कर सकें, सहायता दे सकें। तो आम लोगों के बीच में भी रिसर्च स्कॉलर्स की ऐसी व्यवस्था, एक ऐसा ब्रिज बनना चाहिए, एक पुल बनना चाहिए। अगर इस ओर आदरी अगर काम करे तो उनके लिए एक सम्मान की बात होगी। हालांकि ऐसे स्कॉलर्स सम्मान से पीछे भागते हैं, साइंटिस्ट जो लोग होते हैं वो ज़्यादातर उनका अचानक नाम फेम होता है, पर इन लोगों को भी आना चाहिए। थैंक यू।
Thank you so much, sir. I think that was so valued input. I think we had epidemiological journey of AI and data analytics, then we had smart hospital, and now we are going to talk about the spatio-temporal analysis using AI. And that is again one of the very close to my heart subject, because I also did a lot of temporal analysis, regression analysis, spatial regression analysis, especially in context of the flood in Bihar, and then how it actually affects the health of people in the state of Bihar. That was I did a paper also, but couldn't publish because of timing and all that. But again, thanks for taking this topic, Dr. Arpan Sharma, and over to you.
Sure. Thank you, sir. Basically, I'm a rocket science person trying to learn public health. So, my background, it is very strange. So I did my BTech in aeronautical engineering. After that, I did masters in ecology and environment. There I specialized in remote sensing and GIS. After that, I did my PhD in geospatial artificial intelligence. So basically, I am a technical person. So to set a background, why we need good data before we can do AI and all, why data quality matters, to bring that perspective, I'd like to call my colleague Danesh, if you permit, sir.
Thank you, sir. Good afternoon, everyone. Before we begin, it is important to know Bihar is India's third largest state with population over 120 million people, a high disease burden, and health system that historically relied on manual, paper-based reporting. Digital and real-time statewide digital surveillance in such a setting is not just a technical challenge. It is a governance, capacity, and behavior change challenge. Our story today is about Bihar navigating this challenge and transform disease surveillance to a point where it is now ranked among the top performing states in India. And this journey from paper to portal is a testament to collaboration between the government of Bihar and this journey, and IDSP, NCDC, and AGRI. We are honored to share this learning experience with you. IDSP is one of the largest infectious disease surveillance program covering 37 diseases for many years. The system relied heavily on paper-based weekly reporting (PLS) formats. With limited workforce for documentation and low digital integration, the surveillance system faced difficulties to provide early warning signals for outbreaks. This slide shows the traditional information flow from ASHA at the village level all the way to the state and central level. Between 2019 and 24, ADRI provided structured technical support to the Department of Health, Government of Bihar. Our work spanned gap analysis, pilot interventions, statewide scale-up, and quality control. These phases were shaped by extensive fieldwork, visits, interviews, and continuous engagement with the IDSP staff at all the levels. India introduced Integrated Health Information Portal, IHIP, bringing real-time data reporting Bihar experienced the initial challenges of the digital transition, which were there, but later it was resolved through steady support from the state and district IDSP cell. Public facilities were reporting inconsistently workforce shortage, and limited participation from private sector added to the problem. This is where intensive technical assistance became critical. We conducted 40 plus interactive sessions with IDSP, NCDC, and WHO. This helped establish the continuous feedback loop. Over 15,000 ANMs and over 9,000 officials were trained to do independent digital reporting. This marked a major shift of paper to portal. By June 2022, Bihar became eligible for full migration. Bihar became eligible for full migration, and in October 2022, real-time reporting began, which was a historic shift for the state. Bihar jumped from performance score of 10 in 2021 to 95% in 2022, ranking among the top 5 states among India, in India, and maintaining this position till now. And within the year, Bihar moved from 5% digital reporting to nearly 100% in PLS forms. This led to national recognition from the Ministry of Health, Government of India. The monthly and yearly data trends shows a consistent rise in reporting completeness and timeliness. By mid-2023, Bihar achieved third position nationally in IHIP reporting performance. These gaps led to renewed strategy jointly designed with the state IDSP cell. We worked with the state IDSP cell to redesign OPD cards to capture syndromic data more accurately, which improved presumptive reporting significantly, which overall helped in improving presumptive laboratory and syndromic reporting significantly. By 2024, the system had become well prepared. Protocol, guidelines, SOPs, training materials were developed and made available across the facilities. We also helped strengthening the capacity building of IDSP staff and established a strong review mechanism with real-time feedback. Timeliness, completeness in reporting were achieved, and reporting center expanded over nearly the entire public health sector. Most importantly, Bihar successfully migrated to real-time reporting on IHIP and consistently remained among the top 5 states in national PLS performance, maintaining its position. With these foundations in place, we then identified the next level gaps that indeed needed attention. Even the strongest progress, a few important challenges remained. First, reporting from urban and metropolitan areas were coming in varying levels. Second, engagement from private sector needed strengthening, especially in terms of consistency. And third, data quality required refinement to support real-time decision making. To explain these insights in more detail, how they shape the way forward, I now hand over the dais to Dr. Arpan.
Thank you, Danis. So, before looking into some maps, let me try to explain you what remote sensing and GIS truly means. You know, these two terms are always clubbed, like remote sensing plus GIS. You might have encountered these two terms very often. Remote sensing, it means to sense something from the remote. Even our eyes sense from the remote only. Basically our sense organ, except skin, right? So remote sensing is something through which you can observe Earth, like satellites. The signal processing and all. So that is remote sensing. And GIS, that is Geographical Information Systems. Geographical Information Systems, in West, people have already started calling it as Geographical Information Sciences. Not only Geographical Information System, it is now Geographical Information Sciences. So through GIS, we can do lot of modeling and various other analytical tasks with ease. And if you incorporate artificial intelligence into it, then the prediction becomes especially relevant. So let's say if you want to model the disease spread pattern, like COVID, how COVID is spreading throughout some geographical area. So that research we did we did previously in my another university. There we've found that in northeast region, COVID-19 was following reaction diffusion pattern. There are a lot of pattern, lot of modeling. For that, we need to have this spatial analysis. But to get into there, we should have data first, right? If you don't have data, so you don't have analysis. So in this phase, our major objective was to include private sector into the disease reporting. But we thought in that exercise we can also create health map of Bihar. So we started our journey with visiting to every private facilities in the state. So till now, we have visited around 23,574 private health facilities, private clinic, private hospital, private medical colleges. I think some issue with this thing. And we are even visiting informal healthcare providers. So right now we have, clear picture of where the health facilities are located in Bihar, especially the private players or individual players. And if you see the geospatial distribution of private hospitals and private medical colleges, which we have mapped till now, so the number is 3,169. So it is till now. But if you observe carefully, in Bihar, everything gets centered around the Patna region. Patna, Gaya, Samastipur, Muzaffarpur, Madhubani. These are like hubs for the medical facilities. Almost this pattern repeats for other type of facilities also, except the informal sector. For informal players, if you go to the rural areas, you will get more concentration of informal healthcare practitioners. So you can see this map is like all the facilities having IPTs. So same thing, same pattern you can see like in Patna region, it is very much concentrated. तो पटना में ज़्यादा हो जाता है, स्पेशली तो बिहार का ये पैटर्न हर एक चीज में हमको दिखता है. Even if you see the developmental things, you will get centralized development. पटना में काफी अच्छे से डेवलप कर रहा है. Again, similar kind of pattern. Pharmacies also. And This is like, the rural health practitioners. They are informal care providers. So they are away from the, you can see the Patna here. So it is looking away from the main hubs. Okay, so why we are doing this? One thing I already said, I told you that we are trying to develop the digital health map of Bihar. Along with it, we are also trying to streamline the reporting from the private sector. And it is a unique kind of exercise in this phase of our project. And this can be utilized into the larger health system strengthening plan with our collaborators and different other stakeholders. So these are some glimpses of training and review meeting that we are doing. And this was first ever book on IDSP, Bihar. It was released on November 3rd, 2022 by ACS Health. Thank you very much.
Thank you so much for taking us how the Adri had actually done the geo tagging of the healthcare facilities, both public and private sector. And I'm sure government must be taking the benefit of this in public policy and health policy.
Thanks to all the panelists for this wonderful presentation. Dr. Giridhar Babu's presentation was very, very useful to see how early life diagnosis, early life interventions can help in diagnosis. And same with Dr. Ravi's to see how technology is aiding medical systems. My question to both of them is that while, and I think you have yourselves hinted at this, being a social scientist, what I worry is what about access? And are we making, so as we make more digital, as we go more digital, as we make more use of technology, do we lose affordability, first of all? And secondly, in certain, even for medical diagnosis, sometimes, like Dr. Ravi also pointed out, the problem of commercialization. And in the earlier session, malpractices were also pointed out that there are a lot of tests being conducted, maybe, and all the doctors in the room know this, that there are so many tests that are being conducted, possibly in the traditional way, those were not needed. So how does, while, the benefits are very, very great, but how do we deal with these kinds of challenges, and does it require a new form of medical education, or what is the way?
So if I understand correctly, there are 2-3 questions in one question. One is probably about the access, how the access is improving. Second is about something to do with the prescription of the test and other things. And third, probably at the last you said about change of the education. Is it correct? Okay. So access of healthcare is penetrating. There are 2-3 things happening. One is through digital. A lot of access. While I was talking about robotics, the advent is helping of those surgeries which were unable to be done at certain place. The practitioners are trying to provide those services. And I think it was in US when they did one surgery from sitting in, I think, New York City, and did in some very remote area. This is what we are also trying, but because it needs a lot of backbone, digital backbone, data connectivity and all. If your data is broken, then the surgeon sitting in Patna will not be able to operate in Siwan. So as of now, we don't have that kind of confidence in the system that they will have the seamless run. But digitally, if you see, access is increasing. In primary healthcare sector, it's increasing tremendously. This digital thing is helping. In secondary and tertiary care, things are not like that, because secondary and tertiary care is still run by doctors' predominance, and there is still a lot of decision making is happening. Secondary and tertiary care still is a domain which needs to be seen how it's going to be in the remote area. Secondary tertiary practice at the tertiary care level needs a lot of infrastructure. With the advent of science and the newer technology coming in play and newer understanding of the disease, it's not about somebody is prescribing certain tests. Of course, malpractice happens everywhere, anywhere. So I'm not defending any of that. But when healthcare, again, probably we are diverting from my answer will be diverting from the focus of the conference. When the Consumer Act was enacted for healthcare, that changed the practice of the health in India, especially. That was the change point. Today, no practitioner will be able to prescribe technically. As soon as you say, I have got a fever, and he or she should, if he is rightful in mind, he will not be prescribing you that crocin, which earlier, before enactment of that act, he could have easily written a crocin and said कि 2 दिन के बाद देख लेना, आगे आके हम लोग देखेंगे नहीं बढ़ेगा. तो आज वो नहीं करेगा, because then he will be crossing that limit that he has not diagnosed it and not given that treatment. So to diagnose it, he has to do an X-ray or some certain basic test, at least, because in court of law, doctors have been alleged that why didn't you do it? And one doctor you penalize, you are giving message to a whole society that boss, don't do it. Some of the good Samaritans still do it. They will write the prescription, but verbally say, बाद में 2 दिन के बाद देख लेंगे, अभी मत कीजिए. But that gradually, slowly, nobody is going to take on their neck. There is a environment of fear when you do this kind of enactments. When you are going on the higher side of science, when you are practicing that, when we write that in this case there is a 20% chance of mortality, which is 1 in 5, but for the family it's 1 and only 1. For a doctor, I can say that I have operated 5, 1 died, 4 saved. But for family, that 1 is this thing, and he is going to sue me. Whatever I'm going to do, whatever experience I have got, So those things also play in our mind. So nobody is today in today's mind, especially in allopathic medical practice, is going to prescribe you things which he will not. At least in certain sense, we know that test normal आएगा. But अगर हम करते नहीं हैं, और God forbid you are not corrected with whatever medicine I prescribe, tomorrow you may LS. And that happening day in and out. I am, for last 10 year experience in this thing, I get mails every day or something that one doctor is an idiot. He doesn't know. He is a DM and MCH and with 20 years, but he is an idiot because this guy is probably advocate or something. But he thinks that he is an idiot because he prescribed and he didn't get okay in the first medicine. All those things is leading to change of practice, and I don't see any way of correcting it in near future until unless again the consumer form. But again, things will not go back. It will not go back to those old era when somebody goes to him and he prescribes. I don't see, because the next generation which has been trained in this duration is trained to practice evidence based. So evidence has to be created before I start writing prescription. So I don't see any other way of either proving or disproving or parking it for the next day to prove. I don't see it cost coming down. Healthcare education probably is changing anyway, probably for the worse, not for the good. The way we are opening medical colleges left and right, every small hospital is converted into a medical college. None of the medical colleges, though the numbers have increased, probably 7 से आज के डेट में 20-25 हो गए हैं medical colleges, but none of the medical colleges have got the full faculty as per the NMC norms. None. So education is not the one thing, and medical education has not kept with the changing times. That is another one, because time has changed. When earlier MBBS doctors were well accepted in the society. Today's society doesn't want MBBS doctors to write his prescription. He wants a MD or MS, if not DM and MCH. And those trainings are very limited. DM MCH trainings are very limited. When you have got 1 lakh MBBS students passing out, there are only 20,000 or so specialty, and there are very few hundreds of DM MCH. How do you get it? So this, probably to increase the baseline, these new institutions are being opened, and DNB and DRDNB, even private institutions like us, are allowed to take students. That's what is happening. So some gaps will be bridged, but medical profession as a whole, I don't see any vision document which says where we are going. A lot of activities are happening. I don't see them being very coordinated and very, that we are trying to achieve somewhere. That is not clear to, at least not to me. Maybe Santosh is into different things.
No, you're right actually. But only one thing I would just like to add on your point is that education system, especially the medical education system, definitely requires change, especially about use of technology, AI in decision making, how AI can help them, because they are trained how to do the practice, how to diagnose, and how to take and prescribe the medicine and all that, take care of the patient. But use of AI and then in sharpening their kind of skill in diagnosis, treatment and all that is something I think required training program for doctors, upcoming doctors, and this is already happening in the US and all that, and different parts of the world. Nowadays, we also trying to add, Government of India is also taking initiative that simulation-based skilling, and simulation-based skilling where AI is already part of that. So not only simulation-based skilling, but also the assessment of the skill level using technology and AI. That's another application. If that is going to happen, of course, there need to be trainer. There need to go. There would be required some kind of expert who would be actually monitoring those skill level, change of skill level in the medical college and all that. So that kind of investment is required, and that kind of technological orientation to the medical officer and expert has to be happen. So I think many of the audiences have a question. Maybe before we again ask any other question, we can open to the audience. If you yes, sir, from that side. I think he has raised the first hand. So maybe from right side, can somebody give a mic to me, and then doctor. Please introduce yourself and then just identify with whom you want to ask the question.
Hello. Yeah. Myself, Dr. Anna Babasu. I am from the country office of WHO. My question to the last speaker, Mr. Sharma, to use of GIS in mapping the health facilities. So, at the very best, there is the need of identifying the health facilities, especially the unorganized sector, the RNPs and RHPs, etc. If we are really talking about reaching to the service that is being delivered to the last people. So, how are we going to look into that? Because there are many places in Bihar where, say, if we talk about Diara or areas beyond the riverbed, there are communities where these people are there and still they are not very well connected with the regular geography. Identifying them and adding them to the existing list of providers, how are we going to do that? This is first, and second is, are we already building on something which is already there in Bihar? Because from 99 onwards, the polio surveillance project has been identifying this service providers across traditional and advanced way of treating people, and those list of practitioners are already there with each and every district immunization officer of this state. Are we building on that, or are we trying to, how are we going about that? These two questions. Thank you.
It's actually a great question, sir. I think recently WHO they withdrew support from VPD, vaccine preventable disease surveillance from Bihar. So WHO has actually trained very good people there, the field monitors. You know, they have licensed with the what we call Jola Chap doctors, and even जो informal sector में है, सबके साथ उन्होंने अपना मतलब बना के रखा है. So they are very useful asset जो I think government भी उनके साथ अभी मतलब काम साथ में मिलके कर रही है. So उनके साथ मिलके भी हम we are trying to understand what are the patterns there. अभी in this study we are also trying to do that, and we have like a field team spread across all the zones of Bihar, and them through their personal networks, their experiences, they are trying to connect to each and every informal sector people out there. So yes, I think this is what you was asking, right, sir?
First of all, I'd like to thank all of you, including Dr. Giridhar Babu and Dr. Ravi and Parpan and Danish, and Dr. Santosh for coming up with such a relevant discussion, and also the question-answer session, especially what Dr. Gupta asked. Based on that, I just want to drop a note there that good things occur commonly. It's all about balance. Atom से bomb भी बनता है, electricity भी बनता है. Usage किसका ज़्यादा हुआ है history से. So probably the kind of things that technology can do, the good things will occur more. If you come from the next गोलंबर जो इधर बोला जाता है, you will find some नारियल पानी बेचने वाला जिनका QR कोड में after taking one नारियल पानी you can pay 40 rupees. So ultimately affordability probably is not that issue. We need to look at technology beyond only servers and satellite dishes. I have a question for Dr. Giridhar Babu. I am Dr. Tanmay Mahapatra from Piramal Foundation. Dr. Giridhar, long before life course epidemiology could be discussed in a length as you discussed today, you and I, used to discuss about user-driven healthcare. Nowadays, also in the country where we are, as I just gave the example of 40 rupees Nariyal Pani, we all are user of digital platforms. When we will start taking care of our health using digital platforms, instead of being driven PHR, EHR and everything being driven by hospitals and doctors? Over to you.
Dr. Babu, are you there?
Yeah, I'm here. Can you hear me?
Yes, yes.
Yeah, I could partly hear what Dr. Tamay was saying. Can you please rephrase if there was a question that I missed?
Yeah. Hi, Dr. Giridhar. Can you hear me now?
Yes.
So I was just saying, long before life course epidemiology could be described in the way you described today, we used to discuss about the user-driven healthcare. When the Indian citizen in digital India are going to take care of their own health using the digital platforms, that they are using at least for gutka or nariyal pani nowadays? Over to you.
Yeah, thanks, Dr. Tanmay. I think this is a brilliant question which keeps us rooted all the time, and especially those who are working in public health. We feel let down, mostly because when we are saying health is important, why is that policymakers not taking this note? Why are people not responsible? And it has led to several discussions that we used to have before, and it has always been the bone of contention for every public health professional. But the way I see it is, unfortunately, a smoker will quit smoking after having a myocardial infarction. But it's too late for them to know, and cancer incidence increasing is affecting many families to know what the ill effects are. Now, while we say that this health is responsibility of everybody, we need technology as an enabler to disseminate this information. There's enough knowledge, but how do you convert from knowledge to behavior at the individual level, at the level of family? And one of the biggest drivers I see is the healthcare expenditure. If you are not already poor, the number one reason for becoming poor for middle class is healthcare expenditure. And I'm not saying it in a negative way. It's because we are not preparing for health as a responsibility, both in terms of finances and also in terms of healthy behavior. I think the time has come now, at least the use of technologies, wearable apps which measure our steps to everything in health. The next revolution has to be towards how do we convert knowledge into behavior, what are the actions that can be done at the individual and community level. There are no quick fixes or easy interventions. I wish I had known of any, but this has to be locally rooted, contextually relevant, and evidence-based, and that's why we are all making this effort. But yeah, your questions make me reflect more than have any answers all the time.
Dr. Babu, I think I also have a subsequent question, having your expertise and experience in that. What do you think is the, early life factor you think is currently overlooked in public health planning, especially in context of AI? And
if I rephrase your question, what are the early life interventions that we can do?
Yes.
For a longer, okay. There are plenty. I'll just begin with one of my favorite intervention not yet implemented. We keep complaining there are multiple micronutrient deficiencies in women, and as a result of that, women suffer through pregnancy, and we know very well that this is actually affecting not just her health, her adverse health outcomes in pregnancy, but also we have tons of evidence from India which say that this is putting at higher risk for children in terms of growth trajectories and development trajectories being affected. One simple intervention that can be done, if you look at CNNS, a recent survey, there is a high degree of triple burden of nutrition in as early as teenage. So this is the biggest window for me as a researcher. If we can map these deficiencies, and if we can intervene even before the woman becomes pregnant, we have actually interrupted at least one cycle of malnutrition-led illnesses. At the same time, I feel our culture of being physically inactive, nearly half of Indian population is physically inactive. Now, the earliest opportunities our schools, even preschools, if we can promote, not just promote for the sake of promoting it, but if you see how the other countries are changing their habits, country like Brazil, which has been converting from a fat-based, fat-oriented culture towards a healthy culture where things are possible. We need to start being more physically active, and that can start very early on in childhood. And the third aspect, I can go on with the big list, but the third, which is more important, is We are all affected by stress in some or the other way. And our coping mechanisms for stress are mostly unhealthy. If we can inculcate how to handle stress scientifically earlier on, again, this is another intervention which will have a long-lasting life course trajectories of improving health.
So I think we have one more question from the audience, but I just, as a follow-up question to this, where you said that the early childhood malnutrition and then obesity, I think that again may require that having an integration of the data set. So right from early mother's data to child data, personalized data, and this, so that how it is possible. And there are like apps also available. Everybody has their data and all that from mobile and all. You can do it, but then as Dr. Tanmay, you said that the ethical issues, people are not comfortable in sharing their information on that. So these are the challenges. What is your opinion about that?
Yeah, I think this is a great question again. With some of our collaborators in Netherlands, Maastricht University, I can only give you an example of how this was implemented. Of course, the foremost requirement is how do you integrate data, which is very important. And we need to be looking at ethical, transparent, anonymized data set which is confidential. All of that is the requirement. This is what I told even in my presentation. But when it comes to making impact in health, I can give you example from Maastricht University. They tried a wearable device in children and they incentivized it. You're all familiar with PUBG and all the other apps which promote physical activity in children. Here what they did was, every step taken would be converted into points, and those points they could encash it either for healthy meal or even some marks that are part of their scorecard, and many incentivization that occurred. And they showed that kids adapt technology faster, and the parents readily agreed, and it showed reduction in obesity and stress levels in the children. Now, can't we do this in India, especially when we are seeing the children are being addicted of a screen? Can't we use the same tool as an enabler for initiating healthy behavior? Yes, we can. But we need few models, 1 or 2 models here and there. If they get the traction, we can scale it up. But if anywhere it can be done faster, I feel it's in India. There's only inertia. There are a lot of challenges. But given the digital push given by Government of India and several other state governments, we also have perfect opportunity. It's just the industry coming together with the academia to be able to do this. What we need is those stronger collaborations. And again, the bone of contention is prevention is nobody's baby. Everybody wants where is the money, and there is not much money in the prevention for the industry to make. But if you see in terms of the long-term impact, we are adding more and more economic expenditure to the country. We are saying we have the demographic dividend, but growing NCD burden is only making us as sicker elderly population. And this is again economically beneficial if we can change it.
Thank you so much. I think you are right basically that we need to have so we need to have a kind of small pilots and so which can be implemented, and then people will take up. And Dr. Tanmay, I think this is something you can take up, because in 2007 I did for Piramal Foundation in their hometown. They started this mobile app-based, home-based care, telemedicine and all that. So maybe such kind of thing can be taken up and at large stage can be implemented. So I have another or somebody from audience want to take a question. Please introduce yourself and identify whom you want to ask the question.
Hello, sir. I'm Dr. Harsh Shah. I am faculty at Indian Institute of Public Health, Gandhinagar. I've been working in digital health and AI applications since last 4 to 5 years. My questions to Dr. Ravi sir. Since last 15 years, there are NASCOM reports recently suggested that there are almost 86,000 plus AI-related patents have been registered. And none of them, only 2 to 3% went as the public health goods. Similarly, if you see the CDSO reports, there are the applications that are suggested as medical device. Mostly comes at the class A and class B, low risk groups. Most of them, they are from the private sector only, not from the government sector. So my question is to you and to all of us to rethink also that what steps the government or as a public health sector needs to be taken to invest in such kind that we can create large number of public health groups. That's the first. And what we should do as a public health professionals apart from advocacy to the private sector, that those access issue that Dr. Ashmita ma'am suggested, that access to the common people can be availed easily. So these two aspects, how do we address?
Okay, I'll try to answer. A little difficult for me, but anyway, I'll try to answer. The second part first. See, private sector has got one thing very easily, anything where, you can show that there is a money, private sector will run without any exception. So you have to create a model when, end of the tunnel, they are not, end of the tunnel, whatever long tunnel it is, if you show that there is some gain, somebody will come and they will start investing. That's not that everybody knows. I don't think, some timeline, some specific things, some interventions will happen, and some or other private player can come. The difficult question is how the government gets motivated, apart from advocacy. That's probably Asmita or the guys who are doing it day in and out will be, more apt people to answer rather than me, because that's a large question, and it's more individualized. If I see from their point of view, when the government comes, there is a policymaker, the head of the department probably. When we interact and I am trying to explain and he understands the wavelength, it's probably easier to get implemented. When there is in the same chair, there is another person when he comes and I try to say the same thing the way I had told to the previous one, the next guy just, will trash. And, now just person has changed, individual has changed, but the response is absolutely, opposite direction. So in that scenario, when you raise a larger questions, I think they start forcing different things like how much the cost, what is there for him, and they are not. It's not easy until and it comes from some of their targets, which has come from one of the directives, probably from central government or in their plan. It's not easy. So maybe you have to woo probably policymakers in terms of political leadership. Probably then it's get easier. But then the administration get motivated to get the things done. This is my take actually. Nothing scientific about it, but this is how practically it happens in today's world, and this is how it's happening. Ashmita ji and you guys are interacting more than me, so you can answer more on this front.
We can see the investment that every budget has been made to the health department. If we consider those areas and also the ROI of major hospitals, government part is only 30% that are investing every year. So first thing is that I understand that we need to build DPI, digital public health infrastructure. But simultaneously, what Bihar is doing, what Gujarat is doing, what Himachal is doing, there are lots of silos interventions, and they are not being made as a public health goods. I am talking about GitHub library, where you can have the codes directly, so anyone can develop by themselves. So that is not being seen in government, but I have seen that whatever the Yashoda had created, the Krishna has adopted directly, irrespective of that the challenges or the investment. So that's buzzing me somewhere, that why that is not happening in the everywhere.
Thank you so much. I think it's a very important point you made. No, one reason is that we don't have any kind of inventory of who is doing where. So in fact, I remember Dr. Mashelkar, who happened to be the chairman of Indian Innovation Center. He is trying to do that, inventorize all the things which is happening. And they also need to, that we were talking about inventorizing the startups also. Because many apps, AI-based apps, which improves the efficiency, effectiveness, and efficacy of the care, and including public goods also, they are in silos, and people start looking at the same thing in different places. So there is a duplicity of that, and definitely we need to have inventory. So that the other aspect, I just as a closing note, I will say that everybody has an idea, and then they start working on that without realizing that its idea is okay, but whether there is a requirement or not, whether there is actual value being created in the system or not. If it is private sector, public sector, but without matching the actual value, people start creating an app and they just make it, and that's the reason it may not be scalable in long-term time. So with this, I think, ladies and gentlemen, thank you very much for being a patient, giving us a kind audience, and such an engaging. So we will not take the questions. So maybe you can interact with our expert of this session. So thanks again. Thanks to the organizers for giving us the chance, and it was really engaging thing. So Dr. Girdhar, thank you for coming over and having your such a experience kind of knowledge sharing to the audience. It was wonderful having all of you in this session. Thank you once again. Thank you all.
Thank you.
Now, we would like to extend our thanks to our speakers and our chairs. Sir, please come on the stage to give mementos to our speakers, sir. Thank you, sir. Now we will proceed with the felicitation of our speakers and our chair, Dr. Santosh Kumar Pandey, sir, and Shri Prakash Kumar, sir.
We begin by extending our sincere appreciation to Dr. Giridhar R. Babu, sir, who joined us online. Thank you, sir, for taking out your valuable time to be a part of this conference. For the felicitation, may we kindly invite Shri Prakash Kumar, sir, to felicitate Dr. Ravi Shankar Singh, sir. Thank you, sir. Now, I would like to call Dr. Santosh, sir, to felicitate Dr. Arpan Sharma, sir. Thank you, sir. Now, I would like to call Dr. Santosh, sir, to felicitate Mr. Danish Razdan. Thank you, sir. And finally, I would like to invite Dr. Maushami Gupta, ma'am, to kindly felicitate the chair of our session. Ma'am, please felicitate Shri Prakash Singh, sir. Prakash Kumar, sir. Ma'am, kindly felicitate Dr. Santosh Kumar Pandey, sir.
Thank you everyone for this wonderful session. Since we were discussing regarding disease surveillance, it's my privilege to invite Dr. Sanchita Mahapatra ma'am as she was leading the CHP team at ADRI.
Good afternoon, all. It's my absolute privilege on behalf of ADRI to welcome you all. And since morning, we have been talking lots about digitalization in health, and we also heard in this session about the disease surveillance and Bihar's journey from paper to portal. I'm extremely privileged to have with us Dr. Ragini. She is the state epidemiologist who has been leading the surveillance for Bihar. I would appreciate if Dr. Ragini can come and join us on the stage to share her experience in working in Bihar for the disease surveillance. Thank you.
States went far away from us, and they were performing quite well. And in that period, I do remember, because for long time we could not find even a single developmental partner, because IDSP was considered as something very small among all the national health mission programs. And then suddenly one day, Dr. Sanchita came to me. And she was the first person, who had conversation, and she told that she wanted to work on disease surveillance. And I was the happiest person, because I could not find any person to whom I could correlate or ask for any kind of help, because we had to do with our team at the district level and at the state level. So this is how, and she was very responsive. Whatever, I had requirements or whatever thought process I had, she connected very well. And I'm extremely thankful to the ADRI team, because the value has been added. Like, nobody is perfect. We all know, and we have our strengths and weaknesses. And just a week before, in the same hall, there was AI training in the IT sector. And ADRI was not part of that. So, like we say, we all have our strength, but we are not connected to each other. I think this is one of the platforms where we can, in fact, plan how we can improve our intersectoral and intrasectoral convergence, so that we can actually have some outcome that will be sustainable. Otherwise, if you organize training or conferences, people come, listen, and they will go. So, there should be sustainability. Whatever learnings are there, that should be long time implemented and embedded in the program, so that we can have some output. Already Arpan made the presentation on IDSP and also the private sector, because at present we are ensuring reporting from 10,000 government health facilities on daily basis in our IHIP portal. that is through our system. Many districts have added private reporting units as well, but those are scattered. And what happens at the national level, there's a state ranking. And the more reporting units you have on the portal, and if they perform inconsistently, your ranking gets down. So that was also apprehension among all the districts. But however, we could manage with the center, and they have removed this criteria, like inclusion of private reporting units in the portal. That has been temporarily shut down for ranking at the national level. So we can add district officials also here. And I've always been saying that, in fact, the true unsung heroes of NHM are our epidemiologists. And we can applaud for ourselves because this platform has been given to us. And we have made at least a mark at the national level for which we all need to be appreciated. So we can clap for the performance of the IDSP team. And also because Sanchita had got officials appointed at her level and linked with all the districts. So follow-up was, I think it was very much helpful to all the districts. And I support, right now, private sector mapping, she has already shown that that is a very commendable job that has been done. And it will definitely help because among all the national health programs, we have the mandate to to do surveillance of more than 35 plus health conditions and those communicable and epidemic and outbreak prone diseases. So we have the largest mandate among all the national health programs, and we do hope that we ensure 100% reporting. Right now from government health facilities, there are few private reporting units, but we need to expand it, and I think these data will be very valuable for us because the early we detect any disease will be able to respond well. Now on this note, I would just, because lunch is waiting, I think, so I will request on the basis of performance, we can take a few words from the two districts. One is Jahanabad and another is Purnia. I would like to request first Alok, can you come up and just share your experience, what efforts have been put up and how private sector kind of things we are working on and how do we plan to move ahead.
थैंक यू मैडम, थैंक यू ऑल ऑफ यू। हमको ये चांस मिला कि मैं अपने शेयर कर सकूं कि क्या आईडीएसपी का क्या जर्नी है और आईएचआईपी के बारे में और साथ ही आदरी टीम के बारे में भी। तो जब आईएचआईपी जब स्टार्ट हुई थी, मैडम ने बहुत कुछ बता दिए स्टार्टिंग में। तो कोविड पैंडेमिक आ गई, तो हम लोग उस टाइम में सिर्फ एक ही योजना चलती थी, कोविड। कोई मैटरनल हेल्थ नहीं, आरसीएच नहीं, ना सर्विलेंस, सिर्फ ओनली सर्विलेंस कोविड। कोविड पर ही जितने भी डिपार्टमेंट थे सब फोकस्ड थे और हम लोग भी कोविड में ही लगे हुए थे। कोविड के बाद 2022 उस समय स्टार्ट हुआ, आदरी के टीम के द्वारा भी हम लोग को फैसिलिटेट किया गया और टीम के द्वारा एक जो अपॉइंटमेंट की गई वो, और हम लोग मैडम का जो हर टाइम वीकली जूम मीटिंग होती थी, उस जूम मीटिंग में क्या है, स्टार्टिंग हम लोग को जब स्टार्ट हुआ था कि हम लोग न्यूमेरिक डाटा रिपोर्ट करते थे, जो ब्लॉक लेवल टू सब सेंटर लेवल या डिस्ट्रिक्ट लेवल। अब जो डाटा जो स्टार्ट हुई, जैसे मैडम बताया कि कोई भी डाटा को कि आप ARI का रिपोर्ट, एक्यूट रेस्पिरेटरी इन्फेक्शन का रिपोर्ट अगर 50 लिख दिए तो 50 का वैलिडेट करना संभव नहीं हो पाता था। तो हम लोग ने लाइन लिस्टिंग डाटा और डेली डाटा जो वीकली होता था वो डेली, तो जस्ट इमेजिन लगा कि हम लोग पेपर से पोर्टल पे आ रहे हैं। और पोर्टल पर आने के लिए हमारे पास सबसे एक जो ड्रॉबैक है आईडीएसपी का, हर डिपार्टमेंट का सेंट्रल लेवल, स्टेट लेवल, रीजनल लेवल, डिस्ट्रिक्ट लेवल, ब्लॉक लेवल, इवन की पेरीफेरी लेवल, हर जगह पे HR अवेलेबल है, एक्सेप्ट IDSP। उसका 3 ही लेवल पे अवेलेबल है, सेंट्रल, स्टेट एंड डिस्ट्रिक्ट। अब डिस्ट्रिक्ट में भी मात्र कहीं पे एक HR, कहीं ना कहीं एक है, कहीं 2 है, कहीं कुछ भी नहीं है। अब उस परिप्रेक्ष्य में इसको 100% क्वालिटी एंड क्वांटिटी, ये दोनों पे बात करने के लिए कुछ तो इमेजिन लगा, और डेली रिपोर्टिंग। तो उन्होंने आदरी टीम के द्वारा शुरुआती दौर हम लोग क्वांटिटी पर बात करने लगा कि स्टार्टिंग तो हो, हैंड होल्ड किए, जैसा कि डेटा में पिछले सर के द्वारा बताया गया कि ANMs हुए, डॉक्टर्स हुए, और कई सारे ऑफिसर्स को ट्रेनिंग दिया गया, और इसका फ्रूटफुल भी बताया गया कि इससे क्या फायदे हैं। अगर डेली रिपोर्टिंग होगा तो उससे फायदे क्या है, क्या अलार्मिंग आएगा, क्या आउटब्रेक का इनपुट आएगा। तो ये सब चीजें जब हम लोग स्टार्टिंग किए तो 5%, 10%, 90%, उसके बाद कंटिन्यू हम लोग करते गए। और वो परसेंटेज के बाद मैं बताना चाहूँगा, बड़ी गर्व के साथ कहना चाहूँगा कि ऑल ओवर इंडिया में अभी पोर्टल पर जो IHIP का पोर्टल पर जो डिजीज सर्विलेंस हो रही है, कश्मीर से कन्याकुमारी तक 773 डिस्ट्रिक्ट का पोर्टल पर जैसा कि शो करता है, उसमें मेरा अपना जहानाबाद की मैं बात कर रहा हूँ, कई बार 1, 2, 3 रैंक में रहा है, इंक्लूडिंग नेक्स्ट मंथ भी। तो एक चैलेंज है बिहार में के लिए, 24 में भी हमारा 1 to 5 रैंक में रहें। तो ये बिहार के परिप्रेक्ष्य में, और बिहार को लोग इस ढंग से सोचते, या लोग सोचते थे कि कभी भी होता था, तो बिहार में तो ये इम्प्लीमेंट नहीं होगा, मगर बिहार ने ये इम्प्लीमेंट करके दिखा दिया और बेस्ट करके दिखा दिया। अब हम लोग क्वांटिटी तो ला दिए, अब क्वालिटी की ओर आ रहे हैं। क्वालिटी के साथ साथ प्राइवेट रिपोर्टिंग, हम लोग अभी भी प्राइवेट रिपोर्टिंग जो 22 में हुआ था, या हम लोग कर रहे थे। मेरा जो डिस्ट्रिक्ट था वो पायलट डिस्ट्रिक्ट में था, तो लिस्ट रिपोर्टिंग जैसे कुछ जो सिलेक्टेड हैं हेल्थ इंस्टीट्यूशन, उसी को हम लोग रिपोर्ट में ले रहे थे। मगर फिलहाल जो अभी 2025 में जो सर्वे आदरी के द्वारा किया गया, उसमें लैब कितने हैं या जो भी हैं, अच्छा खासा मार्क आया। हम लिस्ट तो हम ही लोग दिए, मगर उसका जो एक परफॉर्मा था, उस परफॉर्मा में फिट बैठता है या नहीं, क्या इसको रिपोर्ट में लिया जा सकता है नहीं, वो सभी हुआ है और हम लोग इस पर वर्क कर रहे हैं। और शायद जो 26 आएगी 2026, वो आदरी टीम के साथ, मैडम के साथ, या हमारे जो टीम है या हेल्थ वर्कर हैं, कई सारे प्रोग्राम भी आ रहे हैं, उसमें 100% कोलैबोरेशन की बात करेंगे, प्राइवेट, गवर्नमेंट एंड कम्युनिटीज। थैंक यू।
जैसा मैंने बताया कि ऑलरेडी 3 पोस्ट डिस्ट्रिक्ट लेवल पे सैंक्शन है, एपिडेमियोलॉजिस्ट, डेटा मैनेजर एंड डेटा एंट्री ऑपरेटर। तो कहीं पे डेटा मैनेजर्स के हमारे मोर देन 50% सीट्स खाली हैं। उसी तरह डेटा एंट्री ऑपरेटर तो आउटसोर्सिंग से हम लोगों ने दे दिया, बट अगर स्ट्रेंथ वाइज रहता है, क्योंकि इनके भी बहुत सारे ब्लॉक्स हैं जिनको मॉनिटर करना है, तो और अभी एपिडेमियोलॉजिस्ट का भी क्या है कि आई थिंक उसके भी मोर देन 50% सीट्स वेकेंट हैं। तो उस केस में क्या है कि जो ऑलरेडी डिस्ट्रिक्ट में किसी और को डेप्यूट करके चार्ज दिया हुआ है, तो एटलीस्ट वी हैव someone in deputation, but the seriousness we cannot actually when we have our own team, it's better, it gives better performance. This is the challenge.
Right. So I mean, since in this latest elections now the focus of the government is generating, I mean they have at least announced that they will be increasing jobs, तो उनके own मतलब सेक्टर में जो वैकेंसीज हैं, we can maybe highlight that to the top leaders
Definitely, I will tell the last recruitment that happened because we came in 2009. Then in 2014, vacancies came, and then during COVID, only due to COVID at that time, no vacancies were advertised except for IDSP because it was being reviewed by the Prime Minister of India. So everyone knows here also what is the gap. And I think basically what I have witnessed in State Health Society Bihar, whatever is politically pursued, recruitments of those programs or cadres basically happens, and the rest programs are basically kept hanged. This is the challenge that we are facing, but we are hopeful that they do recruit all the staffs under NHM of all the programs, and we are able to deliver them.
एड ऑन करना चाहूँगा। HR चैलेंज है, एक मेजर चैलेंज है जो हम लोग को मतलब सर्विलेंस के लिए है। जिस तरह से आज बताया गया है कि जो थीम भी है कि इंफॉर्मेशन टेक्नोलॉजी हेल्थ में, उसमें कई सारे पोर्टल बने हुए हैं, कई सारे एप्लीकेशन हैं, कई सारे पैरेलल एप्लीकेशन हैं, और इम्प्लीमेंटिंग बॉडी एक है, चाहे वो सब सेंटर लेवल हो, PSC लेवल हो, या मेडिकल कॉलेज लेवल हो, या डिस्ट्रिक्ट हॉस्पिटल लेवल हो। यहाँ पे एक चर्चा अवश्य होना चाहिए, या एक ऐसा इनोवेशन होना चाहिए कि इंटीग्रेशन की बात, अगर एक मेरा डेटा ऑपरेटर या एक HR या एक मेडिकल ऑफिसर अगर इस चीज में अगर डेटा डालते हैं तो वो निश्चय पोर्टल पर भी दिखे, IHIP पोर्टल पर भी दिखे, वो भव्या पर भी दिखे, वो कई और सारे पोर्टल है जैसे में कामिस हो गया, या और सारे पोर्टल जो है उसमें उस पे दिखे। अब एक ही डिजीज को, जैसे में अभी निमोनिया का सर्वेलेंस, ARI का सर्वेलेंस चल रहा है, तो अब क्लाइमेट चेंज एंड ह्यूमन हेल्थ वो बोल रहे हैं कि एयर पॉल्यूशन का अलग से आप एंट्री करें, तो ये कहीं ना कहीं डेटा हैंडलिंग में भी इशू आएगी, कहीं ना कहीं डेटा का जो मैचिंग की बात आएगी। हमेशा हम लोग डेटा मैचिंग करवाते हैं या डेटा एनालिसिस कराते हैं, तो उसमें एक फॉर्मल बनेगा और एक मतलब सही डेटा हम लोग इंटरप्रेट कर पाएंगे, और उससे क्या होगा कि ये चैलेंज अभी भी बरकरार है। जैसे में IDSP का डेली रिपोर्टिंग है, अब IDSP का भी रिपोर्टिंग वो लड़का कर रहा है, और वो भव्या पर भी कर रहा है, वो निश्चय पोर्टल पर भी कर रहा है, वो लैब पर भी कर रहा है, वो हर जगह, मतलब हर जगह एक HR लगे हुए हैं। तो ये इस इंटरनेशनल कॉन्फ्रेंस के माध्यम से मैं मतलब एक मेरा फीडबैक है कि ऐसे चीज पे वर्क किया जाए, क्योंकि IT है, AI का मतलब अभी एरा चल रहा है कि मैंने अगर अंक अगर हम एक पोर्टल पर डालें, इंटीग्रेशन की बात करें, तो वो जो भी स्टेक होल्डर हैं, अगर उसको एक अंक से जरूरत है तो वो अपना वो उस पे सेट हो जाए। तो थैंक यू मैडम, ये एक चैलेंज है जो ग्राउंड लेवल चैलेंज है। थैंक यू।
थैंक यू आलोक।
Can I ask? Okay. Myself, Dr. Basu from WHO country office. Just since you already talked about this integration, just a suggestion, because for my public health journey started from Bihar in 2010, so I have some connection with this state. Regarding the surveillance thing, there is already one data set that is available in each district of this informal network. The network is as good as it is nurtured. For government network, you can just guide them and you have that authority to get the information from them. But the private practitioners who are out there, unless there is a continuous dialogue with them, a continuous interaction with them, the network very easily falls silent.
For private?
मतलब वो शांत हो जाता है, उधर से कोई इंफॉर्मेशन नहीं आती है।
प्राइवेट की बात कर
रहे हैं? प्राइवेट की जो बात कर रहे हैं, क्योंकि हमारा इनसाइड एम्बैंकमेंट एरिया या फिर थोड़ा हार्ड टू रिच एरिया, ये सारे जो हैं जहाँ पे काफ़ी सारे लोग बैठे हुए हैं लेकिन हमें उनका खबर सब समय नहीं आती है, तो उनका इंफॉर्मेशन लाने के लिए ये वहाँ के जो नॉन फॉर्मल प्रैक्टिशनर्स है या प्राइवेट प्रैक्टिशनर्स है उनसे इंफॉर्मेशन लेना ज़रूरी होता है। तो वो उन लोगों से कनेक्शन हमारा कितना अच्छा बने रहे, रेगुलर डायलॉग चल रहा है या नहीं, उसके ऊपर निर्भर करता है कि मतलब हमारा इंफॉर्मेशन बेस कितना स्ट्रांग होगा। जस्ट अ सजेशन, जस्ट एज वी आर ट्राइंग टू इंटीग्रेट थिंग्स, वन ये एक प्लेटफॉर्म बना था गवर्नमेंट ऑफ इंडिया से पूरे देश के लिए, आई एम नॉट श्योर वो इंफॉर्मेशन कितना मतलब वो प्लेटफॉर्म कितना एक्टिव है, दैट इज कॉल्ड डिस्ट्रिक्ट वीकली रिव्यू मीटिंग और DWR, जहाँ पे अलग अलग जो सर्वेलेंस सिस्टम्स है, एक IDSP की तरफ से थे, एक RCH की तरफ से है, तो ये दोनों सर्वेलेंस सिस्टम एक साथ बैठ के अपना डेटा शेयर करने की एक प्रोसेस था। तो आई डोंट नो हाउ एक्टिव दैट इज वन वे ऑफ लुकिंग एट इट, यूजिंग द एग्जिस्टिंग सर्वेलेंस नेटवर्क, उसका जो लिस्ट है वो भी हम देख सकते हैं अलॉन्ग विथ whatever newer list that is getting generated, तो integrated हो list or rich हो। और third, if it is possible in some way to prepare a mechanism ताकि वो जो private practitioners या private information network जो बने हैं उनके साथ local level पे continuous dialogue चले। These three things I think might help. Just a suggestion.
Thank you. Just to update you, because the transitioning of VPD is already happening from WHO to IDSP. So this time I had proposed budget for VPD surveillance, and since mapping of all the rural medical practitioners, as you were telling, is already here. We have the data set. So for their sensitization and regular sensitization, we have made budget, budget proposal, and we are hopeful that once we receive the budget, we will be holding regular meetings with all the concerned and stakeholders and functionaries, and we will try to implement whatever you have suggested.
Thank you so much, ma'am. Actually, Bihar has really showed that it has that surveillance can happen here, which is world class, because previously we have seen multiple people across the globe coming here to understand how surveillance works at the ground.
Yes.
So I'm really sure the team that you have is the best in that country, and you'll definitely make it. Thank you so much.
Definitely. Thank you so much. Okay, very, very short time we have. We can have few words from Purnia district. These basically many epidemiologists from many districts have come, but we have a time constraint as well. And based on the performance, they are in top 5 and under top 5. So we can have listen to their good practices.
Thank you, ma'am. सम्मानित सभी आगंतुक सज्जन, मैं डिस्ट्रिक्ट एपिडेमोलॉजिस्ट नीरज कानेवाला पूर्णिया। मैं IDSP के जर्नी के बारे में जो मेरा अनुभव है वो अभी आप लोग के साथ शेयर करना चाहूँगा। सबसे पहले जब मैं 2012 में IDSP ज्वाइन किया था, उससे पहले मैं यूनिसेफ में एज ए कंसल्टेंट काम करता था। उसके बाद मुझे अपॉर्चुनिटी मिला एज ए डिस्ट्रिक्ट एपिडेमोलॉजिस्ट इसमें काम करने का। उस समय वीकली रिपोर्टिंग होती थी जो पेपर बेस्ड होती थी। उसमें वीकली रिपोर्ट HSC से ANM करती थी और वहाँ से आता था डिस्ट्रिक्ट सर्विलेंस यूनिट को। डिस्ट्रिक्ट सर्विलेंस उसको फिर पुट अप करता था पोर्टल पे, तो वो काफ़ी लेट होता था। मतलब एक सप्ताह बैक रिपोर्ट मेरे पास आया, फिर हमने पोर्टल पे चढ़ाया, फिर वो डाटा एनालिसिस हुआ, तब फिर हम एक रिकॉग्नाइज कर पाएंगे कहाँ डिजीज का सिचुएशन क्या है। लेकिन जब IHIP पोर्टल लॉन्च हुआ और उस IHIP पोर्टल को इम्प्लीमेंट करने के लिए हमारी आदरी की टीम, उससे पहले हम लोग 2019 से ही इस पे काम कर रहे थे। प्री कोविड नहीं आया था, उससे पहले भी एक हम लोग का ट्रेनिंग हुआ था जो हमारी रागनी मैडम है, इन्हीं के साथ इनके इनिशिएशन से ही हम लोग शुरू किए थे और ग्राउंड लेवल पे भी काम शुरू किए थे। लेकिन कोविड आने के बाद ये थोड़ा रुक गया, थोड़ा क्या पूरा ही थम गया था। आफ्टर कोविड जब फिर आदरी का इसमें इन्वॉल्वमेंट हुआ तो बहुत अच्छा सहयोग हम लोग को मिला और संचिता मैडम का भी कुछ फील्ड में जा करके इन्होंने रिसर्च किया था, वो भी पब्लिश किए, हम लोग के साथ शेयर किए। उसके बाद जब हम लोग हैंड्स ऑन ट्रेनिंग देने लगे अपने हेल्थ वर्कर को, चूँकि कोई नया इनोवेशन जब होता है, कोई नई चीज़ आती है, तो लोग उसका बहुत सारा नेगेटिव फीडबैक निकालना शुरू कर देते हैं कि ये आप रियल टाइम डाटा लेंगे, प्रत्येक दिन कैसे पोर्टल पे एंट्री होगा, संभव नहीं है, रिमोट एरिया में काम कर रहे हैं, वहाँ पे नेटवर्क का इशू होगा। लेकिन हम लोगों ने इसको चैलेंज के रूप में लिया कि इसको करना है और 100% करना है। तो हम लोग 2021 से इस पर फोकस्ड होकर के काम करना शुरू कर दिए। जब इस पर फोकस्ड हुए तो हमारे यहाँ 481 सब सेंटर अभी फंक्शनल है, जो कि ग्राउंड लेवल पे काम हो रहा है 481 में, और 25 लेबोरेटरी है जिसका कि IHIP पोर्टल पे रिपोर्ट हो रहा है। पहले तो दिक्कत हुई, सबने बोला कि प्रत्येक दिन रिपोर्ट नहीं होगा। फिर मैंने डेली उन लोगों को फीडबैक शेयर करना शुरू किया। जब ट्रेनिंग हो गई, हैंड्स ऑन ट्रेनिंग मैंने दे दिया, जो वीक पॉइंट था उसको आइडेंटिफाई किया कि इनके स्तर से ज़्यादा परेशानी हो रही है, उनको आइडेंटिफाई किया। फिर उनको प्रत्येक दिन मैंने यहाँ से फीडबैक डिस्ट्रिक्ट में 3 बजे का मैंने समय निर्धारित किया कि 3 बजे तक जिन लोगों का नहीं हुआ है, क्या इशू आ रहा है, उनको देखना चाहिए। तो ये 3 बजे का जो मैंने प्रत्येक दिन फीडबैक देना शुरू किया, इसका इम्पैक्ट ये हुआ कि मेरा रिपोर्टिंग विदिन 3 मंथ्स 100% सभी सब सेंटर से आना शुरू हो गया। तो एक चैलेंज तो होता है किसी नए चीज़ को इम्प्लीमेंट करने में। जैसे अभी AI के बारे में ही सर बहुत कुछ बताया कि इसका बहुत खूबी भी है तो खामियां भी है, लेकिन उस चैलेंज को हम लोग को पार करना पड़ता है। इसी सिलसिले में एक स्टोरी मैं शेयर करना चाहूँगा। एक वीक का ट्रेनिंग के लिए हम लोग कोलकाता गए हुए थे। वहाँ पे सेंट्रल टीम से ही आए हुए थे एक ट्रेनर, कोई कुलकर्णी सर थे। तो वहाँ बिहार से भी 4-5 पार्टिसिपेंट थे, उसमें मैं भी था। तो उन्होंने IHIP पे ट्रेनिंग देना शुरू किया। और एक चीज़ जो मैं आप लोग से शेयर करना चाहता हूँ, कुछ आउट ऑफ बिहार के जो कुछ होते हैं, उनके दिमाग में एक प्रीजुडिस्ड है, वो पहले से पूर्वाग्रह से ग्रसित होते हैं कि बिहार में इतना बेहतर कुछ नहीं हो सकता। तो उन्होंने जब वहाँ शुरू किया तो उस समय भी बिहार बहुत अच्छे पोजीशन पे था। तो उन्होंने रिकमेंड तो किया कि बिहार बहुत अच्छा काम कर रहा है, लेकिन उन्होंने एक क्वेश्चन खड़ा कर दिया कि इसकी क्वालिटी क्या होगी पता नहीं। ये चीज़ मुझे बहुत हट कर गया कि भाई इतना अच्छा काम मैं कर रहा हूँ, उसके बाद आप एक क्वेश्चन खड़ा कर। मैंने कहा सर, आप जो ट्रेनिंग दे रहे हैं आप अभी उसको स्टॉप कीजिए, आपके टॉपिक पे मैं ट्रेनिंग दूंगा। यहाँ जितने पार्टिसिपेंट हैं उसमें छत्तीसगढ़, बिहार, छत्तीसगढ़, कर्नाटका और नॉर्थ ईस्ट से के भी पार्टिसिपेंट थे। मैं सबको अभी ट्रेनिंग दूंगा। जो आप स्लाइड चला रहे हैं, मैं अपना स्लाइड चलाऊंगा, मेरे पास है। और जो भी क्वेश्चन आप लोग को इस पोर्टल से संबंधित करना होगा वो कीजिएगा, मैं एक एक बिंदु पे बताऊंगा। और मैंने फिर वहाँ उनको करके दिखाया। तो लास्टली उन्होंने कहा कि ऐसा मुझे नहीं सोचना चाहिए। मेरा आग्रह सबों से होगा, मेहनत सब कोई कर रहे हैं, आप उस पर क्वेश्चन कर सकते हैं, लेकिन वो उसके मेहनत को ये सोच लेना कि उसकी क्वालिटी क्या होगी। और इसका उदाहरण हुआ जब CRM की टीम की विजिट मेरे यहाँ हुई पूर्णिया में 2013 या 14 में CRM टीम मेरे यहाँ विजिट करी थी। मैंने उसको सब सेंटर ले जा करके एस फॉर्म, उस समय जबकि रिटेन आता था, मैंने उसको दिखाया और उस HSC के रजिस्टर से मैंने एस फॉर्म को मैच करवा के दिखाया कि यहाँ सर्विलेंस की क्वालिटी क्या है। तो सर्विलेंस की एक होती है। दूसरा, सर ने अभी WHO से बोले DWR की मीटिंग के लिए। सर DWR की मीटिंग वीकली होती है, उसमें हमारी डाटा हम WHO से शेयर करते हैं, लेकिन WHO की जो टीम होती है, मैं सर ये शिकायत के लहजे में नहीं कर रहा हूँ, जो आपका WHO का जो टीम है, जो वहाँ पे अभी आपका ये NPSP का नेटवर्क चल रहा है, उन लोगों को फील्ड में हमारे जो ANM रिपोर्ट करती हैं, वो या तो वीकली या डेली बेसिस पे वो डायरेक्ट IDSP यूनिट को शेयर नहीं करते हैं। उन लोगों की शायद शुरू से जब हम पल्स पोलियो देखते थे, पल्स पोलियो में उनका रिपोर्टिंग डायरेक्ट टू DM होता था। जब DM की मीटिंग हुई, उसी में जितना भी सारा एजेंडा रहा वो वहीं जाकर के शेयर करते थे, जबकि वो होना चाहिए कि हमको ग्राउंड लेवल पे या PSC लेवल पे पहले शेयर करके सॉर्ट आउट करें। तो वो शायद उसी ढड्डे में जब वहाँ DM की मीटिंग होती तो उसमें रखते कि यहाँ पे इतना मिजिल्स का आउटब्रेक हुआ, यहाँ इसका मम्स का हुआ, और वो डाटा हमारे पास नहीं होता। फिर हमारे ही एम्प्लॉय, तो फिर मैंने जो नेक्स्ट ईयर ट्रेनिंग किया, मैंने अपने एम्प्लॉय को बोला कि देखो आप जो भी रिपोर्ट करते हो फर्स्ट टाइम, चूंकि WHO चाहे जो भी डेवलपमेंट पार्टनर है वो हमारे सपोर्ट के लिए हमारे कलीग्स हैं, लेकिन उनके तरफ से रिपोर्ट आप पहले वहाँ जो इन्फॉर्म देते हैं तो वो मेरे पास आ नहीं पाता है। आप पहले मुझे रिपोर्ट करो, चूंकि एक्शन हमको लेना है वहाँ पे। WHO का एक मेंबर होते हैं जो फील्ड वॉलेंटियर होते हैं वहाँ पे, वो होते हैं, लेकिन हमारा लैब टेक्नीशियन है, हमारे HSC में NM काम कर रही आशा है, ये सारे के थ्रू हम वहाँ पे ये करते हैं। ये लेकनेस ऑफ कोऑर्डिनेशन हो जाता है। DWR की मीटिंग होती है, उसमें मैं जाता हूँ, और जो मेरा वीकली सर्विलेंस रिपोर्ट है मैं तो डेली वहाँ मेल करके शेयर करता हूँ। तो ये सारा जो अभी तक का उपलब्धि है, मेरा डिस्ट्रिक्ट भी टॉप 10 में टॉप 5 में पूर्णिया रहा है, और बिहार की उपलब्धि भी बहुत अच्छी रही है। तो उसमें हमारे जो ग्राउंड लेवल वर्कर हैं उसका बहुत बड़ा योगदान रहा है। दूसरा एक अभी इशू आ रहा था प्राइवेट प्रैक्टिशनर को जोड़ने का। सर हम लोगों ने प्राइवेट प्रैक्टिशनर के एसोसिएशन बना हुआ है, क्योंकि उन लोगों को कुछ एक सर्टिफिकेट का कोर्स चलवाया जा रहा है, तो उन लोगों को भी हम लोगों ने जोड़ा है, जिसमें हमको अभी प्राइवेट को जोड़ने के लिए आदरी का बहुत अच्छा सहयोग मिल रहा है। उन्होंने प्राइवेट हॉस्पिटल का एक अच्छा लाइन लिस्ट तैयार कर लिया है। सबसे बड़ा दिक्कत होता है प्राइवेट प्रैक्टिशनर को जोड़ने में कि उनके यहाँ रिकॉर्ड मेंटेन जो है वो सिर्फ एक स्लिप पे होता है, जो डॉक्टर देखते हैं एक स्लिप पे लिखते हैं पेशेंट का नाम कि आप फी लिए, उसके बाद उसका कहीं कोई इलेक्ट्रॉनिक ये नहीं है। तो 2-4 हॉस्पिटल मेरे यहाँ ऐसे हैं जिनके पास की ऑनलाइन रिपोर्टिंग का इलेक्ट्रॉनिक रिपोर्टिंग का व्यवस्था हुआ है, तो मैंने उनको भी जोड़ा है और वो लोग रिपोर्ट भी कर रहे हैं, चाहे वो लैब हो या हॉस्पिटल का है तो वो रिपोर्ट आ रहा है। तो हम लोग इस पर भी कोशिश कर रहे हैं, लेकिन आदरी के सहयोग से IDSP को, जैसा कि मैडम ने भी बताया कि हम लोग बिल्कुल अकेले थे, सिंगल मैन पूरा डिस्ट्रिक्ट में प्रोग्राम को चलाना था। उसमें आदरी का सहयोग बहुत अच्छा रहा, ट्रेनिंग में रहा, कुछ रिसर्च पेपर आया, उसके थ्रू हम लोगों ने लोगों को अवेयर कराया। तो मेरा मैम से आग्रह होगा कि IDSP को आपका सपोर्ट कंटिन्यूस मिलता रहे हम लोग को, एक तो बहुत ही अच्छा रहेगा। जैसे अभी AI पे हम लोग कन्वर्ट होने जा रहे हैं, तो उसमें भी हम लोग को मदद मिलेगा, हम लोग को भी ओरिएंटेशन ट्रेनिंग होते रहेगा। चूंकि ये बहुत कम बजट का प्रोग्राम है IDSP, हम लोग को फील्ड लेवल में भी उतनी बजट नहीं होती है कि मास लेवल पे हम जैसे जीविका हो और किसी को जोड़ करके ग्राउंड लेवल से इन्फॉर्मेशन गैदरिंग करें। तो उसमें हमारा आशा मेन रोल निभाती है, क्योंकि आशा फैसिलिटेटर को हम लोग हर साल ओरिएंट करते हैं, तो वहाँ से आउटब्रेक का रिपोर्ट हम लोग को आते रहता है। थैंक यू, मेरा एक ओवरव्यू था इसके ऊपर।
Thank you so much, Dr. Agni Mishra ma'am, Dr. Alok Kumar sir, and Mr. Neeraj Kumar Nirala sir for taking us through this wonderful journey. Now, I would request Dr. Ashmita Gupta, Member Secretary ADRI, to felicitate Dr. Agni Mishra ma'am. Now I request Dr. Alok Kumar to come on the dais for the felicitation. Now I request Mr. Neeraj Kumar Nirala sir to come on the stage for the felicitation. And finally, this brings us to the end of the technical session, and we request all the dignitaries and members of the audience to kindly proceed for lunch. We will be reassembled at 3 p.m. for the next session. Thank you, everyone.
privileged to welcome you back for our afternoon deliberations. Yeah.
Before beginning, we would like to extend our heartfelt appreciation to our sponsors and healthcare partners, Jai Prabha Medanta Super Speciality Hospital and Saint Diagnostics, whose support has been instrumental in making the conference possible.
Up next, we begin with the series of insightful panel discussion featuring eminent experts from India and across the world.
To begin our post-lunch proceedings, we present panel discussion 1, titled Digital Health Initiatives and LMICs Addressing the Digital Divide. The discussion brings together practitioners shaping digital health ecosystems.
We are deeply honored to invite Shri Ajay Kumar Singh to chair this session. Shri Ajay Kumar Singh is a distinguished senior journalist and former press secretary to the President of India, with more than 4 decades of leadership across reputed national media institutions, including the Economic Times, the Telegraph, the Pioneer, and Business Standard. His 6-year tenure at Rashtrapati Bhavan reflects his extensive expertise in public communication and governance. Sir, may we kindly request you to join us on the dais.
Up next, we invite our esteemed panelists for this conversation. Our first panelist is Dr. Tanmay Mahapatra, Director, Data and Learning at the Piramal Foundation, whose work in epidemiology, operational research, and systems trending has significantly contributed to India's public health landscape. Sir, may we kindly request you to join us on the dais.
Next, we welcome Ms. Pallavi Jain, Program Lead at Path India and Secretariat Lead for Youth. She brings expertise in human-centered design, ICT tools, and gender-focused advocacy, supported by academic training from LSE and USC. Ma'am, we request you to kindly join us on the dais.
Joining us virtually from Botswana is Ms. Mavis Motsegwa, a digital health and enterprise ICT specialist with strong expertise in IHRIS implementation, HRH systems, and digital governance. I request the team to kindly bring Ms. Motsegwa on screen.
Also joining virtually from Botswana is Mr. Tumisang Kulangano, Health Officer with the Ministry of Health, contributing to national digital health transformation efforts. AV team, please bring Mr. Kulangano on the screen. With this, we now request our chair, Shri Ajay Kumar Singh, to kindly lead the proceeding and take the discussion forward.
Hello, am I audible? Okay. So, shall we start it straight away, or Tanmay, you want to present something, or so shall we start it right away? Yeah. Okay, Pallavi. So we will start it straight away. I mean, instead of me speaking on something, so at the end I'll summarize it. Tanmay ji, if you start it, then it will be better.
Thank you. I'll just try to use the mic because I may be referring to this at times. So it will be good to have the presentation on. And a very good afternoon to everyone, the dignitaries on dais and off dais. It's a kind of a emotional moment because this is the 10th year in Bihar out of 27 years in research. And during this time, while attending different conferences across the globe, a very special kind of conferences and convening we could experience at Adri. With the leadership of experts, global experts like Dr. Shaival Gupta, Dr. P.P. Ghosh, right now being led by the able leadership of Dr. Rashmita Gupta, we can actually talk to the ground. I remember one conference, one convening where we had a gender convening few years back, during which, while having a panel on the stage with secretaries sitting there, we actually received a question from a PRI member from audience. Today, while talking about surveillance, we heard messages from the district. Right now, while talking about the digital divide, I'm so happy to see people who are actually taking it on the ground, working on ground on technological platforms. They're here. The only problem is the session is post-lunch, when maximum blood supply goes to stomach. And just to ensure that we are awake, I just want to talk about some story. I'll not talk about something very technical. Today we heard about technology, and last 5 years since COVID, probably the most common terminology besides sustainability, community mobilization, and etc., we heard technology. The maximum number of webinars probably happened on technology. Now, the role of information and how technology can help for the right information for the right people at right time, that's what we want to discuss. ये तो हो जाता है. यहाँ पर कोई ऐसे बैठे नहीं हैं जिन्होंने रिव्यूअर्स कमेंट ना पढ़ के अपना लास्ट सेल फोन खरीदा है. So ultimately, when it is for personal use, when it is for anything else, technology use हो जाता है. But when it is for health, I don't know. For that, there is something, a genre called monitoring, evaluation and learning. सुन के लगता है खबर लेने वाले हैं. हम क्या कर रहे हैं इसके बारे में ये लोग खबर लेने वाले हैं. But there is a say, what gets measured, that gets intervened. So information is important for any kind of implementation, and the most important part is the accuracy of that. अब ये accuracy word तो ऐसे ही एक English word है, बोल दिया, लेकिन unfortunately आज हमने epidemiologist काफी सारे epidemiological discussion सुने. So in epidemiology, accuracy is a combination of precision and validity. Now precision is something how precise the information is. जैसे अभी ये सेशन में हमको 7.5 मिनट्स बात करने का है, हम कितना ओवरशूट करेंगे, ये अगर 2 सेकंड से 20 मिनट होता है, दैट इंफॉर्मेशन इज नॉट यूजफुल. बट अगर ये अल्टीमेटली वैलिड होना चाहिए, ये करेक्ट होना चाहिए, तभी ये किसी का काम आएगा. For that matter, there is an important aspect that for every intervention, there is a requirement of information through a framework. And we all know in management science, we call it logical framework. In behavioral science, we call it conceptual framework. In epidemiology, we call it directed acyclic graph. There is something, some input, which is the level of effort, goes to some process, which ultimately is expected to bring some output, to bring some amount of outcome, which is likely to bring some impact. Impact like reduction of maternal mortality, right, reduction of stunted and wasted children, based on some outcome like proper dietary diversity, proper lack of food insecurity, and based on output coming from the system getting ready for supporting them. You all belong to a system, the health system of Bihar. So getting that readiness is the output. For that, there are input and process. This is a theory of change. And every theory of change is based on certain micro theories of change. ये होने से ये होगा. And all micro theories of change are that good as are their assumptions. Given that, it is important to test those assumptions through this monitoring, evaluation and learning. Otherwise,
you have to wait to fail to know that you are going to fail. Because of that, there is an important aspect which is required for any program, any kind of, today we will listen to several programs. Today we'll listen how a digital divide, the divide which ultimately based on several population stratifiers like age, youth and elderly, are they equally savvy towards the digital aspects? Are they accessing? Today Dr. Gupta spoke about access. So are we having equal access across gender? Is there issues related to hard to reach populations? We'll speak about that. But the programs need to identify the red flags coming out of any such kind of digital divide to know if it is going to fail because of not reaching the right population at right time with right information. Changes, if there is any, it needs to be attributed to the right process. गोल गोल बातें करके आज के दिन में कुछ होता नहीं है. We actually put a flag here and because of that maternal mortality came down. ऐसे कोई बात नहीं करता. There is a requirement of attribution to the right process to understand the change pathway. Generating robust proof of concept so that ultimately which is being successful, you can scale it up. You can take it to the right kind of audience for having the advocacy done to take the success for everyone. Given this, we need to have right analytics and that requires quality data. AIML के बारे में तो अभी सब लोग बात करते हैं. कोई भी प्रपोजल में एक पैराग्राफ अगर आर्टिफिशियल इंटेलिजेंस एंड मशीन लर्निंग के बारे में अगर नहीं है तो वो सबमिट नहीं होगा. But unfortunately, it's all about the quality of the data. Machine needs to learn from quality data. Otherwise, we know it will be garbage in and garbage out. To avoid that, there is requirement of input data quality. And today I'll tell you a story of how data quality can be managed very easily with some amount of common sense, which is the most uncommon thing on earth, and with a belief that good things occur more commonly. To avoid bias, to ensure the completeness of the data, to ensure that the known errors are not there, we are making new mistakes. That's better. To ensure that the data is reliable and unbiased. To ensure that we need to measure the impact of the data quality. If the data is high quality, if that is accurate, and if it is being used effectively, then only it can ultimately lead to improved performance, its visualization, and ultimately increased user trust. This trust word is very important. Today we heard about having 500 plus applications flooding the desktop of the secretaries and other program officers. Everywhere, every new organization on the ramp, they come up with a new innovation. The problem is having so many dashboards of dashboards, ultimately where to look at. For that, we have to ensure that we are having the platforms talking to each other, which will help to ensure the data quality, because consistency is something where we lack a lot. By working with a plethora of programs, as well as working with a consortium of development partners, this year, unfortunately, I had to develop a data discrepancy note for the major funder of the state, that what amount of data discrepancy is there. There are issues with completeness we discussed. One of the major issues is with the manual leveling. The manual part, yes, manual part is important. There will be importance of having individual level platforms so that we can correct the digital glitches. But if we ultimately end up in having the register also there and a digital platform transferring those information to a digital platform, then the trust is not being built. The person who is entering the data and the person who is looking at the data, if they don't have the trust on the system, if the vision of the digital aspects are not percolated to the down the ladder on ground people, then ultimately data is of no use. Based on all these, we are proud to say that we have one of the best usage of AI and ML got published in one of the best journals regarding using recording of interviews for the IVR-based assessment of data quality, understanding the respondent fatigue and based on that coming up with data quality improvement. The best practices, just want to show some policy issues, utilization of data quality tools, develop a data quality team, strategy and SOP, collaborate with data providers. Continuously monitor the data quality in real time. I'll not go into the details of these, you all know all these. So for these, there are importance of understanding inter-interviewer variation when you have more people working for a data collection process. Inter-geographic variation, individual level tracking, GIS and GPS based tracking, and tool-based logic check and error detection. All these can be done using AI and ML in real time, just like this example that I am giving you. For each of the interviews conducted between 2014 to 2023 and still now till 2025, just in less number, 78,435 mothers and their children used to be interviewed, and right now in little less number of a few thousands, to understand their reproductive, maternal, newborn and child health and nutrition related different indicators across 534 blocks of Bihar, across 38 districts. For each of the interviewer, we could track directly to the audio which is actually recording each of the interview, and using AI, we can actually relate the data quality by hearing the audio by IVR system and having the data checked automatically. Also, having the metadata, which talks about when the data in the lower one, at what time the tablet or cell phone was switched on, what amount of skips used, how many minutes or seconds were taken, etc. And using those, calculating the submission and completion, and giving feedback, and based on that cleaning the data in real time is possible. And this is something which has been done in this state only, and the dashboard was in the table of the decision maker in real time by hovering on a case of acute encephalopathy syndrome, every details used to come. Given this, there was also all these metadata-based feedback given to the data collector regarding methodology, technique, behavior, understanding of tool. All these are automated to ensure that we understand that embedded in each number there is a life. Thank you.
Thanks, Tanmay bhai. It was very good and very enlightening presentation. In fact, when I joined this conference, so I wanted to ask one thing, that we are consuming data at a fast pace. But is it going to do any good to common man? So that was my right from the beginning. Right from the beginning, I used to think about it. The problem is that the digital divide that you spoke about, it's something which cannot be filled by creating more apps and talking about more innovations. Unless the access to health or healthcare is given to common man, and how should it be done? Otherwise, we will be living in a kind of echo chamber where we can hear our own voices. So these voices will keep on echoing. So that was my point, and I think Pallavi Jain would be better suited to answer all these things, because she is with the NGO and she has been in communication expert in the health sector for a long time. So I would request her to enlighten us about it.
I'm tempted to not use my presentation. I have something up. I was just supposed to I think a couple of points which Tanmay ji mentioned. I think it's much more interesting to, deep dive into those conversations and really talk about what's happening on ground and address the real issues. But So I'll quickly maybe run through a few of these slides. So, good afternoon, everyone. I hope you all are well fed and have some energy to, engage with us in this very interesting discussion. My name is Pallavi Jain, and I'm a senior program officer at PATH. PATH is a global non-profit organization that has been working in healthcare since the last 4+ decades. We work across over 75 countries in health, right from health system strengthening to infectious diseases, vaccines, digital health, AI and medtech, so on and so forth. And again, the idea is that what is it that we can do to, help achieve universal health access to all. So, talking about digital health, AI and medtech, since that's the focus of the conversation today. I'm not sure if I'm using this right. It's the arrows, right? Yeah, it's fine. I don't need this slide. So, the organization has been working in digital health since a while, and we realize that AI and medtech are again two fields which are emerging so rampantly, and they're often being viewed in a silo. Because of which, what is happening is that there is a huge loss of opportunity and also the potentiality of bringing together an ecosystem where we can potentially be working in these three areas together. So the pathway of going about digital health, AI and medtech is that firstly, how can you support country governments as well as state governments in putting together a digital health roadmap? Since digitization and digital health is the way to go, what is it that we can do to understand the context, the specific need? We were talking about digital divide. Every country, every state, I would say in India as well, has different digital literacy levels. The gender ratios are different. Mobile penetration is different. So what is it that we can do to actually create more context-based roadmaps and help do landscapes that can actually help in creating these pathways for the future? So there are countries, there are state governments which are now creating next 5-year digital health strategies. So what are the kind of predictions that we can do? Engaging with different, following rather a bottom-up approach, where you're also engaging with the direct consumers, your citizens. As mentioned, that there is a huge divide there, right? People are not talking to each other. Systems are not talking to each other. So what is it that we can do that instead of just creating newer systems, can we actually use the existing infrastructure, which is in plethora, and actually get them to be talking to each other and, be interoperable? So we have been working with, in Asia Pacific and, also focusing a lot on, the Global South collaboration. And we've been working with Fiji, we've been working with government of Maharashtra and, many others as well, that, how is it that, we can create their digital health roadmaps. Having said that, we are also, we've also worked on several, other national level projects, including the Ayushman Bharat Digital Mission, where we were among the 4 or 5 NGOs that was, deployed for. Thank you. That was deployed for the 100 microsites project. So we actually worked on 60+ microsites to understand that, how can deployment of EBDM actually happen. Are people understanding, what is an EHR? We're talking about Aabhas, on ground, what is actually the reality of a lot of these things. Then we've, of course, been working on, I've mentioned country landscaping. We've also been working on developing multiple digital systems. One of them includes fortified rice quality management. This is, again, for both India and Sri Lanka, that, how can we actually trace, take a look at the traceability, at the same time be able to, look at quality and control as, different fortified products. In this case, the focus was on rice through different, supply chains. We have also been focusing on strengthening the ecosystem. And again, one of our initiatives focusing on AI was the Fix AI Challenge, where the whole idea was that how can we actually bring together innovators from across the world so that they can know what is actually happening across the world. We can connect them with the right kind of funders, with the right kind of partners, help them, navigate through any kind of R&D challenges they might be having, any kind of policy relating challenges they might be having, so on and so forth. I'm just quickly going over these slides so that we can actually get into the real discussion. Even with MedTech devices, we actually have a lab since 2018 where we have supported over 800 startups across the world. Again, with the idea of helping them navigate through their challenges around usability, feasibility, acceptability, market access, scale up. Now, this is one initiative which I really want to focus on, which is something very close to my heart, and I think it is important to address this. And I think COVID is something which, right after COVID and during COVID, I think what really got highlighted was the need for young people to be a part of this entire growing digital health system, right? Because we are the ones who are actually going through this transition. We are the ones who are actually developing these systems, and we are the ones who after many, many years will actually be reaping the benefits of it, whatever they might be, right? So we realize that it's very important to build capacity of youth right from a very early start, right? We would usually see that, whether it is any kind of, representation platform, not just in the health sector, but, wherever we might go, it is usually the more experienced people who get a chance, rightly so. But at the same time, it's the younger people, who sort of lack representation or lack that opportunity. The whole idea was that how can we actually build a platform where we can get young people to talk to each other, to get to network with each other, create conditions where they can actually work with each other in a collaborative fashion. And that's when we came up with this community of practice called as Youth Ownership of Digital Health. So this is a community of practice which has been, now we have over 1,000 members across more than 45 countries. And the whole idea is, to help these young people become future leaders in digital health. And as a part of this, we have many initiatives, again, right from not just webinars, but also, workshops, taking them to on field visits, taking them to, centers of excellence, sites where the real work is actually happening. Bring these people together to actually work on, a bunch of in-house projects. Give them the opportunity to, be interacting with the experts, within the sector. So, again, the pillars of the community are networking, community engagement, and capacity building, so that by the time these people who, reach the senior level, they already have the right kind of connections. They have a holistic understanding of the sector, and at the same time are able to lead and not just, looking at, developing, say, soft skills or, how to go up on the stage and, talk to people. Because at the end of the day, no matter how great your product might be, it's very important that, you first grab the attention of people, right? So the idea is to be able to build them into holistic leaders within the healthcare sector right from an early start. Yeah, we talked about AI. So our team also has been growing substantially. Initially about, I would say, three years back when the digital health team started in PATH, it started from about a 3-member team to now 50+ member team. And we're just, looking for growing this ecosystem through partnerships, looking at more and more innovations that can possibly happen and, looking for collaborations. So if any of you think that, PATH might be an organization through which, we can collaborate, brainstorm some ideas, we'll be more than happy to, always have a conversation. Thank you so much.
Thank you, Pallavi. You have explained it rightly. So, have our guests from Botswana joined us? They have joined. So, shall we toss it to them? Okay. So, Well, during the time of pandemic, the divide between North and South was very evident. And, if medical history has to be evaluated, we can say that in 1918, when the Spanish flu occurred, nobody knew about the existence of virus. But when this pandemic happened, within a year, the developed nations, they acted very fast and they developed a vaccine. And within 1 year, a vaccine was developed. This RNA vaccine that was considered to be a revolution. But that vaccine was confined to North. It was not to South. And that happened all over the world. So that divide was there. I would like our Botswana guests to speak on initiatives that they have taken to bridge this digital divide, and at the same time their own initiatives that had catered to large section of population over there. Over to them. Yeah, are we audible? Hello? Can you hear me?
Hello?
Yeah. Can you hear me?
We can
Yes,
hear
we
you
hear.
even though sometimes we are struggling.
Oh.
Yeah.
So, will you start your presentation, ma'am?
Hello?
Yeah, the sound is feeble, I believe. Shall we yeah.
Dr. Mavis, can you hear us? We could hear you loud and clear.
Hello? Are you able to see my screen?
Yeah, we can see your screen.
We see your screen.
Okay. Good afternoon and good morning, everyone, depending on where you are. My name is Mavis Motegwa. I'm an IRS consultant and an IT project manager as a consultant. I've worked on different projects in Botswana, mainly transforming manual systems into digital systems. The case study that today we are going to present on, I'm with my former colleague, Dumisang Kolahano from the Ministry of Health, who will be here to support in answering questions from the ministry perspective. Today, the case study that we're going to be talking about is the implementation of IRIS to strengthen human resource for health in Botswana. A digital transformation case study. Previously, IRIS was implemented. I think the first time it was implemented was 2011. And for some reason, it failed to take off, and then implemented again in 2015, and then the same thing happened. In 2022, Propel Health, that was a USG-funded project, came on board to implement the system. What we should understand is a strong HRH system is required, and good quality data is required for decision making. Before 2022, what we found was the system was purely manual. It was paper-based, fragmented data, and it made reporting very difficult. So Ministry of Health with Propel Health partnered to digitalize the IRIS system. What was the core problem for this project to be taken on board? The data was fragmented, the processes were fragmented, disconnected paper-based system, no real-time workforce data, long-distance travel just to renew your license, manual inconsistent processes at the regulatory bodies. In Botswana, we have 3 regulatory bodies. We have BHPC, that's Botswana Health Professional Council, the one that deals with doctors and other professions. And there is Nursing and Midwifery Council that specializes with nurses and midwives. And we have a private practice licensing, the one that deals with the ones that want to run their own private practice or clinics. That's where they're being licensed. What are the digital interventions that we came on board and implemented? The key interventions that we did were we fully automate, full process automation. We digitalized process flows for BHPC, NMCV, and private practice licensing. That is eliminating paper-based processes. That is for fast processing. We introduced a self-service for health workers, an online portal for license renewal anytime, anywhere. Even though the process is not fully complete, 80% of the process is gone. We reduced travel with the self-service. The idea behind this is to reduce travel cost and administrative load. What we realized here is because the renewal of licenses happens at a certain period in a year, people had to travel and leave their locations to go to one area to renew their licenses, leaving the patients and all the other customers that need their help, but just to come and queue up so that they can renew licenses. Hence, the self-service for health workers was an initiative to ensure that we reduce the number of time or the time the doctors and nurses are not at the facilities to help our users. Also, cost of travel for the health professionals. We also did what we called a capacity building and a bit of governance. This made, we started off with the IRIS technical working group. We developed a technical working group that includes all the key relevant people within the ministry and the health regulatory councils. The idea behind this technical working group is for us to align and have a strategy in place for us how we are going to implement the system. This helped in decision making so that everybody buys into the idea from the start so that we don't leave anyone behind. This helped also in terms of ownership. People now started owning the system, knowing it's their system, it's not the partner system. It actually belongs to the ministry. The partner was just there to help with the technical implementation. We also did a lot of training, and we had a mentorship program where we had people from IT and informatics as part of the mentorship program. The mentorship program was supposed to capacitate the users, the IT and the health informatics staff, so that they can take over the system once the partner is already out. And then we also mapped the processes, because when we came on board, there were no processes that were developed or mapped. What we realized is everything was haphazard. So we needed to sit and align and develop those processes, document them first before we can even say we are automating a system, so that you understand your processes very well from the manual perspective, to say, if now we are digitizing this system, what is it that we are doing? And also, if the manual process has bottlenecks, how are we removing those bottlenecks going into the digital system? Because you can't just automate everything. You need to see where the bottlenecks are and also be able to remove those bottlenecks, so that your process is effective and it returns more data, good data. What were the results from the key implementation methodology that we did? What changed? What was the impact? We had paper process eliminated across the 3 regulatory bodies. We had a faster license renewal and improved user experience, accurate, up-to-date workforce data, improved regulatory compliance, reduced operational costs, and a stronger government stewardship of IRIS. Them being able to push and direct what they want to see in terms of a system, what they want in terms of results from the system, what are they hoping to benefit from the system, and that was coming from the ministry. Despite the challenge, despite the initiatives that we had few challenges here and there, which we all know when you are implementing systems, challenges are there, and we have to learn from those challenges. One of the key challenges that we picked was the integration complexity. IRIS could not fully integrate with DHS2 payroll system and e-learning systems due to a lack of functioning HIE. As we all know, in health, our main interoperability model is using through the HIE, which is a health information exchange. So when we started the project, the health information exchange was being developed, but it was not fully complete. So we end up developing our part to integrate with the system, but the system from the HIE side, it wasn't fully ready for us to integrate. So that is one of the key challenges that we picked, that it's always better for interoperability for the HIE to be planned maybe ahead of every system that you're trying to implement, so that when you get on board, you realize it's already done. You're just going to plug into, you develop your component just to plug into the system. Another lesson is establish cross-departmental governance, so that there's ownership in every department and people are willing to work into this interoperability thing. And then define technical standards, FIRE and HIE as a main standard for is working, then all the systems should be able to connect and be able to talk to each other. Another challenge that we picked was the data quality problem. There was an issue with data that was there when we're migrating that data into the system. The data was had missing records, duplicate records, inconsistent names. The data wasn't clean. So we had to now start working on a project also to clean the data, which is what was another project on top of another project. Ideally, what should have happened is the data should have been another project before the actual project, and data standards should have been implemented before anything else. But as we all know, data governance is very important and should be prioritized as number one. before anything else, and clean data equals effective digital systems. You can develop a system once you transition the data into the system. If the data is not clean enough, you're still going to get the wrong data. You're not going to get the benefit from the system. The third challenge is plan ahead in terms of infrastructure. Have conversation with the IT and the people who deal with hosting environment to be able to purchase it ahead or ask for budget to have environment ready for you, so that by the time you are deploying the system, you don't have challenges with hosting, you don't have challenges with budget for buying equipment. Also, even buying equipment to take to facilities where people will be using the system, have that budget in mind. The last challenge that I think I would like to share with you is the limited ministry ownership. There's what I've picked as implementing partners. There's always that heavy dependency on implementing partners that normally slows down the full takeover from the ministry. So what should happen is, as a lessons learned, is build capacity from day one. Use co-implementation approaches as well. Transfer skills systematically. Work hand in hand with them, step by step. Ensure they are part of the process all the time, so that they can own the system while the implementing partner leaves the ministry. The main sustainability plan pathway should be HIE should be operating. In short, HIE is operating. Hosting has budget and upgrades. Cross-system harmonization, ensure systems can talk to each other. Payroll system should be able to talk to the IRS system. DHS2 should be able to talk to for better results and data decisions. Strengthen your TWGs. Ensure that your TWGs are able to make the decision, the right decision. Also, to be able to push the idea to even the higher officers and be able to advocate for the system and change management for the system in the entire ministry. Also, continuous data governance in terms of data audits should be done regularly to ensure that the data is captured correctly, and ensure that training for the people who are capturing data is a continuous thing, and ensure that they abide by the standardization that has been done, and check if they are following the processes that have been implemented, so that the data that comes from that system is correct. Why does this case really matters to us? Because government leads the transformation. Once government leads transformation, there's going to be a magnificent change in the organization. Change management is done internally. When it's done internally, it's where now the main people in the government are leading the process and owning the process. Because if they own the process, it means they will continue using the process even if the partner is not there. Capacity building should be an intentional thing. Make sure people go for these trainings, they know the system, you take them hand by hand and ensure that they know the system, they can actually use the system. They can actually advocate and talk about the system in the absence of a partner. Data governance is it's one of the strongest things, because I keep talking about data. For any decision making, we need data, and we need only the clean data. We can't make decisions based on data that is not correct. So data cleaning and data governance, data quality assurance should be key things that are being implemented in a system. Interoperability, like I said, should be planned realistically and ahead, so that other systems can come and plug into it. Technology supports, but does not replace the process reforms. So Yeah. In conclusion, all I can say is IRIS in Botswana shows that digital transformation is possible, it's scalable, and it's impactful, especially when government ownership, clean data, and strong governance drive the process. Thank you. Over.
Thank you, Ms. Mochegova. This program, I think, is more integrative as compared to, we were just speaking about it, that the program should be integrated.
I can't hear you.
So, Tanna ji, would you like to ask anything from Ms. Mochegova, or shall we go ahead?
Mavis, can you hear us?
I can't hear you. Please speak.
By the time this technical glitch gets solved, it's like technology. Good that we had discussions from here to Qatar. Now having little bit problem here to Botswana. Let's that get solved. Yeah. But I think she mentioned about clean data, governance, and the government will.
And interoperability. This silos, that fear that we have been speaking about since morning, that we act in silos, that they have tried to break those silos. So that is something very important. So shall we go ahead then? Sanchita, shall we go ahead or? Let her fix it.
By the time it gets fixed, I have a question for Pallavi. Pallavi, you mentioned about the program, you mentioned about how you had this youth attention and those aspects. Did you apply some champion policy?
Well, I'll say that every youth that was a part of youth was a champion in their own right, because, I think there is a lot of gatekeeping of information which happens, and all of them coming together to sort of, being open with sharing resources, information. It sort of became like a health community as well. I think they were all champions in their own right. But yes, having said that, a couple of things that we did do to motivate them more and, to be able to recognize champions within the community were that firstly, we really believed in the multiplier effect. So the whole idea was that you will be a champion if you're able to get more and more people just like yourself to be associated with the community. So it's like if you are bringing in one person, that one person brings in two people, those two people bring in four more people, right? We also had this core committee, and we also had these ambassador programs. So they were our champions because they were the ones who were actually helping us carry out the monthly engagements that we used to have. Whether they were podcasts, they were workshops. So they were the ones who used to design. They were the ones who would take a lead on it. So they would sort of get that feeling of having championed that particular initiative. So they were very happy to learn a new skill, right? So there were multiple such championing I will say tools or motivational or inspirational tools that we had applied within the community through which they could co-learn and also co-create a lot of things.
Mavis, can you hear us now? Or Tumi-san? Mavis, you are on me. Yeah, can you hear us?
Hello? Now I can hear you.
Okay, we can also hear you very clearly.
I keep struggling to hear you, but yeah.
So Mavis, we had a question. Can you hear us?
Yes, I can hear you.
Yeah, we had a question. You spoke about the change management, and you spoke about how change management was supported by government will. Can you just little bit highlight this, that how change management at the government level was possible?
Change management, that's a tricky question. Change management as for government, it's a tricky one. It's not like we had a plan to say, let's do change management this way, which is something that I realized. But we kept changing their mindset in terms of manual systems don't give us what we need, and convince them that the system is actually what is required. That's the change management that we're doing in terms of speaking about the benefit of the system, highlighting the importance of automated systems. But we didn't have the actual change management, whereby we have a change management committee that does communication, that develops the strategy, but we did it in a lighter version where we emphasize the importance of the system, the benefits that they will get by using the system, and making sure that they realize that they are the ones who are actually benefiting than the implementing partner. I don't know if I've answered you.
Yeah, very much. Thank you.
Can you hear me?
Can we go to the other guest?
Hello? Can you hear me?
Tumi-san wants to answer.
Okay.
Yeah, we can hear you.
Okay. Maybe just to add also perspective on to maybe this response. As government, we've noticed that most initiatives that, for lack of a better word, come with partners, perhaps are adopted in a difficult way, other than initiatives that come from within, that is government. So usually it makes things easier. For example, for the adoption of such systems to be rolled out in government, when a system comes from within, other than when it comes through partners. So for lack of a better word, partners can do so much to initiate the change management into government to ease day-to-day work. But at the end of the day, like I was saying, when something comes with partners, it's not adopted fast, other than when it comes from within. Thank you.
Thank you. That's great when it is coming from Ministry of Health.
Great. So now, we should proceed further. So to my mind, in the history of humankind, we are at a sweet spot where we as a human being have adequately protected ourselves with calamities. As I told you earlier, that the pace at which RNA vaccine was invented, that shows that you can protect yourself with the pandemic as well. Because if you look at the history of Spanish flu, you'll find that the casualty rate was much higher as compared to this pandemic all over the world. But my worry comes from three factors, and that is that while we have protected ourselves, we are destroying other lives in a fast pace, furious pace rather. If you look at the organism or other lives, like wildlife, variety of other lives that human have destroyed, that has created a kind of balance which is harmful. Then the second thing, I'm pointing this out in order to ask you and to take it further, both of you, because it will throw open the wider area. digital divide will ensure survival of the fittest. I mean, those who are rich, those who are affluent, they can survive, while those who are at the margins, they will find it very difficult to survive because they would not have access to that kind of privileges. The advantage, I mean, can it be addressed to the advantage of low and middle income countries? And third, the biggest challenge which I feel is now the mental health. How it can be tackled in a holistic care of healthcare guided by AI but devoid of human empathy. I mean, if everything is algorithm, as AI is trying to imitate human beings, so, but human feelings cannot be described in algorithm. So, how the mental health, because mental health would be a biggest challenge in coming times, apart from other health issues. So, how would you address mental health in an atmosphere which is guided by AI but devoid of human empathy? So with these three concerns, I open this to questions from the audience and from you. I mean, starting from you and both of you. So if you can elaborate on that, and then we can take questions from the audience. So who will start? Pallavi, you can go ahead.
Thank you. So, sir, I basically saw three questions in, what you just said. One was survival of the fittest, and we're talking about digital divide here. So I think for me, what is important is to define who the fittest is, right, when we're talking about the digital divide, right? The second question was, if we take the other aspect of it, is that, as you mentioned, that the more affluent ones who have access to healthcare, they are the ones who are likely to survive more, right? And the third one on mental health and, the growing AI and use of technology around it. So to answer the first aspect of this, when we're talking about who the fittest is, in this, you're looking at this world with digital divide. So I think, again, the one who is equipped to be able to handle technology, for me, is the fittest, right? So, again, trying to bridge that digital health literacy gap. Eventually, I think the issue will not so much be of, mobile phone penetration or internet penetration, because I think we are already pretty much at that level where at least there is one phone in one household, right? If not one mobile phone per person, right? Everybody has access to YouTube. Everybody has access to data. I was on the field a couple of weeks back, and, even at the primary healthcare level, healthcare practitioners are using their own mobile data as hotspot, right? And they're not taking reimbursements for it because they're like, chalo, koi nahi, hame government ki taraf se reimbursement allowed hai, lekin itna sasta hai, koi nahi, hum khud kar lenge, right? So I think we have, in a lot of ways, we have bridged, or, we are, at the helm of overcoming those. But again, that digital literacy, right, is something which we need to address. So I think for me, the fittest would be the person who is digitally literate. Second thing is having access to healthcare. You're right. Again, I think our primary healthcare system is very, very overburdened, right? What is it that we can do to, strengthen that, since that's the foundation, right, of healthcare across the world, right? So again, things like, instead of making more and more systems, right, overburdening our health workforce with that, right? How is it that we can digitally train them, right? Because tools and technologies are here to overtake, right? So maybe उनको और ज़्यादा सशक्त हम बना सकें कि वो कैसे use करें वो tools, क्योंकि at the end of the day computer है जिसने करना है सब कुछ, right? So how is it that we can do that? One very big gap is the workforce, right? We don't have enough workforce, right? So if we are now going to start relying on the use of technology, how is it that we can actually help in overcoming that workforce gap? Right now, even though with, digitizing a lot of systems, they are still manually filling those registers at the same time also, doing entries on the computers, because that fear is there कि register में होगा वो खराब नहीं होगा, लेकिन क्या पता computer का data उड़ जाए, right? So that trust in technology building, that is very, very important. And the third part on mental health, I think it's still a taboo in a country like ours to talk about it. I'm not sure how many young people are actually able to go up to their parents and, tell them that they're struggling with something, right? And to be able to even recognize that they're struggling with something, I think that talking about that is still a taboo. That is why reliance on technology, including ChatGPT, as a therapist has, become more and more prevalent, right? Again, is ChatGPT a therapist? No, right? Are we trying to humanize ChatGPT? Probably not. So I think it's, again, to understand the perils of technology as well as, what are the advantages of it, and using it in the right way. I think we really need to think about it.
Thank you very much. Now, Tanmay.
Yeah, I think Chairman sir's question, I want to answer with one word, that is about balance, about access, about empathy, about human touch, about mental health. Balance is important in everything. And with balancing the amount of time that we are talking and with the frequency organizers are looking at the watch, I also want to mention one point that it's about not replacing something. It's about facilitating something. For long we have questioned ourselves, is population our strength or weakness? Now we are talking in the one go, in one breath, having lack of human resource and having not enough job. We are also in the same breath mentioning that digital literacy is easier than rote learning. We are talking about socio-emotional and ethical learning helping in both digital literacy and rote learning. If we put all these things together, and I just want to second Pallavi, have to have the system. It's not the problem of technology that it is reaching you and me and not my maid who is coming to help me on the days when I am vulnerable. It's actually the system which is not reaching them. So we have to have the system to bridge this digital divide and take technology as a facilitator in that journey. Thank you.
Thank you. Thank you very much. Very rightly answered. So, are we running out of time? Running out of time. It's all right. Thank you very much. Then, shall we open to some questions? Some questions, if anybody wants to ask. किसी को पूछना है भाई? अच्छा. I don't think so. So it's all right. Thank you very much. Thank you.
Our heartfelt thanks to the chair and all the panelists for this insightful discussions. A key message emerging from this panel is that bridging the digital divide requires strong collaboration, good governance, local capacity building, and thoughtful designs. Now I would like to proceed with the felicitation of our dear chair and panelists. Firstly, I would like to request Shri Ajay Kumar Singh sir to please felicitate Dr. Tanmay Mahapatra sir. I would request Shri Ajay Kumar Singh sir to please felicitate Mrs. Palvi Jain ma'am. Now, I would like to invite Dr. Maushami Gupta ma'am to felicitate Shri Ajay Kumar Singh sir. We also extend our sincere thanks to Ms. Mavis Motsegwa and Mr. Tumisang Kulangano for joining us virtually and making this session insightful. Thank you to all the dear panelists and chair. Thank you so much, sir.
Up next, we move to panel discussion second, titled Policy Governance and Implementation Challenges, a Critical Role for Technology. This session brings forward perspectives from leaders working at the intersection of system, governance, and innovation. It is our privilege to invite Dr. Abhay Kudale to chair this session. Dr. Kudale leads the Department of Health Science at Savitribai Phule Pune University and brings more than 26 years of experience in epidemiology, community-based research, and public health system strengthening. Sir, may we kindly request you to join the dais. We now invite our esteemed panel of experts, starting with Dr. Soumitra Ghosh, Associate Professor from TISS Mumbai, specializing in universal health coverage, equity and financing, and recipient of acclaimed international fellowship, including the Yusuf Hamid Fellowship at Columbia University. Sir, may we kindly request you to join us on the dais. Next, we invite Dr. Harsha, Assistant Professor at IIPH Gandhinagar, recognized for his contribution to Niksha Setu, MERM, and AI-driven chest X-ray platforms. Sir, may we invite you to kindly join us on the dais. Joining us virtually from Uganda is Mr. Simon Soni Vijuli, an HRH policy and health system specialist with more than 20 years of advisory experience with governments, WHO, and World Bank. I kindly request AV team to please project Mr. Vijuli on the screen. We now request our chair, Dr. Abhay Kudale, to guide the conversation and commence the panel discussion.
Yeah, thank you. Yes, so we are going to discuss on policy, governance, and implementation challenges and the critical role of technology into that. So I think the momentum is already been set by the previous panel discussion. Okay, in the same go, I would like to invite Dr. Soumitra Ghosh from TISS to share his thoughts on this particular issue. Over to you, Soumitra.
Am I audible? Am I audible to all? Thank you so much for having me here. I'll straight away go to the topic. Could you please go to the next slide? This is a brief outline of what I intend to cover. First is, of course, the context for today's talk. Then I'll move to the strategies that have been in use for moving towards universal health coverage in India. And so far, what is the evidence on the performance of all the measures that have been in place? Particularly, we'll focus on PMJY, the Pradhan Mantri Jan Arogya Yojana, and then I'll come to the concluding remarks. First is as I said, let me set the context. Could you go to the next slide? I'm sure all of you know about it because we have been working in the area of health for some time. If you recall the Sir Joseph Ford Committee report in 1940s, the life expectancy at birth was 26 years. Now, of course, if you look at the life expectancy at birth, it has improved significantly. But in a comparative sense, if you look at other poorer countries or richer countries or countries which are socioeconomically similar to us, the performance has not been that great. As you could see that our maternal mortality, the under 5 mortality rate, it's on the higher side. The prevalence of underweight among the children, it's also high compared to other countries. This is to understand where we are today, basically, in terms of moving towards UHC, the universal health coverage. There are certain tracer indicators, and if we combine all these tracer indicators, then we get a score. So it's called the Service Coverage Index, which means that to what extent the essential service coverage is there in the country and across the states and the districts. And as you could see that India certainly has improved. So the score, the Service Coverage Index score ranges between 0 and 100. So it used to be at 33, in the year 2000. So we have moved up from 33 to 63. Having said that, if you look at the index score across districts, the median score happens to be only 44%. And there are states like, Uttar Pradesh and Bihar where the score dips to even 37% and 38%. And these are populous states. These are equivalent to Nigeria, which is the 6th most populous country in the world. Now, as we have been discussing about UHC, assuming that we all understand what it means, UHC means that whether people can access the needed care without suffering from financial hardship. Now, if you look at the table which is given on the right-hand side of the slide, you will see that the catastrophic health spending, that is one metric that is used to understand to what extent we are providing financial risk protection to the population. It is 17.5%, which is pretty high, and every year 40 million people are being impoverished due to health expenditure. So we are not doing very well on those indicators. Let's try to understand and diagnose the problem. Why we are here, the progress has been not so good compared to other countries. Let's look at the health financing scenario, because this is something which is also a critical factor for achieving UHC. If we look at, as I said, other comparator countries, how much they're putting in for health, you will see that we're still talking about 1.8%. So it's 1% that we have been hearing since I was a student, and we're still stuck at 1.8%. If you recall, the Government of India has made a commitment in our National Health Policy document 2017. By 2025, we're supposed to be at 2.5% of GDP. That is the amount that we wanted to put in. The issue here is, what's the problem basically? If you see the other countries, how much money from their annual government budget they're actually allocating for health, you will see for Thailand it is 16.5%. Look at India, where we are. So far, it is the 6.1% of the total government resources that is going to health. So clearly, there is a problem over there. Let me briefly now talk about, because I could see that people must be familiar with what PMJY is. PMJY was introduced in 2018. Before that, we had another demand-side financing mechanism, the scheme called RSPY. You all should be familiar with RSPY. Now, how is it being financed? Of course, it is mainly it is tax-based, right? And we know that there is 4% health and education cess that is imposed on income taxes. So the money, the resources come from that pool, basically, which is used for financing PMJY. Both the states and the center, they basically share the burden of running this program. The ratio is 60-40 for most states, and for the Himalayan states and northeastern states, it is 90:10. How does it get implemented? There are different models. I really don't want to get into the specifics of those models. In case we are interested, we can discuss about it. So there's this insurance model where you engage with a commercial insurer, basically, which takes the program to the people. There's a target population group. We know that. They're identified based on SECC the socioeconomic caste census, which was conducted way back in 2011, we still use the deprivation criteria to identify the target population group. It is done by, most of the administrative tasks are done by the private sector. So it is also one of those PPP models, so it's interesting to look at what is really happening, because government's role has been limited to financing this program, where the private sector takes it basically, right? Right from, as I said, the claims management, reaching the beneficiaries, and then there are both private and public hospitals which are impaneled. So in case someone is enrolled into this program, theoretically speaking, the person should be able to access hospital care. Of course, the benefit package is quite limited. It doesn't really cover outpatient care, medication. What it covers, a set of procedures, and that also varies from state to state. We have some recent evidences coming from, again, national level data. As you could see that in terms of enrollment or registration, there has been some progress, starting from 11% when the program was rolled out. Now it reached to 33.9%. Remember, what was the target? The target was the bottom 40% population. We're still not there by 2022. We're supposed to be there. Now, there is another scheme. That's the only scheme which is the state-sponsored health insurance scheme you have in India, because that's West Bengal, where the program is universal in nature, so it is not target-based. So we could see that the prevalence is 75.6%. So it's almost universal coverage. That's something they have attained. Looking at the statewide, variation across regions, you could see these are the two states, Bihar and UP, where you would like to have more penetration of this program, but that has not been the case, basically. And that's what the recent data indicates, that the PMJY is yet to reach the intended population group. Has it really been effective in terms of reaching the intended population group? That's the question we are posing, because as I said, it has adopted a target-oriented approach. As you could see, why I painted the bar in red color, it is to highlight basically APL is supposed to be not there, and yet it is there. We don't mind about it because there could be some leakage of subsidies. But the problem is when you put together Antyodaya Anna Yojana ration card holders and priority ration card holders, together they should have captured all of that coverage that we're looking at. Now, another important aspect of this scheme, because the scheme was rolled out in order to improve access to healthcare. If you see the hospitalization rate across quintiles, these are consumption expenditure quintiles, then we see that the great divide still remains. Because if you look at the households which are belonging to the quintile 1, and then you have vis-a-vis households who basically belong to quintile 5, you could see there's a wide difference. And even though PMJY and other state-specific health insurance programs have been introduced, they have not really been able to address the huge unmet need for hospitalization. And that's pretty evident from the data. Now, we also looked at, particularly for the bottom 40% population, because that happens to be the target population for PMJY. So we see that almost 9 out of 10 poor households did not receive any benefits when they needed it most. So there were hospitalizations in their family, but only, as I said, 1 out of 10 such households, they could actually access the benefits of PMJY when they were in the hospital. Now, there is another interesting point, because we have been told by Niti Aayog that there is this missing middle phenomenon. Is there any missing middle phenomenon? Let us try to look at this issue very, very closely. What I did here, it's basically the concentration index score, which ranges between -1 and +1. So if the figures are closer to +1, this means that it's more and more pro-rich distribution. And what I could put only few states' figures because of the space constraint, but I looked at all the states' performance, barring Haryana. Everywhere what we see is the pro-rich distribution of the benefits, which means PMJY, the services of PMJY and other state-specific schemes were actually used by people more from the better of quintiles, basically, from the better of segments. And lastly, I'll briefly talk about this. This is where we try to understand, this is one of the dimensions of UHC. It's to understand what percentage of the population are still facing some sort of financial hardship. So here we could see that households that have used PMGY benefits, 44.3% of those households actually incurred catastrophic health expenditure. So in terms of benefits, there are some benefits enjoyed by certain population group, but it's very, very evident that the poorer population group are still basically incurring out-of-pocket expenditure, and that is why we see the significant incidence of catastrophic health spending. Now, just to conclude this talk, the problem is we all know that we have a program called CGHS, the central government health scheme, which covers roughly 47 lakhs people, so it's barely 500,000 population. Then we have another program called ESIS program, which also started way back in 1950s and 60s. And then, of course, for a long time, we did not have any insurance program as such for the informal sector employees. The point is that all these risk pools are fragmented. What we need is amalgamation of all the risk pools. So far, although we are talking about insurance, there is, as such, no risk pooling is happening. That's something I wanted to highlight. The other issue is something that we can learn from the West Bengal's experience in terms of taking the program to the people. If we continue to use the target-based approach, as we have seen, it is very, very evident from the data that the poorer households are getting excluded from the scheme. So if you have an universal approach, the chances are higher that even it would reach to the marginalized population groups. Just to highlight the difference between how much we are expending on PMJY and other state-sponsored health insurance schemes vis-a-vis programs like CGHS. That will perhaps tell us why the performance hasn't been that great. Look at how much money we are spending on CGHS beneficiaries. Per capita expenditure in the year 2023-24 was 16,773 rupees. When it comes to PMGY beneficiaries, it is barely 200 rupees per person. So the difference is between 200 and 17,000 rupees. So with 200, how much services you can provide? So the other point is, we can keep on discussing the issue of supplier-induced demand. And that's something, a technical jargon I'm using. So we have seen that how the insurance scheme has been misused in certain contexts. So I'll stop now.
Yes, please. Thank you. Thank you, Soumitra, for setting the context for discussion. Yes. Yes, in the interest of time, I would like to call upon Dr. Harsh Shah. Please, sir. You can also have your presentation, and then we can move further.
Please open my slide deck. So it's a difficult time in the last session with a scattered population who are having the limited attention to the intricacy, but I'll try to make it more sound in terms of what we heard since morning. Since morning we had heard about the policy makers who are presenting their views on digital health. In the afternoon we had learned about the data decision making part, where the AI has superimposed in every sabji like aloo. So now AI has become aloo of every sabji, and just like a salt, we are adding AI to everywhere. And that is happening right now when we term the digital health in a different context. So I was supposed to create a simplest way that how the digital health is making the policy, governance and implementation science with some examples, but I would like to change my way of presentation here. So I consider the digital health as a cognitive health system of public health. Why so? Because we had started making so much of EHR portals. Whether you come, I had worked as a HMIS, which was in 2012 to 2014, then HMIS 2.0. And every time we had discussed about how many data points we need to take. I had heard about earlier sessions where sir has mentioned where we need to address digital divide. First thing, we are not making any user-centered or human-centered application with so much of efforts. And whatever we make, we do not evaluate. And earlier, sir, that had mentioned about the research part. So whatever we make as a digital platform, we make that what we see fit for the users. And that's the challenge, sir. Whether for the patients, whether for the beneficiary, and whether for us also, whatever the platform we make as fit to us, not for users. And that's the challenge. So we moved from the paper to PDF to portal, and that is a part of digitalization. Now, there are stages of digitization. So like signs and symptoms, जब डॉक्टर के पास जाते हैं ना, तो हम बोलते हैं कि भाई इसको पेल है, या कोई बोलता है कि इसको येलो डिस्कलरेशन है. Then there are the definition, and same goes for now digital health. With the advancement of this domain, there are stages of adoption. We move to digitization. हमने पेपर से पोर्टल तक पहुंच गए. Simultaneously, we had created so much of portals. So India is in a stage 2, digital for health. But where we want to reach, and that's the stage 3, digital in health. So there is so much of fragmentation right now. Sir ने एक सुबह पूछा था कि where you have collected these data for formal and informal providers. I was in a state somewhere where I had managed all the COVID patients' data, and from users also, from health facility also, and from providers also. And still कोई मुझे पूछता है कि ये कोविड का सही डेटा है, हम बोलते हैं कि no comments. Because I could not comment what is the actual prevalence at that time for COVID. And same goes for every state. So data quality, yes, but decision making, we need to think beyond data. And that's I'm going to cover in subsequent sessions, subsequent slides. Now, there are lots of definitions. So today's topic is not digital health. The conference is on digital information. And there are certain categorization for digital information system. When you talk about digital health, that comes with robotics, medical devices, and etc. lots of things. So there are 22 categorization of digital health. But when we talk about digital health system, these are couple of live examples that we are using. Now there is a technology wearable device that comes as technology of IoT, and that uses technology of eye photoplasmography. So those who are interested in digital technology and digital health, they need now to deep down in the intricacy of digital health. So these are a couple of examples. I am not going into details due to time constraint. Otherwise, sir, मुझे बोल देंगे कि time is up. These are the actions points on the larger areas that we need to build this pyramid. So first part starts and the last part. We need to build the pyramids from the bottom, not from the upside. So human-centered designs के साथ you need to mention the accountability at every step. And that is the challenge right now that we are facing, that we do have lots of application who is doing the similar kind of work. But sir ने कहा कि हर एक organization नया आता है जो fund की demand करता है और एक नई ऐप create करता है. Whether it is the development partners at international level or like us at the local level. We need to again look for World Health Strategy. There is a global health strategy and they have demarcated what needs to be done. Simultaneously, they had classified digital health problems into 3 axes. First, you need to identify health system challenges. There is a clear demarcation, clear categorization of 8 health system challenges. So as a developer, as a public health professional, if I want to build an application or solution, I need to learn these areas also. There are 8 health system challenges, there are digital health intervention categorization, and what system category or technology I am going to use or I am going to create. That's the third axis. And fourth part is what technology stack that you are going to use. So if you are going to use as AI, sir ne jo AI ka, that is built on TensorFlow, that is not completely AI. But still, if you are going to use a different context, different algorithm, that is AI. Now, where is India? So these are the certain parameters. This is the World Health Organization ne banaya hai, digital health monitors. So each country has to achieve this stage, and we are at the stage of 4, and thanks to ABDM, we are on the track. Now, what do we need to do? हम हर बार बात करते हैं कि पेपर टू पोर्टल या पेपर टू पीडीएफ. हमें एक लीप फ्रॉग एडवांसमेंट चाहिए. नाउ इफ यू सी द जेमिनी प्रो 3, that has the IQ of 140. If you go to the cloud, that is at IQ of 125. Now we do have a technology जो private sector बहुत advanced में use करते हैं. सर ने जो कहा robotics, AI, radiology, they are using quite advanced algorithms, and in government system we need to reach at certain advancement level, and that is called leapfrog opportunity. Means बेसिक से सीधा जंप करना है एडवांस में, अदरवाइज वी वुड नॉट एबल टू कीप पेस टू द वर्ल्ड्स कंट्री, डेवलप्ड कंट्रीज. एंड एबीडीएम इज देयर. दिस इज द फेडरेटेड नेटवर्क. देयर आर 2 aspects. We need to create federated network. Means there are lots of applications, there are lots of platforms who are working in silos. जहां पे डेटा प्राइवेसी, ऑडिट ट्रेल्स सब कुछ मेंटेन रहे, जहां पे डेटा कलेक्ट हुआ है वही सोर्स रहे, बट ऑल द प्लेटफॉर्म्स कैन टॉक विथ ईच अदर. सो दैट इज अ फेडरेटेड नेटवर्क, एंड विच इज हेल्थ इंफॉर्मेशन एक्सचेंज सिस्टम दैट वी नीड टू क्रिएट. एबीडीएम कर रहा है. आई एम नॉट श्योर हाउ लॉन्ग इट विल टेक, बिकॉज we need investment of $20 billion in a year to create HIE. जो अभी तक हम बजट एलोकेट कर रहे हैं 3% जीडीपी का, 4% जीडीपी का, that will not suffice. Because if you see the newspaper, Microsoft is going to invest $65 billion for enhancement of their AI. So that kind of investment would require. Now, policy level, what we are doing right now, we do have successful examples. We did not go to the other countries. We should not. There are so many of good examples and they are working well. We need to scale it up. We need to sustain them. So there are a surveillance system, IHIP system, but simultaneously there is a Vadwani AI. They had created a system where they are scanning news articles. And they are using Roberta, means emotional language model है जो NLP बोलते हैं, natural language processing. They are using those, और वहाँ से वो सर्वे आता है, alerts send होते हैं. Anyone can create at state level, but those who have been created, let's adopt them. There are IIT Kharagpur also, IIT Delhi also. They had created similar kind of NLP. We need to just deploy in a certain system where news articles from any of the places can give us a disease alert. And that is another channel that we can use to make the policy more sound with intricacy of data. I've been to ISC Bangalore. Dr. Pallavi has shown that they had fixed. Wahan pe Dr. Raghu and Dr. Bhaskar, they had created a model where through the environment data, remote sensing and GIS mapping, you can predict dengue hotspots or cold spots also. these are the changes that we need to incorporate, adopt, because they do have accuracy. And we all know about EWIN, then COWIN, and now UWIN. That is a successful part, and we need to think beyond those areas. And ultimately, it's a difficult term. I'm not going into details, but regulatory sandbox needs to be established at state level. And if that is not there, so many apps, so many platforms will be created by private sector or by the development sectors, and no one will be there to do a validation. Now, these are the silos. We need to make integration, just like UPI. UPI was created by NPCI. Similarly, APDM is going to create this kind of interface where all the health facilities, all the health personnel can have a unified platform. So, for governance basis, we need to create some kind of sandbox where we can validate, we can do audit, and also the transparency and accountability can be set. Because if I am a person, I do have my medical records, और कोई और उसको fetch कर रहा है, then I should be there to decide कि if I am going to allowed or not. आप देखिएगा बहुत सारे AI chest X-rays, AI CT, AI radio, AI scan for breast cancer भी आ गया, mammography. Does the researcher had taken the concept of a person that we are going to build our algorithm from your data? That's the critical part of informed consent and data privacy. We need to address those areas. There are a couple of parts we need to make sure in the implementation science. User-centered designs, offline part for frontline workers. Almost 17 applications are there. मैम ने सुबह जो थे उन्होंने बताया बिहार में बहुत सारी प्लेटफॉर्म्स है, इंक्लूडिंग SNCO ऑनलाइन सॉफ्टवेयर, जो मैं एक पार्ट था जब वो डिजाइन हुआ. वी हैड डिजाइन इन सच वे कि वो RCH पोर्टल में इंटीग्रेट हो. पर अब क्या हो रहा है, हर एक स्टेट खुद का RCH पोर्टल बना रहा है और API के साथ लिंक कर रहा है. बट वी नीड टू हैव अ डेटा स्टैंडर्ड्स. मीन्स मैं अगर बोल रहा हूँ ट्यूबरक्यूलोसिस स्क्रीनिंग, तो दूसरा प्लेटफॉर्म भी बोल रहा होगा ट्यूबरक्यूलोसिस स्क्रीनिंग, नॉट TB स्क्रीनिंग और नॉट स्क्रीनिंग ऑफ TB. एंड देन ओनली we can merge each data at every platform. अभी वो नहीं है. So at India level, we need to create a data standardized norms in terms of SNOMED जो world level पे use होता है, FHR जो world level पे use होता है, and then only we can talk about interoperability. Otherwise, बहुत सारे conference, बहुत सारे seminar में ये word बहुत widely use होता है. But how many are going to create data standards at national level, at state level? We are struggling. Where I'm working, I'm struggling. And similarly, we had created Nixa Setu application where we had created clinical decision support system. So it's kind of a doctor. तो अगर एक डॉक्टर को डिग्री लेने के लिए NMC या स्टेट मेडिकल काउंसिल से रजिस्ट्रेशन करवाना पड़ता है, पर हमारे इंडिया में कोई भी एप्लीकेशन बनाने के लिए, उसको यूज करने के लिए कहां से परमिशन लेनी पड़ती है? कहीं से नहीं. CDCSO is an organization where one can apply for commercial license. वो लाइसेंस दो चीजों का मिलता है, मैन्युफैक्चरिंग और डिस्ट्रीब्यूटर. They consider medical software as devices, but do they follow the rigorous norms कि ये RCT पे हुआ है? If there is AI software who is going to diagnose or who is going to give the treatment, do we have that capacity at a country level, at a state level, कि हम उसको validate कर पाएंगे कि भाई RCT ठीक से हुआ है कि नहीं, accuracy ठीक से हुई है कि नहीं? We do not have the system as of now at everywhere, and that's why so many of AI platforms, और आप Google Play Store पे जाओगे, iOS Play Store पे जाओगे, there are 27,000 applications are there who says that they are using AI at the back end and provides different kind of medical suggestions. iDrone, that is the big advancement right now. We should adopt at every state level or investment karna padega. And technology scales, but if there are bad governance, it scales faster. How to address this? So whenever we are going to make any platforms, we need to understand कि ये सॉफ्टवेयर की जगह हमें ऑर्गवेयर पे ध्यान देना पड़ेगा. Then only we can reach at up to level. हमने निक्षय सेतु बनाया, still we are struggling कि गवर्नमेंट कब अडॉप्ट करेगा. बिहार गवर्नमेंट से हमें लेटर मिला है कि you need to implement निक्षय सेतु, but still we do not found that opportunity कि कहाँ पे इसको implement करें. जब बात हो रही है तब अलग अलग पॉलिसी मेकर्स चेंज हुए. So still we are struggling at every stage. तो हम ऑर्गेनाइजेशनल सॉफ्टवेयर को समझने में कहीं पे लेट हो गए. एंड स्टिल दिस नीड्स टू अंडरस्टैंड व्हेन यू वांट टू क्रिएट अ सस्टेनेबल एंड स्केलेबल प्लेटफॉर्म. नाउ देयर आर डिजिटल लिटरेसी इश्यूज, बट हाउ टू एड्रेस इट, एवरी ऑर्गेनाइजेशन, एवरी स्टेट नीड्स टू डिसाइड कि क्या चेंज मैनेजमेंट लाना है. Unless still we will have 20 application at A&M level और हम उसको बोलेंगे कि आप home visits नहीं कर रहे. There will be 5 application at private sector और फिर हम बोलेंगे कि आपको अलग अलग 5 application में data देना है, whether it is IHIP, whether it is RCH, whether it is every TB. ठीक है, हमारे पास हर एक चीज़ का वेपन है, एपिडेमिक एक्ट है, हमारे पास गैजेट है, everything is there, but still we need to make a change management. And एक pilot testing का word हमने डिजाइन किया pilotitis. Everywhere the application starts with the funding और उसको pilot करते फिर देखते हैं. And the application has been created manywhere, it has been disseminated, but जब integration की बात आती है तब वो बोलते हैं कि यार fund नहीं है या फिर government adoption reception बहुत कम है. So these things are happening and we had not succeeded कि कैसे उसको कर पाए. So we would like to have your suggestion also. Consent DPDP Act May 2027 में implement हो जाएगा, but that is still widely for social media, not for health, not for IT platforms. तो किसी को भी अभी ड्राफ्ट वर्जन है, दे वांट टू गिव एनी सजेशन, दैट इज द ओपन प्लाट. अदरवाइज वी विल मिस बिग डिसीजंस इन द हेल्थ सेक्टर. I mentioned about CDCSO, software as medical device, but still lacking a rigorous evaluation framework. And at ADRI level, I can say that for Bihar government, you could be the potential partner that can help them to understand that how the software would be evaluated and how it will be working. So take home message 3, understand the organization, create orgware, create workflows, otherwise any platform would not be succeed as it should be or will be adopted. Second, interoperability. If it has not interoperability or advanced technological stack, it won't succeed, because now if you are not understanding the IT part, you would be behind to the technology. And third, human-centered design. If it is not there, we won't be able to achieve a digital literacy, or we won't be able to minimize digital divide. Thank you.
Yes, thank you, Dr. Hirsch. So this session and slightly last panel discussion also pointed towards the most important thing is about systems thinking. And I'm thankful to Soumitra for putting the things in the proper context of universal health coverage, and that is what I think we have to aim towards. Another important thing with second presentation by Dr. Shah is about regulation. See, from morning I want to hear that what happened when we say our National Health Policy 2017, okay, that they envisage the need of having National Digital Health Authority. Okay, what is the kind of a status? We understand that there is no clear roadmap when it comes to National Health Policy 2017, and some of the things are actually done on ad hoc basis. But this is the kind of a situation now, 8 years down the line, we are actually struggling to have a kind of a regulation when it comes to our digital health initiatives as such. And we keep on actually evaluating, keep on actually, I must say we are duplicating many kind of apps and many kind of ideas, and we really need to have, as pointed rightly by Dr. Shah, that we should have somebody who could register of all these particular initiatives. And with this particular system focus, there is a time for us to go to Uganda, where Dr. Simon is waiting to share his experiences, his perspective on this very idea. Can we connect him, please?
Thank you. Thank you. I hope you can all hear me.
Yes, we are hearing you.
Okay. Please confirm that you can see my screen, please.
Yes, we are seeing your screen.
Oh, great, great. So my presentation is on policy, governance, and implementation challenges in Uganda's health sector, but in relation to human resources for health. So briefly, and from the previous presenters, we all know that digital technologies are essential to improving health systems, and strengthening policy governance and financing capacity is essential to ensure that we're able to benefit from digital systems, but also manage risks. In Uganda particularly, as it is in other countries, we rely mainly on digital technologies for human resource planning, recruitment, deployment, performance management, and generally overall human resources for health governance. We have a couple of tools, digital tools that we use as a country. Just to go to the next slide, as you can see, these are just some of the existing systems. And previous presenters have talked about the multiple systems that are used in the digital space. These are just some of the systems that I thought I would share with my colleagues. As you can see, DHIS2, the Integrated Human Resource Information System, MTRAC, the Electronic Community Health Information System, the Family Connect System, and the Uganda Electronic Medical Record System. So these are multiple systems, and some speak to each other, some don't, but all are used by the health workers at health facilities. So, briefly, just to take you through some of the issues that we are facing as a country. As you can see, one of the key issues is the fragmented governance and multiple stakeholders. So we have several donors in the country, previously USAID, CDC, WHO, Global Fund, all funding different kinds of systems. And that has led to a lot of duplication and undermines the interoperability of the same systems because they have different priorities. Then one of the challenges is limited ICT staff. Particularly in Uganda, we don't have a cadre that specifically is assigned to information technology at health facilities, and that is a very big challenge. We only have those cadres centralized at the Ministry of Health, and these move out to support facilities. And with the capacity gaps we have in the country, it's insufficient to support the facilities. We've talked about interoperability. The systems are not interoperable with one another. They don't speak to each other. So you find health workers are reporting into multiple systems, and it creates an extra workload for them. Issues of data governance. We do have a data governance policy, but it's not enforced, and there's no standardization, and it's not actually followed, particularly, for example, in the private sector. Of course, connectivity and infrastructure. The country has about 40% of the country has no access to the internet, and this is where most of the population is, in the rural areas. So it becomes a bit of a challenge to be able to utilize these systems, especially if they are not free to access systems. Weak institutional ownership and sustainability because of heavy reliance on donors for financing and deploying systems, but also lack of financial commitment from the government of Uganda to be able to fund these systems. And then finally, weak monitoring and evaluation to be able to identify how best we can make informed decisions on how to proceed with these systems. Okay. So why does it matter to strengthen policy and governance for technologies in health, particularly for human resources for health? So generally, what we have seen is that it accelerates progress. It supports accelerated progress towards achieving universal health coverage. It improves accuracy, completeness of data. It enhances transparency and accountability. Supports evidence-based recruitment and workforce optimization. It also reduces absenteeism and payroll inefficiencies. Increases sustainability for national at national level and for national programs, but also allows integration into existing national systems at government level. So some of the key recommendations, as you can see, are related to governance, strengthening governance and policy to ensure that systems are registered and they are mapped to existing systems, to also reduce duplicity across the health system, increasing financing by government to reduce over-reliance on donors or other development partners, but also pooling procurement processes. So what usually happens in Uganda is that you have different ministries doing their own procurement processes, and that is not efficient in terms of reducing cost and maximizing the available budget. Capacity, scaling up training programs for health informatics, particularly in ICT for existing health workforce, while the government tries to create a cadre for ICT at health facilities. Investing in local infrastructure, ICT infrastructure, offline modes where you don't have to pay, and be charged highly for the services, but also ensuring that there's interoperability, pushing the interoperability agenda by enforcing the use of national registries, such as DHIS2 and IRIS, so that there's harmony within the existing systems. So I would like to end by giving this quote by Bill Gates, where he mentioned that technology is unlocking the innate compassion we have for our fellow human beings. And I think that is very true, because technology is advancing the way we look at things, the way we look at health, the way we're able to manage systems. Thank you very much.
Yes, thank you. Thank you, Dr. Simon. This presentation in Uganda, as well as Dr. Mavi's presentation from Botswana in the last session, highlights the need of actually we should have some South-South learning going on, because there are kind of parallels, okay, when it comes to certain problems, and there are kind of issues on which we really need to move further. Right now, yes, all these presentations set the tone for more discussion. On one hand, we have to see, okay, on what context we are actually working, okay. Are we so much after innovation that we not able to justify the need of the community for which we are actually determined to provide these particular innovations? So these are kind of open questions, and we really need to think about some kind of a nationwide evaluation is also required with regard to what is the state of the art situation, with regard to all these certain digital health initiatives which are there, and what can be really done in order to actually have a kind of a concurrence in them. There is a language of convergence, okay, between government departments, but each government department, I'm coming from Maharashtra, we see there that every single ministry and the department over there, they are having their own apps. And some of the information, if our public health student, they need to draw, they have to actually draw from various apps which are available. And unfortunately, we saw that some of these apps are not even updated. So what can be done? It is a kind of a public money, and we should be aware about the amount of investment, okay, done by government, okay, in order to come up and manufacture this particular app and sustain this particular app. So this kind of a evaluation, and that particular evaluation, again, I'm trying to refer that when we consider health systems lens and health systems thinking, and nowadays the kind of a focus should be on health policy and systems research, whether there is any kind of a possibility for us to do any HPSR, can we use certain realist evaluation methodologies as such, which will help us to think further, go further, and try to regulate this particular digital health innovations. That is what I would like to say. And I would like to open this forum for questions. Thank you.
So, here at least in the in-person scenario, we see 3 experts from 3 academic institutes. And Dr. Harsh, you very clearly mentioned about the lack of evaluations of the digital systems. We evaluate everything. Dr. Ghosh mentioned about PMJY, all the evaluations done on that, different parameters. I presented all the evaluations that we have done in Bihar for more than 1.5 decades. But for these digital platforms, how we can have a knack of conducting digital evaluations and starting from academic institutes only. Thank you.
Sir, there are a couple of frameworks are available. We did 2 publications on the line of evaluation. Initially, there is a DigiFrame framework for evaluating digital health platforms, whether it is app, web, or anyone. So this contains 10 criteria where it has to be evaluated on different study designs. It includes licensing part, it includes ethical part, and it includes privacy part also. So there are 10 different criteria where one can evaluate a digital platform. DigiFrame is the criterion framework. Second is, there is a checklist. For most of the studies, we used to follow Prisma checklist, we used to follow Strobe checklist, or the concert checklist. For digital health platform, recently WHO has designed iCheck-DH. That is a 20 parameters where 8 parameters are mandatory, and for any digital intervention, one has to document iCheck-DH checklist needs to be used. So that is another part. For diagnostic part, there are different terms that we are a part of ICMR also. So we are working on the Department of Health Research. So where we use 2 techniques. One is the RCT, if it is there. If it's not there, quasi-experimental designs. And if it's not there, then again we would be considering a different technology in terms of what are the data are available. And then we discuss with the, so recently we had couple of done the evaluation of AI technology. And based on that, we had submitted reports to DHR, and we also included cost effectiveness analysis into those areas. The issue in digital health is when we go for the diagnostics, we get only the information of disease part. अगर टीबी पेशेंट पे हुआ या कैंसर पेशेंट पे हुआ है तो हमें डेटा किसका मिलता है, कैंसर पेशेंट का. सो व्हेन वी कंसीडर द ट्रू नेगेटिव वैल्यूज ना, इट्स मिसिंग एंटायरली, बिकॉज टेक एजेंसी क्या होती है, आईटी एक्सपर्ट्स, और हम जैसे यहाँ पे बैठे हैं वहां पे कोई आईटी एक्सपर्ट्स नहीं है. तो another challenge in India is we are not creating stakeholders at certain level, and that's why there is a lack of evaluation framework at everywhere. और एक तीसरा प्लेटफॉर्म फ्रेमवर्क हम यूज करते हैं जो री-एम फ्रेमवर्क है, दैट इज वाइडली बीइंग यूज्ड फॉर टेक्नोलॉजी अडॉप्शन. नाउ देयर आर चांसेस ऑफ बिहेवियरल ट्रेनिंग. ऐसे भी सर प्लेटफॉर्म है जहाँ पे हम ट्रेनिंग्स देते हैं, जहाँ पे हम काउंसलिंग देते हैं, तो वहाँ पे हम टेक्नोलॉजी अडॉप्शन मॉडल, टैम मॉडल करके यूज होता है. दैट इज ऑल्सो फ्रेमवर्क which contains 6 framework, 6 areas. So ऐसे अब models now it is available, and 3 journals are widely being publishing these kind of only articles. JMI publication, and they are using these frameworks only, and if you had not followed this criteria, they will suggest you to follow this. So sir, frameworks abhi design हुए, now we need to build a capacity to train the young health professionals to use these frameworks. Thank you, sir. I hope, sir, I'm...
Soumitra, you want to answer, respond?
Regarding evaluation frameworks? Yeah, I mean, I certainly echo the sentiments expressed by him. You must be knowing the organization called Arman. They are also into digital health technology, the usage of it. So quasi-experimental studies, RCTs, that's something they are also undertaking to understand the effectiveness of technology. But I will slightly say something which may not be popular because we're talking about the use of digital technology. Particularly with regards to PMGY, we have seen that a lot of exclusions are taking place just because we are adopting technology. So we did a study in Palghar, which is not very far from Mumbai. And there the issue of, as you know, that Aadhaar has to be seeded, there is a slightest mismatch of names, then you can't get included. So those issues are also very pertinent issues.
Actually, आज सवेरे से we have several times discussed about data quality, issues with different kind of aspects. This is, I'm actually not asking question as a panelist or a co-panel. This is a very naive question. ये तो वही country है ना जिसमें डिजी यात्रा है. I am telling you, I am not sure whether it actually resonates with you all or not. Every time in those airports where स्कैन नहीं करना होता है, सिर्फ आप खड़ा हो जाओ और अब उसके बाद वो आपको देखे. हर जगह ये टेंशन होता है अगर कुछ गड़बड़ कर ले तो, इफ देयर इज समथिंग मिसमैच, होता तो नहीं है. सो व्हाट इज सो डिफरेंट बिटवीन वन एंड अनदर? दिस इज अ वेरी नेव क्वेश्चन.
If I understood your question completely, there is a segment of the population for whom this should not be a problem. It's not going to be a problem for me because I have different documentations and I can argue for myself also. Right, I'm aware of my rights basically. So the other issue is that how much money we are putting in, for setting up these systems. I was giving a comparison between CGHS and PMGOI. We keep talking about PMGOI, the 5 lakh coverage, right? Have we ever done the simple calculation? How much money was allocated in the last year's budget? Let's say 12,000 crores, 10,000 crores, if we include the state's share. What is the amount of population is to be covered by that? 62 crores, basically. Just do the maths, you will find out. With 200 rupees, how much you can get. And then on the other hand, you have 17,000 rupees. That's the per capita allocation for CGHS beneficiaries. DG Jatra is being used by a certain, minuscule proportion of the population for whom it should not be a problem. But I completely understand from where you're coming, basically. Same system should be developed for everyone because that's the point of city entry. That's the spirit of city entry. Thank you.
Yes. And, Dr. Simon, whether you would like to, just a minute, would you like to reflect on these questions which are going on? Hello? Okay. I think we'll move to the next question. Yes.
First of all, congratulations to all the panelists for this insightful discussion. My question is for Dr. Ghosh. It's actually a two-part question. First of all, as PMJY or similar schemes scale, there's this wealth of data that I personally believe that can drive fundamental decision making. So, according to you, what's stopping us from merely moving from this descriptive analytics, say who is covered, what sort of services are getting covered, and so on, to a predictive modeling that can actually lead to fiscal sustainability of UHC in the long run? And the second part is, what's your take on, say, preventing the frauds and also maybe the optimizing the package pricing using this wealth of data? Because we have seen there are instances using big data that what should be the optimal package pricing, because the way you were saying that, say, comparing CGHS to PMJY, I don't believe that's a fair comparison because those are meant for two different kind of things, two different kind of customer base. But what should be that optimal package pricing? Or say, how do you prevent fraud using that data? Thank you.
I'll start from the last question that you asked me. What should the optimal price? That depends on the perspective that you are adopting. So if I look at it from the societal perspective, then I'll have to see how much does it cost me to produce this service. If I have that information, then I can price it better. And I can also give them some top-up. What is going to be the remunerative price if I know the cost of producing that service? So it has to be cost-based pricing. We can use or leverage the volume, something that Medicare and Medicare, they do basically in other contexts. So that's something we got to do. Having said that, I do believe that benefit package prices have been revised, and most of the states are yet to implement HPP 2.0. And that is something that the important stakeholders like private hospital providers, they're really clearly not happy with the package rates. So again, you need regulation here. As I said, the problem is that if you believe in a free market philosophy, I'm sorry, it's not going to work. If it's a half-hearted attempt, basically. You really want to wish to intervene in the market, then please intervene in the market and set the norms, basically. You have to basically get the private sector on board. Look at the performance of PMJY in Bihar, in UP, and also in Maharashtra. We have been having this program since 2011. It started with Rajiv Gandhi Jivandayi Arogya Yojana. But if you go to the, not even rural areas, tier 2, tier 3 places, most of the, first of all, private sector is not there. And if they're there, they don't want to provide services to the PMJY beneficiaries or, the beneficiaries of state-sponsored health insurance programs. Even if they provide, then they will say, this was not covered or that was covered, and for which you have to make additional payments. This is simply the reason, from the data you have seen, that almost every single household which made an attempt to use the benefits of PMJY, they have reported to have incurred out-of-pocket expenditure.
Yeah, Soumitra, can you be brief, because we are running out of time.
Sorry, you had two other questions, I believe.
So mine is, because as Dr. Shah also mentioned, how do we leverage AI or in general the health information technology to get to those predictive or prescriptive models? Because what you were saying, of course, these have been, the package pricing have been revised, and there have been some work, as far as my knowledge goes, done to prevent that frauds, this financial frauds pertaining to PMJY. But how do we leverage that, and where is that effort? Because I'm not personally aware of any such.
I'm sure you know what is DRG codes.
Yep.
So there is no, I can't say there's a magic wand. It sounds great. Use AI, you can detect frauds. That's something the parliamentarian raised in the ongoing session. I'm sure you must have read the Indian Express report on this.
Yes.
They're talking about fraud. The problem is, that's why I mentioned supply-induced demand.
Yes.
We are too much focused on moral hazard, thinking that the patients are going to be the enemies of this program. They are not the enemies. It's the supplier. It's the providers who are trying to misuse this program.
Yes.
So I think the focus has to be on that. And having said that, as I said, if we can't strengthen our public health system, you can't succeed. You can't even implement PMJY, because in most places, only public sector is present.
Yeah, PMJY is a kind of a big story. I think I encourage both the persons to actually take this into the break. Okay, so with this, I think we have to conclude this very interesting session. I thank all the panelists and Dr. Simon, who also joined online here. Thank you.
Our sincere thanks to the chair and panelists for this rich discussion. I believe key takeaway is the importance of strong coordination, workforce capacity, and policy clarity to support digital transformation. We deeply appreciate the practical insights shared. Now we would like to proceed with the felicitation of our chair and panelists. I request Dr. Abhay Kudale to felicitate Dr. Soumitra Ghosh. Now I request Abhay sir to felicitate Dr. Harsh Shah. Now I request Dr. Sanchita ma'am to felicitate Dr. Abhay Kudale.
Thank you so much, sir. Coming up next is our final panel of the day, Data-Driven Decision Making and AI Applications in Health, Leaving No One Behind. This session brings perspectives from leaders advancing digital innovation in public health. We are honored to invite Dr. Santosh Kumar Pandey to chair this session. Dr. Pandey, CEO of Tata Steel Medica Hospitals, brings over 27 years of leadership in hospital quality, digital health, and patient safety, including international engagement with WHO. Thank you so much, sir, for coming here. I request, sir, to kindly invite our respected panelists on the dais. Handing over to you, sir.
Thank you, and I think we are in the last session of the day. This has always a plus and negative part. The plus part is that a lot of things which we are going to discuss have already been discussed, so we may save time on that. And the negative part is, of course, that for some of the things might be repetition for you. So before we proceed, I think I'll invite the co-panelist. Dr. Arunava Dhar will be joining us from NHS London, UK. We have Dr. Nishant Sagar, who is Associate Vice President, Healthcare Robotics Consultancy. Dr. Preeta GS, Professor and Dean, IHMR Delhi. Professor M. Sivakami, again she is also going to, from TISS, she is going to join us online. You know, before I begin the session, I am reminded of two things. Dr. Tanmay said that every data is not just number, it talks about the life. And the second thing I am reminded of this Amitabh Bachchan story. Once he was looking for a job and in the beginning of his career, and then always his father used to tell him, "Tum kuch ka nahi karta hai, naukri nahi milta hai tumhara." Then he keep on shouting him. तो अमिताभ बच्चन एक बार अपने पापा को नोट लिख के भेजे कि पापा आप मेरे को बोलते हो कि मैं कुछ नहीं करता हूँ, ऑलरेडी जब आपने मुझे पैदा किया था, मेरे से पूछ के मुझे पैदा किया था कि यू कीप आस्किंग दैट मैं कुछ नहीं करता हूँ. With this, I am reminded of this story of Dr. Isha Roy. I think she is from Berkeley University professor, and she said that we don't have any influence on where we are going to born, because otherwise we'll always like to take birth in rich family. Always everybody would like to take birth in US and developed countries, but the pin code, the area where we are born, the address in which we are born, that determines the outcome of the neonatal and mother. That means that healthcare facilities of an area determines that what is going to be the outcome of the family, the mother and the family if they are sick and all that, even in public health sector. So with this, that means there is a divide of healthcare system. And that divide could be on variety of reasons, could be because of address, because of the healthcare facilities there, because of the availability of infrastructure, and other things, and genetics, race, and all that. So we, in this session, are going to talk about the same thing. The topic of the last session is data-driven decision-making and AI applications in health, and leaving no one behind. So we have with us 4 eminent speakers, and I will first invite our Dr. Arunava Dhar. He will be joining us from UK, and I think Dr. Dhar is a consultant pediatrician and neonatologist based at Aden Brooks Hospital, Cambridge, and clinical entrepreneurship fellow with NHS England. He co-develops digital innovations such as remote neonatal care platforms and is involved in health tech ventures and medical education. So today, in private sector, Dr. Ravi also talked about this morning, the technical divide, how hospitals are getting smarter. We have this remote monitoring system, especially for neonatals, which is going to help, which has actually helped us improve the outcome of the neonatal, especially in far-reach area where there is no pediatrician, there is no neonatologist and all that. So with this introduction, I invite Professor from UK. I hope you can hear us.
Yeah, I can hear you. Am I audible?
Yes, you are audible, please.
Okay.
Good afternoon, evening, because my time is good afternoon. As I was introduced, I'm Dr. Aruna Budhar. Forward that if someone's, it should not be abstract thinking or like personal choice that it is, or I would more say like driven by the profit makings. That should be the data driven, all the decision makings, which AI based tool or whatever algorithm we are going to use, whether does that prove any evidence in terms of data driven decision, and how much it is reducing the inequalities or whether it is equitable in distribution or not. Next slide, please. So if you look, why I said that, because if you look at, I'm just looking at two things. One, that how much we are burning out, like the healthcare providers. So now if we look at globally, the 31% nurses, we see it in the Western world too much, that nurses intend to leave their direct patient care job because they are like feeling like totally depleted, exhausted because of the workload, mental distance from one's job because they are doing it for earning rather than doing any other, like rather than engaging in the job or they like it or loved it. When they started their career, probably the situation was not the same. And like gradually they're losing the motivation to go for the professional development, resulting in reduced professional efficiency. And also in that way, the other way around, if you look at that, I've just given a data for like the US-based data, but you can see that 77 million people face there is a shortage of provider in US alone. If you want to do just an X-ray, it is so costly if you do not have the insurance or if you cannot provide the insurance, let alone the other high quality AI generated products or intervention system to achieve or adopt or use. So this is a clear example of disruption of care delivery, and the people are not being able to access the care they should. Wants, what the family wants, and ultimately disease lies in the patient. So it has to be patient-centered. family-centered. And to understand that, it needs a good collaboration, good partnership while we are developing it, rather than after developing, sending it to the like the clinicians or the healthcare allied health personnels to be customized and optimized with that thing, or like habituated with that thing. That will not cause good for the patients or parents or family. Next slide, please. So while those are the like loss of good, nice words and promises, we have some risks inbuilt in it actually. So first of all, I would mention about all these have been learning through data. And unfortunately, all the training models, whatever they are doing, are working on available resource data. So in first instance, as its global inequality is always everywhere paramount, so the data collected from every corner or every part of the world is already biased. And with that biased data, basically all the algorithms is being made up. So now these unrepresentative data sets, say for example, I have given an example, pulse oximetry, oxygen in patients with darker skin tones. So think about sub-Saharan African areas. How many kids are being screened at the time of birth for cardiac monitoring or cardiac situation, or exclude any congenital heart disease with pulse oximeter? If it is not there, then how will you get the data from there for them to incorporate or feed in the algorithm to find out what should be the pulse oximetry's like light intensification and report back? So it's not possible. Next, I'm coming to the data gaps. So there are always a huge data gap, what I mentioned before, from the ethnicity. I work in neonates and pediatrics. I see that all the WHO charts are made from the Caucasian population mostly. And the reason why I say that, when I started working in NHS, I realized all the Asian boys and girls, like those are newborns, they are below at certain centile. Then I realized it's basically their data sets, their predictions, everything is made mostly at that point in time with the Caucasian data set, Caucasian people's data sets or babies' data set. So that is there. Now loss of context, if you think about that, now it's basically, it's not like it's just booming, it's just big. But like we are losing the context, the problems at the ground reality, at the base level, we are not looking. The 10 years plan for the NHS yesterday, I was reading that all the parameters, we are going downhill. If you think about housing, if you think about the income. So without looking at those social determinants of health, how can you get the context of taking it forward in an advanced way? This is another thing. I think I'm seeing it in a way that is probably need to look at. And next is access divide. That comes from the problem which I mentioned in number 1. Because if you are not starting the point with equality, then you are going to get a situation when there will be the available options will not be equitable. So the system are more likely implemented in financially robust urban academic hospital, tertiary hospital like Cambridge, Oxford, Harvard, Delhi, Calcutta. But what will happen about the remote areas, both in Eastern and Western world, the gap, this will remain, and it may increase if we do not act from now on. Next slide, please. So if I think about the problems that I mentioned, then apart from that, there are another set of problems. Then how can we think about it? Like, first of all, over-reliance. Nowadays, we are looking, when I see the new trained graduates, medical graduates, they are like gradually over-reliant and more comfortable sitting in front of a computer rather than facing a patient and touching patients to see the clinical signs, exploring the symptoms, etc. So this is not going to be great, because clinical skills, if deteriorates, ultimately all humanity and civilization will get that impact of that, because AI cannot treat a patient and AI cannot cure. It can help the clinician to augment the decision. So if we are like new generation of doctors, it is very good to be advanced, but at the same time, we have to learn, because we are a generation, we learn in a traditional method. But we are heading towards a generation who are learning from the newly skilled method, which is technologically aligned. That is very good. But we need to make sure they are also engaged with the like the conventional pathways. Think about the patient alienation. Already we are alienated those who cannot provide for their own health. Most of the countries, apart from few European countries and few places in India, few places in in UK NHS, I would say at the delivery of care it is free. But most of the places where you are not think about like diabetes management, like type 1 diabetes management, you can have AI-driven algorithm to push insulin. That is true. But if you do not have that equipment, if you do not have the monitoring system, if you do not have the provision, then then ultimately your innovation or all these things are going to be alienated from the main patient pool. We will serve a short, very small cohort of patients, and we'll think that we have done a lot for the new era or for the sake of civilization. Now, think about the misaligned incentives. Now, what is happening? Because of, as I was mentioning as 10 years health plan in NHS, the second plan is, the main second plan is like move from digital, analog to digital. So that means basically prioritizing financial efficiencies at the expenses of meaningful improvement in patient care. So now the key parameters index are going to be changed gradually from the patient parameters rather than to see how many patients are booking the appointments through their NHS apps. So is this the right thing to think about? I think there are food for thought in it. So definitely that we should encompass what new and what is important. I'm working on it, but I would say that with a little bit of slightly cautious thought process. Next slide, please. So the path forward, what it could be. So first of all, I would say, like from what we learned from our good medical practice, that 4 component of ethics. One, like beneficence, non-maleficence, autonomy, and justice. It's not the scope here. So only I would mention, we must think about the autonomy of the patient. Should we augmenting without their consent, without their intent? These are the things we need to think from now on. So humans should remain in control over the healthcare system. I should be, the doctor, the healthcare professional, the patient should be in control with the healthcare system and medical decision. AI is a tool. If I want to use it. I want to use and augment it for good. If I do not want, as a doctor, if I feel this is the best decision, that should be the best decision. Algorithm, even if it has the data, why I mentioned it before. I should not be relied on that. I should go ahead with the learning what I learned from my experience. Number 2, ensure the inclusivity, equality by design. So from the beginning, if we think about the diverse and representative data, involve the staff and patients, communities, all over the globe, not a specific community where they can provide and where they can provide for money for doing the investigation, doing the tests, doing the new research, not only that areas. You have to think about the disadvantaged, marginalized groups. Otherwise, the whole data set, whole intention of doing things is going to be wrong. Jaundice, skin color jaundice, you cannot compare with the Caucasian skin with the, if you think about Afro-Caribbean skin. I'm actively working on that, and then I found that it's not easy. So if you just put it straight away, the way it's coming as data, it's not going to work. Next, third point is transparency and explainability. Definitely, technology is good. The AI will take us to the next era, definitely. But at the same time, we need to be clear that what we are doing. Google has all data now. They can monitor where my whole calendar probably will find in Google if the Google wants to extrapolate it. But does that necessary? That is the question. So we need transparency, why we are gathering data, why we are trying to evolve a new algorithm for a specific situation. And the most important bit, I think, accountability and governance, most important, because at the end of the day, we are human beings. We have our own rights to live. We need a very strong and stringent governance system. Whatever we are doing, when we're implementing it on the human being. Next slide, please. So that was overall the thing, what I thought I told you. And future of health is not automated. If it's automated, then it's going to be a sci-fi movie. It's not going to be human civilization. It's amplified. So, and our task is to build a system where AI empowers every clinician and serves every patient. This is not just a technological challenge. More importantly, it is really an ethical and social mandate. We need political will to implement it. If it doesn't happen, then this will not be implemented. It will be another innovation like many others, which will not reach to the people who needs it most. Let's build a healthier world together, leaving no one behind. Thank you.
Thank you so much. I think you highlighted the gaps and also gave the solutions, talking about protect human autonomy, ensuring the inclusiveness, fostering the transparency, establishing clear accountability and governance. I think these are the few things which is very, very important. And I'm sure many people would be asking, wanted to ask different questions. Even we would like to ask a few questions, but I think the next speaker he has a flight to catch, so we'll take his presentation and then we'll come at the end of that, we'll take the audience questions. So now I invite Dr. Nishant Sagar. Dr. Sagar is Associate Vice President for Healthcare at Rodic Consultants Private Limited, where he works on health infrastructure, hospital projects and advisory services. Public health information highlights his involvement in health sector. So over to you, Mr.
Thank you. Good evening, everyone. So may I have a presentation, please? Yeah, so I will be more focusing on the last sentence, that is leaving no one behind. So I think lots of discussion on the digital health, information technology, the framework, the guidelines, the data privacy, etc. The last speaker just told, like AI or any algorithm cannot understand the human sentiment. They cannot understand what patient wants, what family wants. So I would like to show you this picture. So this is not working. Okay. So anyone can guess what is this? Shopping, yeah. So right, it's a marketplace basically. It's a crowded marketplace. Maybe if someone is from Delhi, Buddha Bazaar, Braspat Bazaar or something like that, and even Patna also, we can find such type of scenario in Gandhi Maidan or whatever. And what is this? So we can see the similar type of crowd at the OPD registration desk of the hospital. I don't know the name of the hospital, even I cannot disclose that, but yeah, this is OPD queue for the registration. So patient and families doesn't understand your AI, your algorithm, your data governance, your policy, but they want the basic things. The first thing, the ease, the accessibility, the equality, and these basic aspects they understand. If they are visiting hospital, are they getting a glass of water free of cost? Are they getting a good sitting arrangement? Or they're getting definitely then clinical care, your laboratory services, your bed management, etc., etc. But these are the first thing. If you're entering in a hospital with such type of crowd, मुझे तो देख के ही घबराहट हो जाएगी कि what's going here. So this is the real-time scenario. So now, what is the digital transformation? So lots of discussion on this. Definitely, for me, if I'm getting a paper written by hand, or if I'm getting a paper printed by a printer, doesn't make any sense for me. If that is not giving any ease for me to access that healthcare services Definitely quality healthcare services, I would like to add. So if you are thinking for the digital transformation or AI or whatever, the data-driven policy should be there. So data-driven policy means if you are capturing a data, we are creating a data golden lake or whatever the language you want to use, standards, whatever. Abha ID and the EHR, what is the benefit we are creating for the population? So AI-powered system is important, but it should be inclusive. It can be for the ASHA worker, it should be for the me, it should be for you, and it should be for the everyone. So it should be inclusive, without any barrier, gender, location, geography, whatever. So a patient journey is not into the hospital. So whatever we are discussing, that is within the hospital, the registration, the curative part of the health basically, we were discussing. But what about the pre-hospital care? What about your community outreach programs? What about the different departmental programs like Anganwadi Center? They are doing something related to malnutrition or nutrition. What about the water and sanitation department? What about the climate department? What about the Ministry of Forest and Environment? So are we taking care of these things? Because we should take the 360-degree approach. It should be the life cycle approach, like Dr. Santosh told. Like if you are not taking care of the neonat and the mother, then you are not doing anything. So the approach should be 360-degree. It should be life cycle approach, the preventive part, the promotive part, and then the curative part, which is in the hospital. And definitely this is a very old statement that digital transformation can be disruptive. There is nothing much to discuss on this. Yes, this can be disruptive. Someone told about this change management part. So I always focus on the change management part. Definitely you can procure hardware, you can procure software, you can make state-of-the-art software, compliance, EHR, everything. But what about the human mindset? So for me, the change management is the human side of the change. So are we ready to adopt this change? Can we talk to the doctors to adopt these changes? Doctor can enter each and every details correctly into the system? Then only your data will speak some meaningful insight. Otherwise, if I am writing a 5-year-old baby height is 6 feet, that data is garbage for me. So are we capable enough to teach or train? Teach is not the right word. Train the clinician, the nurses, the paramedical staff, the public health professionals. So how important the data is. So that change management is very important, and definitely that is going to disrupt your entire system. And I would like to share with you, we are implementing Bhavya in Bihar. Bihar Health Application Visionary Yojana for All. I think बहुत सारे लोगों को पता भी होगा what we are doing. So that is one of the largest digital health program, implementation program in public health setup. Like we are implementing this into the 13,000 government hospitals, starting from the health sub-center till district hospital. So we are creating, every day we are creating lakhs data sets, generating electronic health records. But again, anomalies are there. How we are going to deal with that? How can we do the corrective measures? That will speak your insight, into your insight. So definitely we know AI can save the future. Nothing new in this. We are wearing a smart watches. Every third person is wearing some type of gadget, mobile phone, speed tracker, your walk tracker, your sleep tracker, this and that, human biotracking we are talking about. But how you are going to implement, how you are going to sensitize the population at the community level, that is the most important part. Definitely through AI we can go for the disease prediction, we can forecast your supply chain management, clinical care we can improve. Many organizations are doing something very good with the AI, like lung cancer detection, breast cancer detection, tuberculosis detection, KORI is there, Badwani AI is there. Many organizations are doing a lot of work into this. But how can we reach to the last mile population? That is the major challenge. 5 years back, 10 years back, we all are talking about the rural health population. NRHM was there, then NHM is there. Now everyone is talking about the urban health mission. Urban population, the most vulnerable population. So you can visit Mandiri area somewhere, sometime. So you can see many people are living just over this drainage system. I don't know today that scenario is there or not, but I have seen. So we need to incorporate each and everybody into the entire ecosystem, then only you can think about the AI and data-driven policy. Definitely challenges, there are lots of challenges, barriers in the digital health system. Like I told you, the biggest, what I see, that is your human side of change. And there maybe someone can say internet connectivity, your mobile devices, your hardware, your interoperability, and lots of changes. And definitely we know, at least this audience know how to mitigate. So growth drivers, that is a very important thing. So the first, I would like to take the name of the growth driver, that is ABDM, Ayushman Bharat Digital Mission, which is the responsible body of the Ministry of Health and Family Welfare to create this digital ecosystem in India, which should be interoperable, and definitely the UHI and everything they are taking care of, the ABHA ID, your health professional registry, your health facility registry, etc. Definitely lots of capital ventures are entering into the health, and they are investing, they are ready to invest into the digital health market. This market is growing. Then the third is your increased use of mobile phone. Everyone is having at least one mobile phone. Even in the family, 5 member of the family, 4 is having some type of telephone, which is either iPhone or Android phone. And definitely the rising demand of the patient, remote patient monitoring care like tele-ICU or teleconsultation because of the population, the low doctor-patient ratio, etc. So these are basically the growth factors for the digital transformation. And then it's pushing actually to adopt the digital things. So you can see the right hand of the PPT. This is a real-time dashboard snapshot, what we are doing in Bihar. So we are talking about the digital data-driven AI analytics-based policy. So you can see the map of Bihar, so real-time dashboard we are having, and from there you can predict what is going to happen with your supply of the paracetamol or amoxicillin. You can also see the consumption pattern, you can see your human resources deployment, you can map what is going where. So you can map the individual, you can map the facility, and you can map the entire state. So this is the real-time dashboard right side. You can see one snapshot is there, the bed occupancy in the certain hospital, doctors consultation ratio, how many patients they are consulting every day, and different type of data is there, the consumption pattern of the different medicine you can see at the real-time level. This is very interesting. Like NFHS 5 we are having in every 5 years. And we need to wait for 5 years to understand the scenario of the particular district or particular state or the country, what is going where, the stunting, the family planning modalities, the adoption, and ANC adoption, whatever. You can see this is the real-time dashboard the Bhavya is having, where you can see the stunting proportion. Like if doctor, the vital is a very small thing, which everyone is doing in the hard copy system and in the soft copy system in the digital ecosystem. Like you're taking your BP, your pulse, your weight, your age, your demographic details, etc., etc. So, but if you're correctly measuring each and everything, we can go with the BMI, your height and growth, you can figure out stunting, your vesting, everything you can track. And if we are having such type of data set, lakhs of patient registration and consultation every day, why we cannot create our own NFHS? Every state can do it. There is no need to wait for another 5 years. Even you can track the progress into these 5 years. So digital has that power where you can do the live thing. Every day you can track your progress. Definitely not all the outcomes I am talking about, but you can track your progress, your adoption rate, your prediction modeling you can do. You can forecast your supply chain, and definitely then the end user will be more than happy. So again, these are the few snapshots of the dashboard. That is, even we are able to track the antibiotic uses, the rational use of antibiotic policy state governments can have. So these are the real time. So also we have made the SAJ application, Sehat aur Arogya ki Jankari. This is application for the community, for the patient, for the people of the Bihar, where they can track the services of the Bihar government, the nearest health facility, the availability of the medicine, and everything is live, real time पे they can track. बेड कहाँ पे कौन सा अवेलेबल है, कौन सी दवाई कहाँ पे अवेलेबल है, which facilities are available in which type of facility, उसके MOIC का मोबाइल नंबर क्या है, वहाँ पे किस तरह के बेड्स अवेलेबल हैं, and this is a screenshot for the same. You can see the bed availability on the right side and the type of hospital on the first screenshot. This is also so transgenders. So I put it this slide because no one talks about these things, this marginalized population. So in the hard copy system, why I'm showing this? Because I wanted to say that digital has that power to give the equity to everyone and accessibility to everyone. In the hard copy system, you cannot understand how many transgenders coming into your facility. Their health needs are different. Maybe, I am assuming that. And if something came in mind about the transgenders, maybe I have 5 bullet points, but real-time data can speak something else. So now you can say, see, it's a small data set I'm showing you what type of disease burden transgenders are having, in which facility they are going, which level of facility they are going. You can also see this map of the mapping of the ground level facility. This the left side, we have shown this HSCs are there with the red dots. So these are the real-time data where you can reframe or frame your policies according to your state, according to your district, or definitely for the entire country as well. So I would like to ask the audience, what is the future of health? So I'm not talking about, again, the AI, the digital, the paper system, or whatever. So are we expecting this? एक patient को stretcher नहीं मिला और he's holding someone, I think maybe father or son, he's holding someone in the lap, and the second cap खो गया cannula का तो syringe लगा दिया. So are we expecting such type of healthcare? Or we are expecting this, जहाँ हम घर में बैठे हो और ड्रोन दवा डिलीवर कर रहा हो. So I believe most of us would like to see such type of healthcare where ease, accessibility, equity would be the principle to deliver the outcome of the good healthcare services, quality healthcare services, and definitely better health outcomes for the nation. And definitely the digital health is, it should be patient-centric, ethical, and future-ready. So thank you. Thanks a lot, everyone, for patience listening.
Thank you so much. I think you rightly said that bridging digital divide largely rely on successful implementation of digital programs, which basically needs proper change management and change of mindset of the people. I think one way to handle it, there are a lot of ways we'll discuss it. People have discussed. One way to handle is like involvement of the design, human design concept. Because if we have already, like it's like many times the researchers and the research students comes and then sir, after at the time of their analysis part, they'll say, sir, kaun sa test lagega, kaun sa model lagega, isme all that. Whereas at the time of your synopsis itself, you know that what is my data, what I want to achieve, and then what kind of testing, how you're going to achieve that output. So that way, if we start implementing the human concept design in the beginning itself at the time of developing any digital platform or programs, most of the issues will, of course, get sorted out. I know you have sort of time. If you want to leave, maybe I'll allow the organizers to present him bouquet, the memento, so that his flight is at 6:15, what I was told. Meanwhile, if anybody has a specific question to ask with Dr. Nishant, maybe we can take one question.
I've been involved in a couple of this kind of platforms for other states. मैंने उनको बोला कि ये जो डिसीजन मेकिंग है, बहुत सारे लोगों को डैशबोर्ड पढ़ना नहीं आता और हम उसको एक्सपेक्ट करते कि पढ़े. तो अभी मैं बनिया हूँ सर, गुजरात से हूँ, तो स्टॉक मार्केट में अभी एक AI का बटन आ गया, तो जितने भी पोर्टफोलियो में है वो बता देता है कि इसका स्टेटस क्या है. सो कैन वी पुट दैट आई बटन where they can press it and get understanding? क्या वो बहुत costly होता है services?
So, frankly, I will speak on this. AI is not mandatory actually. Yes. We need a basic intelligence to understand the data. Yes. Okay, AI will give you, definitely will add some value in that, but to start with, there is no need to put lots of money and AI and algorithm and machine learning into that. So like I will give you an example, sir. So हमारा जो डैशबोर्ड अगर आप देखोगे तो इसके अडॉप्शन, सक्सेसफुल अडॉप्शन का रीजन यही है कि इट्स वेरी सिंपल एंड आई बटन इज देयर. सो आप कुछ भी डेटा पढ़ना चाह रहे हो, लेट से आप फैसिलिटी मॉनिटर हमारा खोल रहे हो, आपने आई पे क्लिक किया तो आपको पता चल जाएगा कि उसमें क्या मतलब है, बिकॉज डेफिनेटली इट्स ए स्टैंडर्ड लैंग्वेज, बिकॉज वो डेटा जो समझने वाला है वो हेल्थ प्रोफेशनल है, एडमिनिस्ट्रेटर है, नॉर्मल कॉमन पीपल नहीं है, तो उसकी लैंग्वेज में वो लिखा हुआ है. सो ही और शी कैन अंडरस्टैंड. फर्स्ट. द सेकेंड, द यूएक्स यूआई पार्ट. अगर वो यूजर फ्रेंडली नहीं है तो विल नॉट अंडरस्टैंड. एंड द थर्ड, एआई इंपॉर्टेंट हो सकता है, इंपॉर्टेंट है, आई विल नॉट टेल कि नहीं है, but basic norms है, like I told, vital. So 5 साल के बच्चे का क्या height 6 feet हो सकता है? It's an alarm. Yes. मतलब you can use the simple thing, simple Excel thing, Power BI dashboard or whatever to figure it out. क्या एक 50 साल के आदमी का या किसी भी उम्र के आदमी का height 10 feet है इंडिया में? मतलब अगर होगा भी तो शायद एक होगा. If you are getting 100 data sets एक ही facility से, it means there is need for some preventive action. I will not take you need to punish, but preventive action, training, capacity building, whatever. Yes. We are also finding some data sets जहाँ पे एक nurse है, वो 1000 मरीज का उसने vital लिया 1000 patient का, और 900 patient का उसने 120/80 लिखा. Maybe सही होगा. I'm not telling it's wrong, but can we double check? You are talking about the HMIs, I think, in your presentation. You have worked with the interoperability, RCH वगैरह. So जो RCH का HMIs का जब देखोगे 2.0, so there are few basic things. एक सब सेंटर से डेटा आ रहा है या एक जिले का डेटा आ रहा है, तो 5000 लेट से कि आपकी एएनसी हुई. आपने 7000 मरीजों को कैसे कैल्शियम और आईफे बांट दिया? आपने सीजेरियन हुआ, लेट से आपके डिलीवरी हुई 500 और आपने 700 प्रेग्नेंट लेडी को ब्लड दे दिया. So you know, these are the basic understanding. जिसके लिए
I think you'll miss your flight. So
no, I'll just conclude. So these are the basic understanding which we need to put into the data set to understand, and definitely AI will help.
It's not costly.
Yeah, it's not costly at all. Thank you.
Thank you so much, sir, for your insightful thoughts. Since you are running late for your flight, I would kindly request Dr. Santosh Kumar Pandey, sir, to felicitate Dr. Nishant Kumar, sir, Nishant Sagar, sir. Once again, thank you so much, sir, for joining us today.
Thank you. So with this, I think now I invite my next panelist, Dr. M. Siwakami. She is faculty at TISS, leads at the work on gender, reproductive health, population studies. Her research addresses social determinants, family planning, and health policy, and she is widely engaged in teaching and mentoring public health professionals. So over to you. I know you couldn't come here because of the Indigo fiasco.
Thank you, Dr. Santosh. Can you hear me? Just confirm that you can hear me.
Yes, we can hear you.
Yeah. Thank you so much. Good evening and good afternoon, distinguished colleagues and participants and friends. First of all, let me start by thanking Dr. Sanjita for the invitation to join today. It's absolutely an honor to join the important conversations on innovations in health, information technology. I miss being there in person at the conference for the session, and thanks to the Indigo chaos currently, my return flight got cancelled, so I had find it difficult to kind of come there, then get stuck over there and not proceed for my next commitment tomorrow that I'm traveling to Hyderabad. So let me start with a confession. I am not an AI or digital space expert in public health. I speak here as a researcher who uses gender as a lens to look at the public health problems in India. Hence, clearly my interest is always on how do we reduce gender inequality in health in the era of digital and AI transformation. At a time, India's digital health architecture is evolving at an unprecedented pace. It's an apt time that we all have gathered here collectively to explore how data-driven solutions and AI can strengthen our health system. At this juncture, one of the critical questions we all must ask ourselves is who is being left out or who is being left behind in our digital transformation, and what will it take to correct these systemic inequities. I think for me, that's a critical position when I look at the public health from a gender lens. And let me begin by a story from the ground that has a huge relevance for our today's theme, and also to highlight the fragmented data system and fragmented data trial that we live in the AI transformation that we all are living in. In one of our recent projects on migration and health, we recently met with an young migrant woman who had moved across 3 states in 4 years due to her husband's construction work. Each move erased her antenatal health records. Paper-based, inconsistent, and never integrated into any state system. This is our digital transformation era. She told us, Didi, I kept starting from zero. So she said, I kept starting from zero. This is a simple statement, but illustrates the core challenges we face despite our digital transformations over the years. Like this young woman, millions repeatedly start from zero because our data systems are not designed for the realities of mobility, gender, and marginalization. This leads us to ask ourselves, and we strengthen such critical gap in India's digital ecosystem. India's digital public health ecosystem, like the Aadhaar, ABA, UHI, eSanjeevani, are all global standards, are global models. Yet, I see 3 systemic gaps that limit the equity of our digital health transitions. First, let me begin by saying that there is a weak gender disaggregated and gender sensitive data. Our digital health platforms frequently omit, like our paper records, sex, gender identity, occupation, indicators of mobility or vulnerability. Women's lower digital access produces systemic sampling bias, distorting the epidemiological trends and algorithmic predictions. That can create weak disaggregated data from the gender lens perspective. Let me move to the second aspect that I want to highlight. And in this country, migrants are invisible in our health records. India's 450 million plus internal migrants do not fit the assumption of stationary population that the most health systems often rely on. Their fragmented health journey leads to incorrect denominators. We saw during the COVID, it stared in front of us, and weak cohort tracking and misinterpretation of disease risk patterns. Unless collectively we find ways to address the issue of migrants' health in this digital transformation era, we will continue to leave behind millions and millions. The third group that I want to talk about is the underrepresentation of marginalized groups in AI training data sets. AI systems often rely on urban, clinic-based, digitally visible data sets. This includes tribal communities, informal workers, pavement dwellers, women with low-tech access. This clearly leads to algorithmic bias. Hence, my humble call for the AI and digital space innovators is that can we bring or build equity by design? And our first speaker in the session highlighted very eloquently why the need for the equity by design. Equity in digital health should not be as a moral aspiration, but should be a core design by default. In my limited understanding, an equity by design framework for us in India need to capture at least 3 basic components. There may be more as we evolve over a period of time, but for now, at least these 3 basic parameters need to be met. The first parameter that I want to highlight is the whole set of basic parameters, or what I call the mandatory demographic parameters, like which has sex, gender identity, migration status, occupation details, and disability details. This must be paramount for any innovations that we develop in the AI space and the digital transformation space. The second one, we must build completeness and missingness audits to detect who gets excluded and who gets included. That must be our second commitment for while we building the innovations. The third one, I think both my previous speakers highlighted, interoperability protocols, which enable the persistent portable health identities for migrants and mobile populations. So all of this can have the potential to get us to global benchmark by embedding us the equity principles into the architecture of the digital health ecosystem. So this leads us to ask, where do we begin, or how do we begin to address the digital gender divide? Possibly, in my limited understanding, we must adopt low literacy, multilingual, and multimodal interface when we develop innovations, whether it is using the voice or developing an icons or any other gesture-based navigations. This is very, very necessary given the kind of diverse population that we have in our country and the diverse geography that we all come from. The second one I want to highlight is that probably we must actually bring in women-led data validation networks to leverage our ASHAs, our self-help groups, and community organizations. In my mind, these are not the peripheral interventions, but they have the potential to directly improve the model performance and equity. That's how we bring in the philosophy of leaving no one behind. Next, given that we have over 450 plus million internal migrants, integrating migrants' health into the India's digital architects must be our priority, and we no longer afford to exclude that. So designing for mobility requires at least three major things. One is the portable health records with seamless cross-state access. I don't think we've evolved while we do a number of things to address or bring in the digital transformation. We are yet successful in bringing the portable health records with seamless across the state. And the second one is the interoperable registries. And this interoperable registries not just actually focusing on health, but also the other domains like labor and social protection sectors. This is very, very necessary for a population like the migrants population. And we must also build temporal metadata to track the mobility-driven care discontinuation. And this will enable us to provide the continuity of care. And today's world must actually always ensure that wherever we are, continuity of care must be at the center stage in our innovations. If we do not design for the migrant population or for mobility, our AI systems and digital space will misclassify migrants as non-compliant when they are simply in transit or moving for survival. There is a lot possible with AI and digital space today. For example, recently in the slums of Mumbai, we met a young girl who was learning to use an AI-enabled mental health app. She said to us, "This is the first time information is coming to me and coming to us." This is what digital health can achieve when systems are inclusive by design, information that is timely, portable, and empowering everyone, and not only the one who can afford or who has the agency. So in order for us to translate all of these aspirations that we have, I can think of 4 or 5 larger buckets that what we must do in order to not to leave behind anyone. One is that at the national level, we must establish national standards for equity by design in digital health. So irrespective of what are innovations and equity by design need to meet this national standards. This means that you mandate demographic data, missingness audit, and bias assessment across all government-supported systems. Second one is that create a migrant data integration framework so that we don't leave behind migrants. Third one is that we must have a gender as a main focus, and AI on health must understand the gender diversity. The fourth one is that I think the previous speaker highlighted that there must be a regulatory framework for algorithmic fairness in health, which will capture people from across all parts of the diversity, so that your data or the decision that you make will informed by everyone, not by select people. Give me 1 more minute, I'll finish. And lastly, we must invest in community level data stewardship. What I mean by this is that we must empower our ASHAs, we must empower our SHGs and Panchayat and NGOs as data leaders. These are the people who can support data collection, validation, digital literacy, and feedback loops for system improvement. Finally, as India leads globally on digital public health infrastructure, we have the responsibility to demonstrate that technological ambition and social justice can and must coexist. The true power of AI lies not in predicting the disease, but in recognizing those who have been invisible for too long. So let's not leave behind anyone in the world of digital era. Thank you so much.
Thank you so much. Concluding in time, I think you really highlighted the system gap and the 3 important aspects, whether it is gender disparity, fragmented health journey of migrant population, and lack of data training on marginalized group, and of course the framework you discussed about that. We'll take up the questions at the end, but before that we have another speaker, Dr. Pritha. She is the Dean from IHMR Delhi, and her area of interest is very large in public health and all that. So over to you, Dr. Pritha. I know you are the last one, but I'm sure that people are eagerly waiting for your interaction. Thank you.
Good evening, everyone. Thank you, the organizers, for giving me this opportunity. Last speaker of the day, but I hope the subject I'm speaking is not the least important. We heard, there's a lot of elitist technology words and concepts and approaches and frameworks in technology, but I am going to make an emotional pitch-in. I take anticipatory bail before. I'm not a technologist. I'm a public health professional, at best a teacher, a researcher, a trainer. So keeping in line with the theme of the conference, the theme of the session of leaving no one behind, I would like to pitch for our elderly population, for the senior citizens of the country. In the last less than 10 years, I had the opportunity to take care of my mother, who went into her 80s, saw my aunts and uncles, who parents of friends, who actually struggled to find respect from everyone, from family and society. I saw they struggle to live with dignity, and in the face of a more or less uncaring healthcare delivery system. So I am not going into technology a lot, but I am trying to understand what the future holds for us and try to link it with the technology-related solutions. Next slide, please. Whether we like it or not, next slide, please. Whether we like it or not, they are going to occupy a lot of space, physical, healthcare, emotional, academic, research. They're going to occupy a lot of space in sheer numbers. In 2020, people above 60 years overtook children less than 5 years. And by 2050, in developing countries, we'll see every third or fourth person will be above 60 years. In European countries, maybe every third person will be above 60 years. So we spoke a lot of change management. Our health systems, our systems are generally more suited to take care of maternal and child health conditions, and now increasingly non-communicable diseases also. But we may have to do a lot of change management. There are so many principles of like going for that change, creating a lot of interest and creating coalitions. There are so many principles in it. We really have to make a pitch in for that. So having an elderly population would also mean that we'll have a population with all these problems. Not one, but a syndrome of more than one problem. And chronic diseases, we know it will necessitate long-term care. Social systems have to wake up. Families have to take care, less of clinic care. We have to really rethink our strategies. So we need to strengthen our health systems also accordingly. So I'm just holding a telescope into the future, and I'm just presenting 2-3 scenarios where technological solutions, technology-based solutions can help. So here, a woman who's prone to falls. Now we know falls are the leading causes of accidental deaths and injury in older adults, accounting for a large proportion of hip fractures and other traumatic brain injuries. There are digital-based solutions. What are they? There are sensors, there are deep cameras, there are smartphone applications which analyze data and offer different types of solutions. The solutions can be in the form of risk calculation, risk prediction and prevention, or it can be an emergency response in the case of a fall. So this model, again, it's from literature which uses these 4 Ps. 4 Ps are prediction, personalization, prevention, and participation, and of course data analytics to come up with a fall risk score. This app needs participation of the aged person also. Now this is a wearable device. A wearable device, this wearable device can be worn on the waist or wrist or elsewhere, and this will also continuously measure acceleration. There is an accelerometer which measures movement along 3 axes, X, Y, and Z. So data sets are trained, the training of data sets of both kinds, of falls as well as activities of daily living. So when a person lies down, the sensor will be able to detect that it's not a fall because it's continuously measuring a movement along 3 axes. So when there is a fall, it detects and alerts the caregiver. So this is another solution. Now this is another scenario that we may face. Lots of chronic diseases. We know chronic diseases are for life, and they need continuous treatment. They need frequent checkups, timely checkups, and if they are not done, there can be implications on other systems. So again, there are many technological solutions available even now. This is an AI monitored glucose pumping system. Continuously glucose measurement is done. Accordingly, insulin dose is calculated and delivered. There are digital pill boxes. This is extensively used in TB program, where the patient himself opens the pill box, takes the medicine, the patient will have it. At the same time, an alert goes to the caregiver. There are many risk prediction models. For example, in chronic diseases, a person with diabetes mellitus or patients with diabetes mellitus, how prone are they? What is their risk of getting CRF, chronic renal failure. So there are many risk prediction models which are available. Again, another scenario where our elderly will face social isolation. Now, WHO has already, has come up with many articles speaking about loneliness which is prevalent even in the adolescent and younger population. And of course, our elder population, they are more prone to it. For that, also, there are many solutions which are available. There are many community apps which will link them with the community members. We'll have quizzes, we'll have, they can plan out events. They can keep socializing with the community, like-minded people. There are many apps which are available. There are companion robots. There are companion robots who sort of live with them, will live with the individuals. They give alerts about medications. They alert the elder persons about time for exercises. They also keep giving alerts to the caregivers. Of course, machine learning based, already we heard many times during today's discussions also, ML based risk predictions. So that also is available for this scenario. There are many challenges which we kept discussing throughout the day. Challenges are not different. Here also, digital divide is there. Digital literacy is also, of course, very important. Training on wrong, non-representative population that keeps happening. There are many wearable devices. There are many appliances, and we are not sure about the sensitivity and specificity. Many false positives and false negatives may be there. And of course, interoperability, use of data, privacy, that is a problem. All these are there. Today, I was very happy to hear Dr. Simon saying of the previous panel, he said something to this effect, that use of data, use of technology is more about compassion, is approaching the health problems in a compassionate manner. All of my fellow panelists spoke about equity and importance of leaving no one behind. My chair, in his opening remarks, said that the country you are born will determine maternal mortality and child mortality. The country you are born will also determine how well you age. How well we take care of our elders is very important. We have a very rich tradition of taking care of our elders. So let us use technology also in an appropriate manner to further the health of the elderly. Thank you.
Thank you so much. I think I'm not sure that whether it was by design or by chance that the first technical session started with the life cycle approach, where we said that predicting the disease from the mother's womb. And then the end of it, the presentation started with the elderly person, the end of the life cycle part. And so really you touched upon, I was part of the 3 longitudinal studies of WHO multi-country where we did SAGE study, and we found out, and WHO could gather the information, of course, by 2030, 30% of populations will be elderly. So it is not the western part, Japan, China, Europe, USA. It is also India which is going to face this problem. And we right from beginning, now this is the right time, because it is not only creating the infrastructure, the training, the manpower, but also the training the nursing staff that how to take care of that. And so it is very imperative. You touched upon the topic. Most of the things you suggested is basically already being used in hospitals, and as of course in the market are there. The only thing is WTO, in one of the event I was in Geneva, they said that this will be by 2030, everything, all of this will be a household commodity. So the time is not far that all the technology, robots and all that will be, it is already there in European countries and all, but it is going to be a household commodity. And rest all is already in the most of the private hospital, like risk assessment. The patient walks into the emergency and the hospital knows that which patient is more prone to fall. And during the time when patient moves from one area to another area, there is a sensors are there, IoTs are there, they keep on tracking on that. So, and the challenge is again, how to bring that to the every household, how to bring it to every, even in public health, because in private hospitals there, but some of the technologies can build, and telemedicine and AI is definitely going to help us. So I'm not sure we will be allowed to take the question answer. Maybe you can all interact off the session, and then even tomorrow you will be here. There will be there. So definitely I'd like to close. So as we close, let's reaffirm one guiding principle, that healthcare innovation has no meaning if it leaves people behind. So, and when you talk about people, we definitely talk about everybody, all criteria, whether it is about gender, whether it is about the race, the location, or the age and all that. From all points, who are the people, for everybody's, their health needs has to be met, and how to include the technology so that not only providing care, but even predicting, providing, and then of course analyzing, monitoring, and evaluation, so that every beneficiary is reached and all. So let us build an ecosystem where access is universal, trust is central, and outcomes are equitable. So with this, I end this, close my thing, and thank you so much. I think audience must be given a big applause, because for being so nice and patient here. Audience, thank you so much.
We extend our sincere thanks to the chair and panelists for this insightful, future-oriented discussion. The panel reinforced how data and AI can strengthen public health systems and widen access for underserved and vulnerable communities. I now invite Dr. Santosh Kumar Pandey sir to felicitate Dr. Preeta ma'am. We also extend our sincere thanks to Professor M. Shivakami and Dr. Arunava Dhar for joining us virtually and making this session enriching. I now invite Dr. Sanchita Mahapatra ma'am to felicitate Dr. Santosh Kumar Pandey sir. We extend our heartfelt gratitude to all our speakers, panelists, and chairs, both in person and virtual, for their meaningful contribution throughout the day.
To formally close the Day 1 proceedings, we are honored to invite Dr. Sanchita Mahapatra, physician epidemiologist with extensive experience in public health research, disease surveillance, and large-scale data program implementation. Recognized for leading Bihar IDSP strengthening initiatives and advancing data-driven decision-making in collaboration with government and global partners. To deliver the concluding remarks, ma'am, we kindly request you to address the audience.
Thank you, Danish. On behalf of ADRI, it's my privilege to offer this vote of thanks. And I want to thank those coming from districts. Abhi tak aap log baithe hain, and I think you are getting late, so I'll not extend this session for long. So we have learned a lot from today's session. So what I learned myself are 3-4 points. So we need a balance between the technology and human mind. We have to have an integration. We have to have a system in place for proper implementation. We have to have a community acceptance. And lastly, no one living behind. I would also take this privilege to thank all of you who have come from all across the country to help me to make this program a huge success. Thank you all. And we also have professors who are joining online and enriching us with their insights. I can't be more thankful. And thank you all for joining us in person and also joining in line. Thank you. Thank you.